USB-C.
Oh, really?
Yeah. Roger's laptop is only USB-C. No worries. What do you do? We'll put it into my com first, and later I'll load it on here. Because you're not your starting com. Next slides are here.
Okay, come.
Okay, good. Okay. Oh, sorry. Yeah.
It's silly to do a study. How do you say it?
Okay. Yeah. Net, okay, right? Okay. He checked, right?
Check.
He checked, right?
Check. Here, 2 video.
Okay, okay. Then it's just because I don't want people to keep seeing. Okay. Thanks.
Okay, yeah.
So we just set up there.
Do you want a coffee or water?
I'll go get one. That's okay. Thank you.
Good morning. Thank you all again for coming today. So we'll get started. We are slightly delayed, but that's all right. That's part and parcel of a Saturday morning workshop. So what I'll do is I'll just give a recap of what we did yesterday, and then we can take it from there. So thank you again for coming. We had about 100 participants yesterday who were coming in and out, and we had about 200 online. So I reckon that will obviously grow today as well. So thank you for making the time to come today. So what we did yesterday was we kind of opened up with this concept of what we see, or what we do with what we see. So I'm hoping that we can carry on this concept throughout the day as we concentrate on the bottom end of things, the colon. Ban Hong, can you just switch off the lights? So the summary was that while evaluating the esophagus, we should try to identify landmarks. Maybe go in with white light and perhaps come out with narrowband. You may want to use Lugol's if you're unsure and there's a suspicion of squamous cell cancer. We'll try to recognize and characterize pathology, as in all things in the entire GI tract, perhaps using some of the tools which we have. Professor Raghunath spoke to us about Barrett's esophagus and how do we do a quality endoscopic examination, as well as looking at EMR versus ESD for endoscopic resection techniques. He touched on RFA as well as APC and cryoablation, and obviously discussed surgical management for select patients. We then had Professor Bapaye, who spoke on SELs of the esophagus, explaining to us about how we characterize them, perhaps leaving SELs which are less than 1 centimeter in size alone, and evaluating tissue which is more than 1 centimeter. Tissue diagnosis is important, and tissue yield apparently is poor for lesions which are 2 centimeters or less in size. So various techniques were discussed, including EMR and ESD. And for some of you who may not know what STIR means, it's submucosal tunneling to try to get a lesion which is inferior, which is deeper to the mucosal area, and surgery for lesions which are not suitable for endoscopic resection. Dr. Bapaye did say that surveillance remains a valid option, and patient preference is an important consideration. I touched on gastric lesions, basically summarizing that there are quite a few different pathologies within the stomach itself, and I think it's important for us to try to characterize these lesions if they're found. If you're not sure, obviously biopsy. The most common polyp in the stomach is FGPs, and lesions which are more than 1 centimeter, it's probably best to remove them. And then Professor Yip, Honchi Yip, looked at the gastric sort of submucosal lesions, and this is a consensus statement which he informs me will be published fairly soon, looking at how we evaluate submucosal lesions in the stomach. So do wait for the publication which is coming out soon. We then looked at one of the MDTs. I'll just show you a lesion which is in the Barrett's, and we had quite a robust discussion, basically summarizing that with imaging techniques, if we are careful and cautious, we would be able to find certain areas which will then change the approach or the management. In this instance, this was sent as a 1 centimeter nodule, which on further imaging 2 days ago revealed that there's evidence of cancer within the lesion, which subsequently changed our management because we did not want to remove this in pieces and took it off in a single piece using an ESD technique. So mucosal imaging here helped with decision making in real time, and it turned out to be a mucosal cancer with possibly some suspicion of perivascular invasion, but we will be discussing this patient at the MDT next week. So learning point is careful assessment of lesions and biopsies. Then Professor Brown spoke to us very nicely on a deep dive into the small bowel. How do we evaluate patients with small bowel pathology? I like this slide because it clarifies and summarizes what we should be doing in our minds when we are faced with a patient who has got suspicion of small bowel bleeding. Obviously, he spoke on spiral endoscopy, and we hope someday he'll come back to us. And then we had the final talk, which is on adverse events. And aborting a procedure is not equivalent to failure. That's what Professor Bapaye told us. It is judgment. So these are some of the warning signs you should look at when you are or when we are doing a procedure, be it the endoscopist or the nurse or assistants within the room. Key takeaways include trying to be like Spider-Man, but with great power comes great responsibility. You have to be very careful, selective, and have safety culture, systems, checklists, and audits are the cornerstones of prevention. This is what Amol has given us as his tips. A lower threshold to stop a procedure, earlier airway protection, greater caution when patients are frail, listening to the entire team, and auditing one's own practice and the team's adverse events. I think these are all very important things to reflect and introspect. So with that, I'll ask Dr. Liz Murphy, the Divisional Director of Surgery, to open the session for today. Just to let you know, towards the end, we'll have a hands-on model from 3:30 to 5:30 p.m. It's fully subscribed. There are 8 stations, but if you are wanting to have a look, please feel free. There are no patients in the unit today. We've cleared it all off for this hands-on session, which will take place for over a couple of hours. So thank you again, and Liz, if you can say a few words. Thanks.
Thanks, Raj, and thanks for the opportunity to be involved. It's really exciting to see everyone here today. We had a great program yesterday, and we're looking forward to a wonderful session on the lower GI tract today, especially being a colorectal surgeon myself. I would like to acknowledge that we are meeting on Kaurna lands and that we like to pay our respects to elders past, present and emerging. It's been a wonderful journey with Raj and his gastroenterology unit over the last 15 years, and it's been great to be there to see it grow into such a wonderful unit today with 12 excellent gastroenterologists, and I think the future looks really bright. So it's really great that we can bring everyone here today to share sort of lots of really important learnings and sort of hopefully find out some new things as well. I'd also like to thank Heath, who's providing excellent nursing leadership in our gastroenterology unit as well. So I think without any further ado, I think we should probably crack on with the program, which looks excellent, and I look forward to hearing what we've got to say today. Thanks.
Yeah. Thanks, Liz. So we can invite the chairs for the first session, which will be Dr. Murphy, Dr. Sathananthan, and Dr. Rychak. If you can come to the front of the room. And then we'll get one of you to introduce the state-of-the-art lecture. Thank you.
Our first speaker today is Cameron Bell.
No.
Sorry? Oh, okay. Sorry.
Thanks, man.
Associate Professor Hong Chi here is currently Clinical Assistant Professor at the Department of Surgery, Faculty of Medicine in the Chinese University of Hong Kong. He's also serving as Deputy Director of the Combined Endoscopy Centre and Honorary Associate. Honorary Associate Consultant at the Prince of Wales Hospital. Focusing on upper gastrointestinal tract cancer management, Dr. Yip underwent overseas training in Osaka and Tokyo, Japan in 2017. His current research focuses on endoscopic diagnosis and treatment of early gastrointestinal cancer, as well as minimally invasive and robotic techniques in surgical treatment of gastric and esophageal neoplasia.
So, thank you, Chairman. So today, moving on, so we will be talking about third space endoscopy. So once again, I would like to thank Raj for the kind invitation to this wonderful symposium. So let's take our journey to the third space. I guess perhaps all of you know how ESD, endoscopic submucosal dissection, has made a big revolution in the realm of endoscopic treatment, starting from treatment of early gastric cancer, expanding to early esophageal, colonic, and maybe even duodenal cancers, and basically providing a good en-bloc resection treatment option for patients suffering from early GI cancers. And then almost at a similar time, a couple of years later, with the adventure into nodes, in fact, this was one of the important landmark publications from Sumiyama that looks into the possibility of making a tunnel within the submucosa. So what he did was he injected solution and entered the submucosal space and then take a biopsy of the muscle layer. And that was the initial beginning of the so-called submucosal tunneling procedure, which came into real practice or real clinical use when POEM was first published clinically by Professor Haruhiro Inoue from Japan, where he actually did a myotomy of the esophagus as well as the stomach through a submucosal tunnel created more proximally in the esophagus and followed by closure. And so this was probably, as far as I know, the most cited paper from endoscopy throughout the years. And in fact, that has actually expanded the entire realm of submucosal endoscopy, where there are so many procedures being reported and spin off from the initial idea of submucosal tunneling, and the list will just get longer and longer. So I'll just mention a little bit about each of them, but because of this, in fact, this term of third space endoscopy was coined afterwards, starting from first space, which is our intraluminal space. The second space is within the peritoneal cavity, where surgeons are working in, and the third space is somewhere in between within the submucosal area. And so where are we now and where are we heading? So to start, I think we must mention about POEM, which is the original third space procedure. And I think much more than 10,000 procedures have been reported in the literature. And now we have very standardized techniques which could help us to create a good, steady outcomes of POEM procedures, which include identifying important landmarks such as the two penetrating vessels in the cardia, which helps to identify where you should end your myotomy, and also identify the area of the sling or the clasp fiber and the circular muscle fibers, so that you can hopefully avoid post-POEM reflux. The use of double scope techniques to help to identify the appropriate end of tunnel. Anterior versus posterior myotomy unfortunately didn't show any major difference. And there's also a trend towards using shorter and shorter myotomy, especially for patients who are not suffering from type 3 achalasia, because it has been found there's no difference in clinical outcomes, but yet you can complete your procedure with a much shorter procedure time. So this is just a quick video showing how such a procedure can be done, even in some tricky situations. So in this particular patient, she actually had prior helamartomy as well as an esophageal staple diverticulectomy done some years ago, but now presenting with recurrent symptom with a tight LES causing dysphagia. So we were referred to consider a new treatment option. And you can see that the esophagus was actually quite dilated and quite tortuous. And but nonetheless, we can still enter the tunnel if you identify the right area. So in this particular case, we had to do posterior because the anterior has been operated on before. And this is actually a bipolar knife, but you can still get into the tunnel quite easily with different types of devices. And then all you need to do is to try and navigate within the tunnel until you can enter the area of the LES. So for this particular interesting case, in fact, what I saw throughout the procedure is actually you will encounter staples because this patient underwent a stapled esophageal diverticulectomy before, but that actually helped me to guide through because the staples are on the muscle side, so I can still navigate through the staples and get deep into the entire tunnel. So this is the completion of the tunneling procedure where you can actually see entering into the LES, and this is the tight LES part. And more proximally, you see the staple from the previous surgery, and then you can perform a myotomy afterwards. And finally, completing the procedure by using clips to close the entry. And that is the whole procedure. So, in fact, I think there's no doubt that the use of POEM has completely changed the landscape of our treatment for achalasia patients. Even as a surgeon nowadays, I hardly see any patients who are willing to undergo the conventional surgical myotomy, even though I would explain everything to them. So comparing with pneumatic dilatation in this particular randomized controlled trial published quite some years ago, in fact, the primary outcome of a proportion of patients with treatment success was much higher with POEM than with pneumatic dilatation, even though there's a trend towards a higher reflux post-procedure after the POEM procedure. However, this actually showed the preference towards the use of POEM for patients with primary achalasia. And this is the other landmark paper from New England Journal of Medicine comparing endoscopic now with surgical myotomy, again showing that basically there's no difference in terms of the clinical outcome, primary clinical outcome at 2 years. There seems to be a higher trend of adverse events, serious adverse events with Lapella myotomy, although, again, there is a tendency of higher reflux rate with POEM procedure when you compare with the surgical myotomy. But if you look into the 5 years outcome, then things pretty much a little bit similar in terms of the symptom success. So you can see both procedures had an equally high sustained clinical success at 5 years' time. But on the other hand, it seems that now the degree of patients with esophagitis has gotten more and more similar between POEM and Heller's group. So there are a lot of postulations behind this, but one of the postulations could be that the fundoplication's effect starts to wear off with time because of the loosening of the wrap, while on the other hand, the POEM procedure, because you didn't really disrupt the other anti-reflux mechanism, anatomical anti-reflux mechanism, so the rate of reflux stays pretty much the same over time. There's a new tool, the EndoFlip, which is a very hot topic within the esophageal motility guys, which essentially is looking at the sensibility or the impedance within the esophagus. And this tool has been used within the POEM procedure to guide the possibility of the extent of the myotomy, whether or not you need to cut more or whether or not you should stop because of risk of reflux. Unfortunately, there's actually quite conflicting evidence from the literature. Some studies showing a possible benefit, some actually didn't. So for example, this paper actually did not demonstrate any difference without or with the use of EndoFlip, or whether or not you actually think the EndoFlip was showing an adequate or inadequate myotomy. There's no difference in terms of any of the outcomes, be it symptomatic or the measured outcomes of IRP or even the post-flip data. So there are a lot of questions unanswered for the flips because of the various definitions across different studies, various versions of flips, and different metrics. And there's also the second consideration is of whether or not we are just extending our gastric myotomy because cutting more means more postoperative reflux, or whether we should be changing the strategy to doing some other types of myotomies, which is still up to debate, like double myotomy or even resecting some of the muscles, etc. So this is another more newer development spinning off from POEM procedure, knowing about the reflux rate. In fact, Amo here is one of the experts who pioneered, originally described by Professor Inoue, where he actually tried to mimic a fundoplication procedure after the surgical myotomy. But instead now, through the endoscope, they actually did a complete peritoneoscopy and get into the peritoneum and then find the fundus through that peritoneoscopy and suture or actually tack the sites of the fundus onto the myotomy site to mimic a so-called anterior fundoplication. And in fact, this first publication from Amo's group back in 2021 showed a much lower overall GERD rate when you compare with historical data where the POEM is associated with 20 or 30% rate of objective reflux. And in fact, just this year, this is one of the latest outcomes from Amo's group, which actually showed that the difference between POEM-F and POEM was sustained at 3 years between the two groups in terms of reducing the risk of GERD. So, in fact, we are working into a randomized trial together, and this is one of our own local data showing that it actually did show a objective difference numerically comparing reflux between POEM and POEM-F. And interestingly, if you apply the flip through the procedure, you will see some changes in terms of the flip parameters before myotomy, after myotomy, and after a fundoplication. So next coming up, I think actually Raj and Amo mentioned about this. So from the tunnel, apart from cutting muscle, you can actually resect tumors. So this has been applied most commonly for esophageal subepithelial tumors because you can easily create a straight tunnel through the esophagus. And of course, spinning off from that, you can also perform a full thickness resection, which I mentioned in my talk yesterday. Just a very short video, which I probably will skip through it. So you can create a mucosal incision and enter the tunnel like the previous video. But this time round, this lesion, in fact, is located right at the lower esophageal sphincter. But once you dissect through the space, you will be able to see the muscle fibers and a small, around 2 centimeters tumor hidden within the muscle fiber. So this was a symptomatic leiomyomas, and with some more dissection, you can see the glistening capsule of this tumor, and then all you need to do is to dissect around it, cutting the muscle attachment, and pretty much using different devices. And in fact, you can see on top here anteriorly, it's the diaphragm or the pericardium, because now you see outside of the adventitia of the esophagus. And with use of IT knife, that actually helps to provide a safe dissection because you won't be cutting from the outside. And once you detach completely the muscle layer and the adventitial attachment, then you can retrieve the tumor with the use of a snare outside of the mucosal tunnel entrance. And you can see this is what you can result afterwards. And then finally, the step is similar to a POEM. You just close the incision. So if you look into data, there has been numerous reports of this third procedure. And this is one of the latest meta-analysis and systematic review of more than 2,900 patients who underwent this procedure. So you can see overall, ulcer resection is high, en bloc resection is reasonable, with a very low adverse event rate. Although you can see that particularly for lesions that arise from the stomach or lesions that arise from the muscularis propria, the en-bloc resection and outer resection rate tends to reduce a little bit, mainly due to the difficulty to maintain within the tunnel. So these are the limitations. I will not go into detail because of time. And similarly for EFTR, this time round, the reports actually consisted of majority of GIST, but in fact showing a very high complete resection rate and a low adverse event rate. So this might be the better procedure, as I mentioned yesterday, for a GIST in terms of the en-bloc resection. So there are other kits. So this is the Suture Art, which recently came into the market from Olympus, which helps you to suture close defects like a surgeon. So if you're from a surgical trained, you will feel like this is quite native because you're actually having a needle holder within your endoscope. But mind you that this is actually also very technically challenging to use, and it requires some training. So, of course, nowadays, apart from subepithelial lesions, we can also do epithelial lesions resection, especially in the rectum, because of the lower risk of perforation and the lower risk of disseminated sepsis. So this EID has been reported first in Japan. They call it the myomectomy. And this helps to resect some of the tumors that has a dense adhesion to the muscle layer by doing a selective muscle resection, preserving the longitudinal muscle, but only cutting the circular muscles. So in fact, this is the Netherlands group paper published very, very recently, showing a reasonable outcomes with this particular technique. So time is quite limited, but I would just say that the POEM procedure can be applied even for other situations, like the Sancus diverticulum. So now you can actually easily cut the muscle bar by creating a submucosal tunnel. And actually, there are numerous studies on this, most of them showing a good technical and clinical success rate. Similarly, even for esophageal diverticulum, you can actually cut the muscle bridge and create a widened lumen so that the foot would not be stuck inside the diverticulum and create a symptom relief. G-POEM, the gastric myotomy, is proposed for the use for gastroparesis patients with a similar idea with the conventional POEM. The only problem is the difficulty in selecting the right patients, because you can see the clinical success rate compared with POEM for achalasia is much lower. And so we have to choose the right case, usually by doing an adequate emptying studies, by looking at the symptom scores, etc. So there has been a randomized trial showing that G-POEM, in fact, creates a much better outcome compared to the conventional group. CP-POEM is another one that we can do for patients who have neurological disease, where they have a spastic cricopharyngeus that impairs their swallowing function. And in our university, we performed this pilot trial showing that it actually helps to reduce the patient's symptom related to swallowing among patients with Parkinsonism. There has been some other studies that, novel studies that used this similar techniques even for bariatric patients. So this is a gastric myotomy, but not the pylorus, aiming to reduce the gastric emptying and weakening of the pump, so that it could help with patients with obesity. This is quite early in terms of the studies, so we're still waiting for longer-term results. There has been some modest weight loss achieved with this beam procedure. There are some other developments that I would like to mention, including the use of AI. So you know that in the diagnostic area, the AI has been pretty much very, very popular. In the therapeutic area, I think this also will come soon. So this is one of the work, different works done by different authors. Some is in collaboration with the German group, and some is initially from the German group. So in fact, what you can expect to see is in the future, when you're lost, maybe the AI can help you to guide your way through difficult procedures, or giving you some guidance on where you should cut. And of course, Countertraction is still something quite difficult in ESD procedure. So this is one of the studies that we are doing with a novel device we developed with our own engineer by combining an external and internal magnets. It's not a particularly new idea. So many years ago, it was already proposed in Japan. But what we did in this particular scenario is we made a small magnet which can pass through the channel of the endoscope, and then pairing it with an external permanent magnet. So this is an ex vivo study, but you can see that once I apply the magnet, so the retraction became quite natural. So the good thing is you can alter the traction angle throughout, because once you dissect, a lot of the problem is the traction became looser and looser, and then you lost the traction, and then you need to reapply. But with this, as long as you change the traction from the external magnet, then you can actually alter the angles as shown here. So it will help in terms of the procedure, and we did show on an ex vivo setting. This will help in both novice and experts in terms of dissection time, and also the stress and also complications. So we're moving on to clinical trial. In fact, this particular magnet was applied in this gastric ESDs, and you can see that when we apply the magnet, the space is being exposed like this, and you can alter the dissection area based on the need. For example, here I need to control the traction and expose the underlying vessels, which is located here. So I'm not saying that it will replace the cap or replace anything, but it will definitely be an important, useful adjunct. So of course, robots is coming. So this is one of the pioneered by my boss, Professor Philip Chu, which we are working on in endoscopic robots. So you can see coming out of two channels of the overtube, you can have a manipulable robot that can actually provide another option of countertraction. I think this will be coming quite soon, because there are actually a few companies and a few investigators all working on a similar direction on endoscopic robots. And this is a video showing an in vivo animal trial, how this could potentially help. So you can see Professor Chu here with myself, and in fact, in the background, Professor Inoue and also Amrita, we're all here just seeing how we did this case. So you have two arms, so you can provide a more intuitive traction, counter-traction, as opposed to the conventional way. So I would like to conclude that actually the submucosal space, the third space, has enabled us to venture into newer procedures, utilizing the space for various conditions. For instance, the Polyp procedure has become one of the most efficacious treatment for achalasias, and we have newer and newer techniques that will help us to reduce GERD. And all this procedure has spinned off into other procedures for resecting tumors, for cutting other muscles, etc. And in fact, these concepts have been brought back to ESDs because the tunneling procedure or the pocket creation were essentially a spin-off from the so-called third space endoscopy. So with that, I would like to conclude. Thank you very much.
Thank you very much. That was a masterful talk and lots of exciting developments there.
Thank you.
Especially that robotic endoscope. I think that was very exciting. Do we have any questions?
There's one question on Slido. So that's with regards to POEM. And you did mention that there's sometimes this issue with doing a gastric myotomy. So the question was, how do you utilize the double scope technique, which basically obviously needs two monitors? So can you explain a bit more on that?
Actually, the the double scope technique was proposed also by the Prof. Inoue group. So what you do is during the endoscopy, you insert the second ultra-thin endoscope or the nasal scope through the nose and enter into the stomach and retroflex in the stomach. And your primary scope will be inside the end of the tunnel. And then you can actually gauge how far you are from the LES, and also where the location it is. So if you can see your scope way beyond the LES, hopefully less than 2 centimeters, at least for your myotomy, it should be less than 2 centimeters. And that will guide you to have a slightly more confidence that you're within more than 2 centimeters beyond the LES and you're not creating an inadequate myotomy. The other thing you can use as a double scope technique proposed actually by Amo is that it helps you to find the anterior space, because if you're doing a POEM F, then it's very important that you're going anterior. Otherwise, you may go to the wrong place in the peritoneum and get into the lesser sac or somewhere else and not able to find the fundus of the stomach.
Do we have time for any more questions, Raj?
So there are no questions online, but if there's any questions from the audience or the chairs, if not, we can.
Yeah, I think
close
Raj has a question.
Yeah, I have a question. Thank you for your talk.
Thank you.
Based on the evidence and data you provided, do you think there's a role for surgery in managing achalasia now, or should we all be sending people for poems?
Well, actually, I think if you read carefully, I think the argument is still, I would say, ongoing. I think at the end of the day, both treatment provide same treatment efficacy in terms of relieving patients' achalasia symptoms. There's a trend towards less complications with POEM procedure, and it's probably more eye-catching or attractive to our patients because it's so-called non-invasive or no-scar procedures. But the reflux still remains a consideration because we know that numerically at least there's a higher risk of reflux after POEM, which we have to explain to the patients, although majority of them are pretty asymptomatic, to be honest. So they are all still both viable treatment options. It's just that if you ask a patient to choose, most of them would choose POEM.
Okay, I think we might move on to the next one.
Yeah,
Just like
thank you.
To thank Professor. Thank you very much.
Can we invite the next group of chairs, who will be Arvind, Gary, and Devinder Raju?
Morning, everyone. Looking forward to moving on to the next session about colonoscopy. I know that a lot of registrars are very excited to hear about tips to improve their technique, and hopefully a lot of consultants that can do it the same. So we'll start with our first speaker today, Dr. Cameron Bell, who's a staff specialist gastroenterologist at Royal North Shore Hospital in Sydney. He has a doctorate in medicine from Sydney University and is a fellow of the RACP. He's got an interest in bowel cancer, endoscopic training and quality. He has significant experience in endoscopic teaching. He's the chair of the Gastroenterological Society of Australia's National Endoscopic Training Initiative and has been the lead in the NETI Train the Trainer program since 2009. He's developed colonoscopy quality improvement projects for GISA, participated in many colonoscopy quality workshops, both as a convener and a faculty, and convened ARCP training workshops. Probably in a room of luminaries, he's one of the more luminous we have. He still remains a long-standing member of the clinical advisory group for the Australian National Bowel Cancer Screening Program and has worked on a lot of the clinical practice guidelines for the management and detection of colorectal cancer. So welcome, Dr. Bell, to speak to us today on colon insertion tips, how to get to the cecum internal ileum seamlessly and safely.
I'll just make an announcement before that. So if anyone wants to look at the QR code for Q&A, please do so. So your questions can come to Gerald and we can put it forward to the speakers or the chairs. So I'll just go back to Cameron and won't take the stage from him. Thanks.
Thanks, Raj, and thank you very much for inviting me to speak. I feel this is going from the sublime Professor Yip to the ridiculously simple. But if I could just find out how many registrars and trainees and junior consultants are in the audience? Show of hands. And surgeons and physicians? Okay, great, thank you. I've got the easy bit. Gregor's got the hard bit, and so I'm grateful to you, Raj. Why focus on insertion, though? Well, the answer's obvious. You want comfortable patients, particularly if you don't have propofol. You want a complete to TI or CECM all the time. You want a minuscule complication rate, and you want to let more patients benefit from your expertise by getting through them, at least the insertion phase, quicker. I'm going to, this is not going to be a standard insertion talk. I'm kind of distilling a whole lot of things that I've learnt from my colleagues. So I'm going to make some generic comments about colonoscopy and then 2 or 3 site-specific suggestions. I can't talk about this without touching on conscious competence. I haven't got time to discuss that. If you don't know what it is, please talk to me afterwards. But to be able to continue to improve, you need to build your own conscious competence, and you need to do that, you need to actively reflect. And most people have heard that bit, but to actively reflect on what's working in your scopes and what's not working, and if you're a trainer, what's working for your trainee and what's not working, you need to have a simple language, and this has been one of the impediments to improving conscious competence. So there are only a couple of things you can do with a scope. You can point the tip in 4 directions, you can insert or withdraw, you can talk clockwise or anti-clockwise, you can insufflate with either CO2 or water, and you can deflate. And deflating and then slowing down are 2 incredibly important and useful techniques for insertion. As an extension of that, think of the lumen that you're looking at and thinking about and talking about with your trainee as a clock face. And the thing that hasn't been put into good words is how the scope feels in your hand. I like tense and relaxed. Anybody who's scoped knows what I mean. The first bit, particularly for the physician trainee registrars, understand the anatomy. The ascending colon and the descending colon are retroperitoneal, so they're fixed. And it's the bloody bits in the middle that are the problem, the sigmoid and the transverse colon. So that determines what's fixed and what's mobile. The other thing you need to appreciate is physics and gravity and what those things do in the standard left lateral position, or if you move a patient another position, how gas and water behave in the colon. I guess you also have to factor in the things that interfere with seamless colonoscopy, and they're things like severe diverticular disease with fixity and narrowing, adhesions, and also the dreaded redundant left colon. If you're starting out, I'd encourage you to find somebody who can teach you water-assisted insertion, or at the very least minimise CO2 during insertion and deflate any dilated segments that you come to. A few pictures speak a million words. I'm grateful to my counterpart in Canada for this. So this is one of those Kagaku models that some of you have seen. In a left lateral position. So this is what it looks like when you start. If you shove your scope in there and inflate like hell, this is what it turns into, also known as a nightmare. If you've done that and you deflate, it becomes a little more friendly. But then if you weigh it down with water, this is what it looks like. It's almost a straight shot. So if you don't take home anything else from this talk, remember those slides. A couple of other tips. If you've got small hands, give your right thumb a chance to get to the 9 o'clock position on the big wheel and hold your... there's a difference between the 2 photos in terms of where the umbilicus is in relation to my forearm, so think about that. And give your brain a chance to sense what the scope is trying to tell you in terms of that tense and relaxed thing that I was talking about before. You can't sense that if your knuckles are gripping with a tight grip. And if you water insert and you've got a light grip, a pencil grip, so to speak, the scope will often swivel or torque by itself within the lumen and do some of the work for you. Be conscious of the scope shaft on the bed outside of the patient, because how it is and how it looks influences what's going on inside. I'd strongly encourage you to think about unnecessary bends. We all know that when the scope's in the right colon and you need good tip control to take off an SSL, that having the wires as straight as possible is necessary. And we all think of that in terms of loops inside the patient and reducing them before we attempt any therapy. But the loops on the outside of the scope have the same thing. And I noticed this, it's not a very great picture, but there are two things wrong with this picture in terms of the scope not being straight. The two pillows are supposed to be buttocks. So the first thing is that I'm trying to insert at 90 degrees to the angle of the rectum, which parallels the sacrum. And the second thing is I've got my hand on the bed and the anus is a buttock higher than me. A buttock's a sort of an ancient unit of measurement, like a cubit. So at the very least, if things aren't going well, just fix that bit. Understand obstacles to applying torque to the scope. So again, this pertains to the shaft of the scope outside of the patient and where your hands and bed edge are in relation to this. So I'm just going to give you three simple examples. You can't apply torque to the scope if it's over the side of the bed. If I try to apply torque to this scope, I'm just going to hit myself in the knees or worse. If you can't clockwise torque here because the scope shaft is over itself and resisting, and you can't clockwise torque here because the shaft hits the inside of your forearm. So just be mindful of those things. So a couple of specific suggestions. I think it is a real, an achievable goal to minimise sigmoid alpha loop development. I'm not going to talk about loop reduction today. If the trainees want to come and talk to me afterwards, I'll show you something with a scope. But you want to get to the splenic flexure by applying net clockwise torque. If you're a trainee, go and grab a scope and try to put in an alpha loop. And to do it, you're going to have to apply lots and lots and lots of repeated anti-clockwise torque, which is why you get rid of an alpha loop by applying clockwise torque and withdrawing. To me, this is a no-brainer. Of course, you've got to scope the lumen ahead. If the lumen's at 10, you've got to anti-clockwise to get to it. But after you've done that, reduce the torque on the scope and continue applying clockwise. To me, this is my starting position for a colonoscopy, and I can sort of explain it or defend it if you want. The next thing, and my least favourite part of the colon, is the splenic flexure. There are a couple of tips for the splenic flexure. Particularly, the first is particularly if you've not managed to be perfectly straight in a say a constipated colon which is long and redundant, and you're not perfectly dead straight. So the first tip I would give you in that situation is you may need lots of tiny tip deflections so that you can follow the series of corners ahead of you without very much insertion indeed at all. You're just changing the tip direction so it can follow the lumen. And the other thing is, if you've done a great job in the sigmoid and you're dead straight at the splenic flexure, there is a manoeuvre that I would use at least once every list, and that is stop, admire the triangular transverse folds ahead, lube the scope just outside the anus, apply the stiffener briefly, and then deangulate, sacrifice that perfect view that we're all taught to desire, and insert, as Elmer Fudd would say, very, very slowly. And that's minimising friction between the shaft in the sigmoid and the wall of the sigmoid. It works incredibly well. The main problem in the transverse is sag, and although Gregor, I know, is not a fan of abdominal compression, to people who aren't geniuses like Gregor, getting the assistant to put some suprapubic pressure on and minimise that sag is often very effective. I also have thoughts about sigmoid pressure, but I won't bother you with those. And then finally, at the hepatic flexure ascending colon area, the two prime words are suck and slow. So deflating the colon doesn't just deflate the radius, it deflates the length. And something that hasn't worked, an insertion manoeuvre that hasn't worked, may very well work 5 seconds later if you deflate the lumen and again insert slowly. So build your conscious competence, understand anatomy and gravity. If you're a trainee, find someone who can teach you water-assisted insertion. Be mindful of the basics and the basic errors that can creep into scope handling. Manage the shaft on the bed and match your solutions to where you are, where the tip of your scope is in the colon. Thank you for paying attention.
Thanks for that, Dr. Bell. So I think there is one question and we're to quickly ask, but we'll try and, I guess, reserve the rest till the end if we can. But I think there's one question that Charles has.
Yep. So from one of the endoscopists, unfortunately had a perforation recently for a positive FIT patient with very bad tortuous diverticular disease. Any tips about when to give up?
I thought one of the most masterful talks yesterday was the last one about hubris and using your experience to decide when to stop. So tips for the sigmoid, you should always read the previous reports. If you're struggling, don't struggle with your adult scope and think, if I can only get around that next corner that I can see. Just save everybody some time, swap to a paediatric scope, and if you have the same problem yet again, just get a gastroscope out. And accept that it's usually possible to get to cecum with a gastroscope, but if you can't, then you can always do a CT colon just to make sure there's no substantial pathology in the colon beyond where you can get to. But nice gentle hands. And just on water assist, most talks about colon insertion include the phrase, don't push against fixed resistance. You will be astonished if you are not a water user at how much that, often somewhere in the rectosigmoid there's a bit where you think, I don't know how I'm going to get around this corner. If you stop, withdraw a centimetre and fill it with water, the corner will often disappear. So I don't have any other tips.
Thank you. On the similar vein, how about patient repositioning during insertion?
I beg your pardon, sorry?
Turning the patient.
Turning the patient? Yeah, well, they do this in the UK all the time, routinely. They often turn the patient 3 or 4 or 5 times to get maximum, and that's mainly for viewing on the way out. And their patients are much thinner than we are because they get so much exercise during a colonoscopy. And I do. It's harder when they're propofol. And if you live on the North Shore of Sydney, their BMIs are all 35 or 40, so nobody likes it. But sometimes you just have to accept the fact that that's the solution to the problem.
Okay, thank you.
Okay, thank you.
Introduce next.
Thank you, Cameron. I have the honour of introducing Professor Gregor Brown. Gregor is a physician gastroenterologist and head of endoscopy at the Alfred Hospital, Melbourne. He was previously chair of the Conjoint Committee for the Certification of Training in GI Endoscopy and now sits on the recertification in Colonoscopy Conjoint Committee as well as the Clinical Advisory Group to the National Bowel Cancer Screening Program. He also led to the review in the Advances in Colonoscopy chapter for the current Australian Recurrence Colonoscopy Guidelines. He's the past chair of the Australian GI Endoscopy Association and remains active in the National Endoscopy Training Initiative. Thank you very much.
Thank you. That's very kind. And I'm going to talk about withdrawal. I actually think insertion's harder to talk about than withdrawal, so thank you, Raj. The only thing that last question about repositioning, I think a little trick that I learned from Alan Moss years ago is that when you can't get round the hepatic, a little bit of partial supine repositioning often helps. I think it opens up the splenic flexure. It's relatively easy to do. My patients are just as fat as Cameron's. So I'm going to talk briefly about the gear, briefly about withdrawal times, ADR, why they're important, but then mainly about technique and how you fill that 10 minutes, which is where it lands in terms of withdrawal time, I think, these days. I won't dwell on this, but, you know, it's really hard to do good colonoscopy if you've got shit environment and bad gear and unhelpful staff and you're not using the right stuff. So if you, insofar as you can influence what is available to you, do so. And if you're not splitting your preps, then split your preps. Okay? You just got to split your preps, even for morning procedures. Withdrawal time is the time. I always say it's from cecal entry to anal exit. You know, how long should it be? I think I won't present the data, but I think 10 minutes is sort of where it's at. Beyond 10 minutes, certainly, as a routine, is a waste of time. This is from Cameron from some years ago, but I think it does take as long as it takes, and doing too many scopes on a list is bad. I won't go through this. You all know adenoma detection rate relates to cancer risk and also death, and that's important. That's why we do it, really, is to prevent those things. Adenoma detection rate, what should it be? It's changing, isn't it? It depends who you are and where you are. It's interesting being on the research committee and seeing where the numbers, you know, 25% is the nominal ADR, 4% is the nominal SDR. There are still people routinely performing at or around those levels, which is disappointing. But overall, the numbers are getting higher across different cycles of recertification. And as a result of recertification, we all know nowadays what our adenoma detection rates and serrated detection rates are. This fella knows a bit about colonoscopy, Doug Rex, and I was interested. He gave a plenary at DDW San Diego last year, and he talked about this same concepts: good scope, good bowel prep, good technique, and measuring and reporting your performance. Insertion, I won't dwell on, Cameron's done that, but I do think the concept of getting in efficiently, not quickly, efficiently, gives you more time. You know, if your anaesthetist is getting shitty on you because it's taking too long, at least if you're getting in quickly, it gives you more time to come out appropriately. Cameron's talked about this. Now, the concept of withdrawal and meticulous inspection, that the Doug Rex phrase, it really means, and I'll show you a video of one I did a few days ago just as an example, but working the folds and scrutinising the blind spots. And I like to use a cap for that reason. I think a clear cap on the tip of the scope really allows you to peel back the folds and have a really good look. I routinely, if I can, retroflex in the right colon and the rectum. You should always be able to retroflex in the rectum, perhaps colitis notwithstanding, but the right colon is harder, but it is usually doable. Right colon diverticulosis is not a reason not to retroflex. Double passing, particularly in the right colon. I'll show you my video I actually would routinely do 3 passes effectively in the right colon. And in fact, really, I think we're doing, if you're coming back and you're making sure you're getting all the folds, you're often double passing anyway, because you've got to come back twice to see both sides of the bowel, sometimes more often. Particularly the splenic flexure is a nightmare. And you've got to suction the puddles, and that's what takes time. The colon at the end of the procedure should be clean. And if there's a lot of muck and puddles left around, you can't see serrated polyps through puddles. You just can't. You've got to get it clean. Doug Rex again. So he, again, talks about CAPS, a mucosal exposure device, and at least one highlighting tool, by which he means different lights, which are, of course, available at the press of a button. You don't need to use chromo. I don't know if anyone's using true chromo endoscopy anymore for routine colonoscopy. Maybe for IBD, I don't, but others do. So I'm not going to dwell on this because Paveen's going to talk about this, I'm sure, but the different lights. And my workhorse mode is just high-definition white light. I love it. It works really well. NBI, for me, is interrogation, digital chromo endoscopy. So you see something, you interrogate it with NBI. I'm not a huge fan of TXI. Others are, I know. I think the only reason I use TXI is because it happens to give a better picture in the colonoscopy report than the other modes. But I don't use it routinely otherwise. CAPs, I think, certainly improve your view. I think they can improve access. They may make ileal insertion a bit harder, and they are expensive, which is a problem, and it's ridiculous how much they cost for a little bit of plastic. It drives me nuts, but I'm not going to talk at length about AI, except that I do use it routinely. I use target mode for insertion and withdrawal. And here's a little video. I think this is the wrong video. Anyway, it'll do. So we've just reached the cecum, and this is not a bad prep, is it? This is actually pretty good. There's a cap on. You can't see it very well, or is this the wrong video? No, there isn't a cap. Sorry, we must have linked the wrong video. It doesn't matter. This is an old video, so there's no cap, and I'm not using target mode. But routine ileal insertion and imaging to prove you got there. Now this is the wrong one because there's a polyp there that is not removed. But routine retroflexion, I use the ileocecal valve, not the cecum, but you can use either. I run it around. You can see there's diverticular here, no problem. When you retroflex, it's important to use it, not just do it. So you must come back as far as you reasonably can, try and peer behind those folds, particularly up under the hepatic flexure, which is that blind spot, which we don't see very well antegrade. You see a little polyp on the left. So the problems with this, and I used to use this, I've got a new one, but there's no cap, there's not enough water. You see the little polyp up there that I just gloss over. That's no good, you should interrogate that. And then really working the folds on the way back, making sure you're getting in behind them. These days, this is probably 10 years old, this image, this video. I would use a lot more water and really making sure that all of the puddles are clear. So to summarise, to maximise the yield of routine colonoscopy and improve your detection rates, you've got to split the prep, you've got to use good scopes and good monitors. A water-based insertion, I completely agree, but an air or CO2-based withdrawal, expand the bowel. Meticulous withdrawal takes time, and it basically means cleaning the colon so that it is completely empty by the time you finish. You do need to be facile with highlighting techniques so that you can interrogate lesions and know what they are and what to do about them. And then you should consider using CAPS, and if you have access to AI. I use it, but it's a personal choice. And we can have a discussion about AI. I don't know if that's part of other talks, but I think it's coming. At the moment, it's not good enough, but one day it will be better than you. So you might want to get used to it. Thank you.
There's a question on Slido. What are the blind spots in the colon?
So it depends on the bowel prep. The main ones are the splenic and hepatic flexures, so the flexures, but also the cecum under the ileocecal valve. I think that's often not interrogated adequately, and it's hard sometimes, if it's a long loopy bowel, to get good cecal insertion. And if the prep's not good, unfortunately what didn't come up on that video is the first thing I do when I get to the cecum is just put lots of water in and clean it up. I invest in the cecum to really clear the cecum, because you've got to do it at some point. And the other thing is it makes ileal intubation a lot easier if the cecum is clean, because almost by definition, when you're trying to get into the ileum, if there's muck in the cecum, you hit the muck just as you're trying to get into the ileal opening, because it tends to puddle there. So clean the cecum. And I think the hepatic flexure, we know the right colon is the problem in terms of missed cancer, missed polyps, and interval cancers and higher colorectal cancer morbidity and mortality. So we have to be good there. And you cannot always see what I call the subhepatic flexure, that the fold under the hepatic flexure antegrade. You just can't, the physics of the scope it's not possible. So I think you have to be able to retroflex and pull back up and have a look. Now you can't always retroflex, but that then means you've got to come backwards and forwards several times. So my routine, which again was meant to be shown, was into the cecum, clean it up, ileoscopy, a cleaning run back through the right colon up to the hepatic flexure, so lots of water, suctioning, trying to get it clean, back to the cecum, retroflex, coming back up to the hepatic flexure in retroflexion, trying to probe behind the folds, suction the puddles that often form that you can't actually see, antegrade, interesting, and then go back to the cecum and do a final withdrawal, antegrade. And that's often, in fact, a double withdrawal, because if there's folds on both sides, so you've got to come up one side looking at the folds and then go back and come back up the other side. So the video I show in a normal colonoscopy with a reasonably good bowel prep, from first entry to cecum to getting back to the hepatic flexure, is 4.5 minutes. So if you're doing 4.5 minutes just to do a normal right colon look, that's why it takes 10 minutes to come out, because that's only a third of the colon. And then you can spend the rest of the time coming out. And the splenic flexure often, in the left, I don't change position because, like Cameron, my patients are propofol. So in the UK, at St Mark's, where it's minimal sedation, the patients are awake. Yes, I would definitely turn them into splenic flexure, get the splenic up in the air, like Cameron said, know your anatomy. In the left lateral position, the splenic flexure is the lowest part of the colon. All the muck and the water and the shit sits there. You've got to clean it up. Ideally, you would move them and that all falls away and you get a much better view. But in our propofol patients, they're in the left lateral. I would often come backwards and forwards through the splenic, cleaning it up and trying to look 3, 4, 5 times, because that's tiger country. The other thing I like to do, which is not always done, is another look back through the sigmoid. So back to the anus, retroflex, see the hemorrhoids, make sure you haven't missed anything in the rectal ampulla, and then I will go back up as far as I reasonably easily can up into the sigmoid. And the thing you don't want to miss is the rectosigmoid cancer, or the high rectal cancer, because they're the ones who need the low anterior resections, and they're not as nice an operation. A right hemi, that's okay, but a low anterior resection. If you find the polyp that was going to be the cancer in 5 years' time, really important.
That's a question from Cameron.
Actually, Raj, it's a comment. 2 things that Gregor has taught me over the years about inspection. If there's any trouble in the left colon, if it's not nice and straight, do your first double inspection antegrade, face forwarding, because they're the ones that sometimes you have trouble retroflexing in, and then you can't get back to the base of the cecum. So that's the first thing Gregor taught me. And like him, he warned me about splenic. And one tip for the splenic is have a good look at it, maybe do it twice, but then come back to descending, and then almost insert badly with tip up, and that opens the flexure up. Very surprisingly, it's if you were doing the insertion first, it'd be annoying, but you can use that to your advantage to open up that inner corner, which is a bugger.
Can I ask a question? What are your criteria for repeating colonoscopies in terms of bowel prep? Do you go by the Boston score? Or
I don't use the Boston score on the ground. It's experience, and it depends on the clinical scenario as well. On the indication and the age of the patient and so forth. If they're really elderly and it's iron deficiency and it's not cancer and then I'm not going to get them back if the prep is okay to say it's not cancer. I'm not worried about the 5mm polyps. But in general terms, if I can't see 5mm polyps, I'm getting them back. When do I get them back? Again, depends on the indication and the patient, but usually within 6 months. If it's high risk and it's a terrible prep, then we get them back much sooner. But if you get to the cecum and you can say, well, I've had a look. I mean, I have had the experience of then coming back in 3 months and seeing the little cancer in the cecum that I couldn't see because the prep was bad, which is why you do it. So you've got to be careful. But
Greg, I've got one last question for you. Is it mandatory to use a cap?
No, not at all. No, I don't think it is. And it's expensive to use a cap. And I don't use a cap if I've got a planned dilatation, for instance. But I just find it really helpful in withdrawal and exposing mucosa. I don't use the spiky caps. I think are a bit of a gimmick, and they make it much harder to get into the ileum. There is data that they work, but they're even more expensive than a clear cap. So no, you don't have to use a cap, and it may not be an option for you depending on where you're scoping and so forth. But I just make my hospitals buy me caps. So, thank you.
Okay, the next speaker is Purveena Aslam. She's an interventional endoscopist and staff specialist at Canberra Hospital with a special interest in ERCP, endoscopic ultrasound, Barrett's esophagus, endoscopic mucosal resection, and endoscopic submucosal dissection of early cancers. She's going to talk to us about mucosal imaging for polyps, all you need to know for now.
I forgot to add that for now. Anyway, thank you, Raj, and the organising team for the kind invitation. So I'm going to go through a little bit about why mucosal imaging of polyps is important. So I've already gone through why we need to see polyps, but I think the important thing for us now is once we've seen the polyp, we need to be able to predict the likely histology, and that's because it helps us determine appropriate management. So the method of removal for a polyp really does depend on how likely we are in terms of what we think the polyp will be. It also helps us determine surveillance post-resection without waiting for histology, which can reduce the amount of clinical burden we have. And potentially we may be able to discard polyps that are diminutive, which might reduce cost for pathology and pathology burden. So there are a lot of different imaging platforms. So the one that you have access to is likely determined by the stack that you use. So Olympus has white light, which is image A. Image B is TXI, which is meant to help us see the vascular pattern a little bit better. We should all be familiar with NBI, and if you compare it to traditional dye-based chromo, now I think there has been a shift to virtual chromo endoscopy, which is less annoying, particularly with bad bowel prep, and takes less time. Fuji's got similar platforms, so BLI and LCI, and Pentax is iScan 1 and iScan 2. So the first time that they really thought about pit pattern and determining histology was Kudo back in 1994. They looked at 14,000 polyps and they found that pit pattern determined the likelihood of cancer. And at that point, they didn't really have virtual chromo. So they used they used indigo carmine, so dye-based chromo and magnification. And this led to the development of the Kudo pit pattern, which we still use to this day. At this point, we didn't really have sessile serrated adenomas, so we determined whether they were non-neoplastic, and type 2 is probably more sessile. Neoplastics, if they were adenomas, and if they were cancer. And I'm going to show the slide from so these are the pictures they used initially, back in 1996. And the reason I've put this up is to show that if they were able to tell with that kind of image quality, then I don't think we have much of an excuse these days to not be able to really have a good look at polyps. Is Kudo accurate? So there have been a lot of studies on this, but there was a meta-analysis back in 2014 that showed with magnification alone, it's actually pretty good. So sensitivity is about 90%. With chromoendoscopy, it increased marginally. So it's actually not a bad thing to still use. But it's complicated. There's lots of numbers to remember. So in 2012, the NICE classification was developed, and that's based upon NBI, so with virtual chromoendoscopy. And they tried to make it simple. So they just had two. So type 1 and type 2, and again, sessile serrated adenomas were not really a big thing back then. So type 1 includes sessile serrated adenomas, but we looked at the colour, so if it's lighter or darker, the vessels, if they're brown vessels, if it's lacy or there's none, and also the surface patterns. If it's homogeneous, we're looking at more of a type 1 lesion, and type 2 is more of an adenoma, which is branched or tubular. So these are a couple of pictures from the original paper. So as you can see in the first panel, the first two are lighter, so they're more hyperplastic or sessile, so type 1 NICE. The third picture at the top panel is a type 2 lesion because it's darker. And then you can look at the vessels in panel B, whether they're brown or whether they're lacy, and if it's homogeneous versus tubular structures. So we're trying to make it simple, and then they later on introduced type 3, which was more in keeping with Kudo, so type 3 is cancer, and that's if it's amorphous or disrupted. It's pretty good. The sensitivity is about 91% in real-time colonoscopy, and importantly, it's a simple way of determining appropriate surveillance colonoscopy intervals, so I don't think it's a bad thing to use day-to-day in practice. And it has been used in other platforms with similar results, so it's actually not too bad. But there are limitations, so it doesn't really differentiate between high-grade and low-grade adenomas. And as you know, Japan's very much about on-block resection. So in 2016, when we talk about JNET, which is the other one we use relatively routinely, they wanted to differentiate in type 2 lesions between high-grade and low-grade lesions to determine whether something should be removed en bloc or piecemeal. So essentially for type 2B lesions, you look for a type 2 lesion that's a bit irregular with vessel pattern and pit pattern, and it was more likely to determine whether it was a high-grade lesion or whether it had superficial submucosal invasion. And I'll show you a video later about why this is important. They've looked at this in Japanese studies. So the sensitivity and specificity is high for type 1. The specificity is high for type 3. So if you think it's a cancer, it probably is a cancer. But in type 2B lesions, about 50% of lesions were classified incorrectly and after removal had deep submucosal invasion. So I think it warrants further classification, and certainly the guidelines, particularly from the ESGs, that you need to use either a dye-based chromo or you need to use Kudo. So I don't think Kudo is going anywhere, despite it being a little bit more difficult to remember. But morphology is also important. So this is a quick slide on Paris. It's been around for a long time. And the one thing to remember with this is anything with a depressed component is a high-risk lesion, and certainly that depressed component needs to be interrogated further. We use granular and non-granular a lot to describe larger lesions. The one thing to remember is if it's a nodular lesion, so if there's a 2S component or there's a pseudo-depressed or 2C component, it's a higher risk of submucosal invasion, and that determines whether or not we remove something piecemeal versus en bloc. So I'll show you a couple of videos. So this is a granular lesion. So this is in the cecum. It's quite large, but as you can see, it's quite homogeneous, and there's no big nodules anywhere. I apologise for the bowel preparation. Should have probably cleaned it a bit better. And then this is it on with virtual chromoendoscopy. So you're just having a look, and it looks very uniform. There's nothing particularly concerning there. And so this, despite the size, is very safe to remove piecemeal, and it turned out to be a low-grade tubular adenoma. When we look at a non-granular, this is what we're looking at. So this is, I think, in the distal sigmoid or rectosigmoid maybe. But as you can see, this is less uniform. There are little bits that look a bit depressed. And so certainly if this was in the rectum, because of clinical outcome, it probably should be removed en bloc. Risk is a little bit less further up. Okay. So that's what we mean when we talk about that. So there have been some studies, well, this is actually an Australian paper, that looked at predictors of submucosal invasion. The biggest and strongest predictor is still Kudo 5. But if you have something that has a non-granular appearance with a depressed component or location in the rectosigmoid, it also predicted submucosal invasion. So these are the kind of lesions where you really need to think about whether you're going to remove them, particularly piecemeal, or whether you send them to a centre for ESD. So a couple of examples to finish on from some standard polyps I found in the last couple of weeks. So does anyone want to hazard a guess or talk about the pit pattern here? Anyone from the panel? No? I put a cheat sheet of Kudo next to it because I find it hard to remember as well. So this is probably a Kudo 3-4. It's a type 2 lesion, so as you can see the vessels are darker and it's more of a tubular structure. And I would say it was a type 2A JNET because it's quite uniform. So it's a tubular adenoma with low-grade dysplasia, simple enough to remove, can be cold snare polypectomy. This is another lesion which we commonly encounter. So this is probably a Kudo type 2, and it's got lacy vessels. It's a little bit lighter than the background, although this is an NBI picture. So I'd say type 1 JNET. And this is why image enhancement's important. So this is what it looked like without NBI and without cleaning the mucus cap. But sessile serrated adenomas, which is what this turned out to be, often have a mucus cap. So at a distance, when you look at this, has a depressed component, so you're a little bit more concerned. And when you focus in, this is a typical Kudo 5. So this is a cancer. It's important that we biopsy the right part of the cancer. So if we get the edges, we might get more high-grade polyp, which would be sampling error. And in most cases, this should really go for surgery. I'm just going to show you this video of a real patient. So this is a patient that was referred for a laterally spreading lesion, as well as granular in the rectum, for an EMR. So this is why interrogation is really important with virtual chromo. Okay. So I don't know, Raj, do you want to tell me when to stop if you see an area that you'd like to look at more? Like, what are you thinking?
So obviously, this is in the rectum. So first things first, generally the present sort of state of play or understanding is that if you have lesions in the rectum, which you can't quite make out whether there's any covert cancer, it's best to address them in an en bloc fashion. So although this looks granular, it's important to wash the area carefully. The black bits are blood, and this part here, which you are nicely demonstrating, is in keeping with possibly a superficially invasive cancer right there. So that needs special attention, and if this was to be removed in a piecemeal fashion, then you may cut that cancer into bits. So this needs an en bloc resection.
Yes, so when we talk about JNET 2A, 2B, as you can see, this isn't the area that Raj has correctly pointed out. You can see a demarcation zone around it. The vessels are irregular and interrupted, and so this is high risk of a cancer. So it's probably got a submucosal invasive component. So if you were to remove this via EMR, which I think a lot of people, perhaps if they didn't interrogate it carefully enough, would be happy with, because it is granular, there's no big nodular component, then what happens is that you have essentially cut a cancer into pieces. So people can't be sure of resection margin, which means in the rectum it has quite a lot of clinical consequences. So this was removed en bloc. And it turned out to be a T1A adenocarcinoma, no LVI, curative resection. Okay, so that's why it's important. So classification systems are good to know. I know it's a lot of stuff to remember, but it's a universal language, so it's important for reporting and referral. These are the three main ones we use. Paris classification and Kudo are not going anywhere, so it's good to remember them. Virtual chromoendoscopy just helps you see better. So I think, like, I agree. So standard colonoscopy on entry, you definitely go with white light, but I don't think there's anything lost by using virtual chromoendoscopy when you need it, and particularly in high-risk lesions. So anything in the rectosigmoid, anything with a JNET 2B, anything with a 2C or depressed component, we really need to interrogate further, because we can find things that are unexpected, which affect clinical decision-making. And I'd like to thank my old colleague from Portsmouth for giving me some of the videos.
Thanks very much.
A couple of questions on Slido. Question one is, what anatomical structure corresponds to a pit in the Kudo classification?
Anatomical structure. So do you mean between 2A and 1S? So I'll put it up here. So essentially, if you're talking about differentiating 2A and 1S, usually use a closed biopsy forceps. So if the polyp is bigger than a closed biopsy forceps, like taller, it's a 1S. If it's Smaller, it's a 2A. And then obviously 2B is completely flat. Is that what the question was?
So I think it meant, those dots you see on Kudo when one puts chromoendoscopy. So that's in keeping with a gland, basically, and so those little dots.
Yeah, this is normal.
Yeah. So if you were to use narrowband imaging in these days, you would see those sort of left-hand side image, which is rounded, but the pits would have a dot in the center of each round. So you can kind of imagine that. We'll probably show some images later as well on MDT. But yeah, so those pits are in keeping with glands, and you're seeing it sort of end on. There's another question which is quite important. Where do you biopsy on the tumor?
Yeah, so I biopsy. So for the video, I would biopsy straight in the center. So try and avoid things that are overtly ulcerated, because sometimes you just get ulcer. But you look for the area with Kudo 5. So I'd biopsy straight in the middle of that.
And Pervin also gave a good tip that sometimes we tend to biopsy at the edges, and it may turn out to be a TVA with high grade, whereas the vast majority of the lesion is a cancer. So if you're not certain, you could biopsy the edges and the center as well. There's one Slido question here, but probably I'll just answer that. The question is, what's the difference between virtual chromoendoscopy and NBI? So NBI is part of virtual chromoendoscopy. You've got other techniques like BLI, TXI. So those are all virtual chromoendoscopy techniques, or technologies rather. And NBI is just part of it, as shown in that slide. Any questions from the chair or audience? Anyone wants the mic?
I mean, I suppose you've sort of briefly touched on this, but I guess what you're looking for as an interventionalist for the scope, the polyp that we're not removing, how you want that described, because I know that there's often a lot of resource use with polyps that are inadequately described, either from a secondary scout scope by the interventionalist or not allowing enough time in a list to take it off because it's suddenly very different to what you thought initially. So what would you expect if you're getting a referral internally from your team to say how the polyp's described and allowing you to plan accordingly?
So I think, one of the biggest things is that some people underestimate the size of a polyp. So sizing is difficult. So an open biopsy forceps about 8-9 millimetres. And you can also use your scope to measure. Location is important. Access, particularly if they're from a referral centre, and particularly for lower GI, we don't usually do assessment scopes before doing the resection. So access is good. And lots of pictures, I would say. I don't know if anyone else has a comment.
What about biopsying things? Do you get concerned about people biopsying lesions that they're sending to you beforehand?
So in the upper GI tract, I don't mind. I think we should biopsy. In the IBD colon, you should biopsy. If it's a patient with a polyp for removal, then the biopsies increase the risk of fibrosis, so it can affect the lift. So I'd prefer no biopsy, unless you're really worried it's a cancer. And if you are biopsying, keep it superficial. Like if there's a big nodule and you biopsy the top of the nodule, you're probably fine. But if you take 10 biopsies from the base, it just makes it really challenging. But it's less of an issue in the upper GI tract. It's more of an issue in the colon.
Yeah, I agree. And if necessary, I think make sure that you biopsy the most abnormal area, because there are times where cancers are sort of delayed because biopsies were taken at the wrong spots. I think the other thing is that although this is a mucosal imaging talk, I think it's very important to ensure that when we tattoo these areas, if needed, please do not tattoo underneath the lesion or even 1 or 2 centimeters away, because the tattoo tends to seep through and makes subsequent resections really tricky and sometimes complicated by things like perforations. Okay. We'll move on to the next talk. Thanks. Thank you, Praveen.
Thank you.
So I want to welcome Dr. Brown back for the second tandem talk of the conference on snare. So it's hot tips, cold snare.
Thank you. It's me again. Cold snare is fantastic, isn't it? It's really taken over, and I think increasingly, in fact, for our registrars, they often don't get much exposure to diathermy-based polypectomy because it's so unusual now. I'm going to talk briefly about why cold snare. I'm going to talk about what polyps are fair game for cold snare because I think that's important, and that's a changing landscape. It's still in evolution. And then some videos around routine, tricky, the large serrated polyps and adenoma. So the principles of polypectomy, of course, should be that it is safe, that it is complete, no residual, that you avoid holes in people because that's generally bad unless you're an expert at fixing them. You want to retrieve the tissue still, and it needs to be efficient. There's no point taking 3 hours over a little polyp, and it needs to not bleed. The rationale, of course, with cold snare is really it's just a big biopsy. There's no diathermy at all. You're using the wire to transect normal tissue so that you get normal tissue around with the polyp centred in it, so you need a margin. But it completely eliminates the risk of thermal injury, which it turns out is really part of the problem with polypectomy, is that diathermy increases the risk of delayed bleeding, increases the risk of perforation. And certainly cold snare there may be immediate bleeding, but it usually stops. It's usually capillary based. It's unusual to have a big bleed from a cold snare, and it's really unusual to have a delayed bleed from a cold snare, even in the setting of anticoagulation. And this is not new. This has been around for over 30 years now. It's quick, it's cheap, it's safe, it's effective, and depending on the size of the polyp, you get an en bloc specimen. Which polyp is fair game? Certainly, obviously, small flat polyps, and I think small pedunculated polyps. My line in the sand, if I can get a 10mm or 9mm snare over the polyp, it's fair game for cold snare. And you can manage the stalk if you need to. The one thing I would say, though, in that setting is you've got to be a bit careful if the polyp is potentially malignant. And the reason for that is often with the cold snare, when you do a pedunculated polyp, it doesn't cut through cleanly necessarily, and it sometimes de-roofs the stalk, and so that the specimen that is sent to the pathologist is not so clearly stalked. And so that if there's then cancer in the polyp, your Haggart's is all up the creek. So I think if there's any doubt about that, then you shouldn't be cold snaring that pedunculated polyp. Large sessile serrated polyps are clearly fair game. I think large flat sessile adenomas are fair game, and patients on anticoagulation are fair game, even if they haven't stopped. I don't stop warfarin anymore for routine colonoscopy, and if patients, we normally ask people not to take their Xarelto on the morning of the procedure, but if they forget, I'm certainly happy to remove normal polyps. So large pedunculated polyps are not fair game because they tend to bleed more, because it's hard to get the snare over and cut through and because of this issue of making sure you've got the stalk controlled from a resection point of view. Bulky 1S adenomas are not fair game. The bottom right polyp there, could harbour submucosal invasion and should not be dealt with because you cannot remove that en bloc with a cold snare, and obviously malignant polyps. So any question of cancer in a polyp, they should never be removed cold snare. They should always be removed en bloc with a diathermy-based technique. Choose your weapon carefully. By that I mean you want a snare that you're used to, you use it all the time, you know how it behaves, you know how it goes over the polyp, you know how it captures the tissue. The size is, I don't understand a 15mm cold snare because it just doesn't cut through properly. It's too much tissue. I don't understand why that's a thing. except perhaps in a hybrid EMR where you want to, but even then it doesn't really make sense. So I use the Exactodes, the one on your top right. It's a 9mm snare. It's got a nice stiff wire. It doesn't cut through quite as well as others, but it goes where I want it to go. It's not floppy. And the catheter is finer. This is important, and it's stiffer. So the fineness is important because it means you can suck more stuff up. You don't have to take it out all the time. Once it goes in, when I'm doing colonoscopy, once that snare's in, it's in. It stays in until the end of the procedure. I'm not pulling it out and putting it back in for multiple polypectomies. And you can suction more stuff up beside that one because the catheter diameter is not as big as others. The catheter stiffness is important in terms of how well it will manage the stalled polyp, and we'll talk about that in a moment. So your basic cold snare technique should be that you need really clear commands because the nurse is doing the work, or your assistant is usually a nurse is doing the work. When I do hot snare, I do the cut myself, but in cold snare, I don't. The nurse does the work. So you've got to be very clear, and then and like the nurses I work with, they know how I do it, and so we get the device, we get it down, the trap is on. I ask them to open it. It's really important to work close to the tip of the scope. Right? So the thing I see with trainees when they're learning is that they have the polyp distant to the scope, and then they're sort of fishing hard, trying to get the snare out over it, and the catheter isn't stiff enough. And particularly if the polyp is down in a sulcus behind a fold, you have to use the tip of the scope to depress the fold to get the wire to apply to the polyp. Right? If you're trying to use the catheter to manage the fold, it's too soft, it just pushes up. So close to the tip of the scope, I often will have the snare open inside the scope, get position over the polyp, and then push the snare out over the polyp. You need to centre the polyp, you need to take a rim of normal tissue. This is really important. You can't take too much with a cold snare, right? You can't hurt them by taking too much. You might, if you take too much, you might stall, and we'll talk about that, but generally more is better. You've got to press the flesh, you've got to set the wire into the tissue so that it captures. Again, if you just have it waving over the polyp and try and hope that it's going to catch it, it's not going to work. You've got to have good opposition. So that often means you need to be able to manage the scope. With this hand managing the catheter, you've got to be able to manage the shaft. And whether that's with your little finger, whether it's using your hip, I do have the scope over the edge of the bed and I can use my hip to stabilise the scope relative to the patient. Right? And then ask the nurse to close the snare and you watch it capture. And the nurses I work with regularly, if it doesn't capture properly, they'll stop. Right? They won't just transect the top of the polyp. They'll stop and they'll go, that's not right. Oh, yeah, that's true. I wasn't good enough. And we'll try again. Keep the tip down so it's not like hot snare diathermy. If hot snare, we lift the polyp up to get the diathermy away from the muscle. With cold snare, we're not worried about that. And if we do that, when it cuts through, the polyp will sail off into the distance and you can't find the bloody thing. Right? So if you keep keep it pressed down, it will cut through under the polyp and it'll just be sitting there and you can just suction it up really easily. You don't have to go chasing it. So often the nurses they'll do it tight, so it's finger tight without cutting through, and they'll pause and just make sure that I'm happy, and then they'll cut through. Or if I can see that it's coming in, we've got tissue, it's nice, I'll say just cut through, and they'll cut through. And so here's where you sometimes need to be patient. The snare should be closed fully. So the other thing I haven't put here is when you're opening the snare, you don't, if the catheter and then the loop, if you open it too much, there's what I call the legs, right? They're the straight wire of the snare. You don't want to see legs. So often the nurses I don't work with very often will have legs. I'll say no legs, and they don't know what it means. So I just pull it back in a bit so that the V of the snare is right where the catheter is. That's really important. But then when they close it, it's fully closed. And then again, don't just keep it closed. Just wait. It will usually cut through, right? You just wait. And keeping the tip down. And then if it cuts through, as it usually does, you suction it up, check the defect, irrigate the defect. You can often do a little sort of swelling of the defect by irrigating into the defect. It'll puff up and you can get a beautiful image of the defect and the margin. If in doubt, if you think I haven't got it all, I've left a little bit, take more, just keep cutting. It's really safe. So here's a little serrated polyp. Here's that exacto snare. You can see there's no legs. It's at the 6 o'clock position. This is an old video. I think there should have been more margin on that. That's too quick. Here's another one. So less ideal position, slightly harder. We'll talk about this in a moment, but the tip of the snare has a point on it for a reason, and we can use that to manage the loop in relation to the polyp if we need to. If it won't cut through, so here's a little double polyp, and we get both of these, so it's taking a fair bit of tissue. This was a big problem back in the day before dedicated cold snares, when we were using the Olympus stiff snares. They were thick, they wouldn't cut through very well. And so we had to know how to manage the stalled snare. And so the concept is, if it won't cut through, firstly just wait a bit, it may work its way through. If it doesn't, straighten the scope and straighten the catheter outside the patient. That shortens the distance between the handle and the wire. Pull back gently, it might just work, it may not. And then you can release and regrip. And then if all of that doesn't work, and I must say I don't do all of that, I just go straight to crop myself because I'm a very impatient person and life's too short. So what I mean by that is, so the snare is closed, it's not cutting through, I'll retract, so I'll pull the catheter back into the channel, and then I'll ask the nurse to slowly open the snare. And what that does, we haven't got a thing, but of course what it's stalling on is not the mucosa, it's the submucosa nubbin underneath, the connective tissue. And so by opening it slightly, it releases the nubbin and allows you to complete the mucosectomy. And so you can see there that little bit of white stuff. That, of course, is not polyp. That's submucosal connective tissue. That's the nubbin that the snare was stalled on. So by gently opening it, and you're actually allowing the nubbin to be released from the snare, and you're actually avulsing the mucosa on the tip of the scope. Right? And you shouldn't do that with the snare closed, because I've never seen it. I've heard of it, but I've never seen perforation with a cold snare. But that is a potential risk. The other thing is, if you're a serrated polyposis patient, you're a lot of polyps, the snare fatigues. You get a new snare. So if it's incomplete, keep cutting. Bleeding is usually ooze. It usually stops. You can clip it if you need to. Don't take the snare out. The tricky small polyp, use the tip of the loop as a point of pivot. So this one, it won't sit right. You can decompress the bowel a bit to soften it up, to take the tension off the mucosa, but then using the tip of the snare to pivot, and then this one is inadequate. It's not ideal, and so we check the defect, and there's an error out the top that I'm not happy with, and we recut that. So keep cutting until you've taken it all. Large polyps use lift. The blue dye is really good. It doesn't matter it doesn't have to be gel effusion. Saline is fine, but the blue dye really demarcates the margin of the polyp, and it makes it it thins out the submucosa, so it's much easier to cold snare. Again, a quick video. It won't be as quick as I'd like, I think, because I'm showing you the polyp. So a little tip for young players is don't wash the mucus off until you're ready to cut it, because it can disappear. But you can see how the lift really demarcates the polyp better. You can see the margins much better. And then this is a little two-piece cut. When the first cut, it's really important to decide where you're going to attack, and just make sure you get a margin on your first cut and then work off that systematically across the polyp. There's legs on that snare, it's not good. So there's the first cut, suction it up, and the second cut. You can see working off the first cut, put the snare in the defect, the side, and then take the other side with a margin. And then check the defect. Make sure you haven't missed anything. Large sessile adenomas, I think, are fair game. I think particularly if you're doing that elderly patient, it's their index colonoscopy, they're on clopidogrel, you don't really want to bring them back. If it's bulky, that's a different matter. Again, I don't think we've got time to do this, to show the full video, but the principle is exactly the same. I think the question that we have at the moment, which we've still not answered, is if we cold EMR these large sessile adenomas, we know the recurrence rates are higher, 20% over 5% compared to hot EMR. Should we be doing something different, like should we be doing snare tip coagulation to the margin? So, that's something to consider. I think we've got time to... But you can see it cuts through. It's really important with adenomas not to be greedy. If you take too much polyp, it doesn't cut through as well as serrated polyps, and you can end up butchering it and making it messy. I think it still works, but it's not as nice. So you've got to see this one stalls a bit. I've tried to be greedy. I think the problem with the really, really large polyps is it can take an awful long time. So that wasn't very elegant. That was that wasn't even a crop. That was just a yank. But very safe. I think we'll move on. But that ends up really nicely, and there was no residual at check. And you do need to check those at 6 months. So cold snare is safe, it's effective. I haven't shown data, but it's really safe in anticoagulants. It's not a thing. It's a big biopsy, right? So it's fine. And it does have a role for large sessile polyps, certainly serrated polyps, probably flat adenomas, as long as you're happy they're benign and there's no bulky bits. That's it.
There's a question on Slido. I think with regards to your second last point, what's your practice around DAPTs and polypectomies?
Don't stop them. I haven't stopped clopidogrel for over 10 years. We did the study. It was underpowered, but it showed no significant bleeding. It's just not a thing. If you can biopsy, you can cold snare, would be my line in the sand. So, yeah. And as I say, we're doing a study looking at DOACs and warfarin, but I'd normally pause warfarin the night before routine procedures, more so they don't get a spike with the prep, but I think there's no evidence for that. And if someone takes their warfarin, I don't actually even check the INR anymore. As long as they're basically stable, I just get on and do it.
Just a point on that, Greg. So, I agree that we could do cold snare pretty much on any blood thinner, but the current guidelines don't reflect that. So I know in our institution we stop it, but because what we don't want is for a patient to have a repeat colonoscopy to remove like a 6mm polyp because it wasn't removed by that proceduralist. Yeah. So do you think the guidelines need to change?
We don't have Australian guidelines.
No, we use
you
the overseas ones.
No, I don't use the overseas ones. I use mine. I do what I like. No, seriously, the evidence hasn't caught. The guidelines haven't caught up with practice and evidence, and there is data out there showing it's safe. Anecdotally, it's really safe. And I have had, like you all have had, patients who've stroked out when you stop their drugs for routine procedures. It's a disaster. And patients, if you have the discussion with them and you say, listen, you've got two choices here, because they worry about bleeding. I say, yeah, you might bleed. We can manage bleeding, but if you have a really bad stroke, that's it, you're done. So, I don't know. I just think... it doesn't mean we don't have respect for the drugs, but I think in the greater context, these interventions... I'm not doing hot EMR. Well, so we can start the conversation about warfarin and hot EMR, right? So bridging is bad. Bridging is really dangerous. Why would you stop a drug that you can control the level of anticoagulation for an interventional procedure and then give them a drug to bridge them that you cannot control and cannot reverse? It just makes no sense. So if I'm doing an EMR on a patient on warfarin who's got a valve, a mitral valve, you don't want to stop it, or you're going to use something, we just keep the warfarin going. And then I do check the INR, I want it down around 2 or 3, and we do the procedure and they're in hospital overnight. Because if they bleed, we can reverse it. Whereas if they're on Clexane, it's in, and they bleed, it's in. And heparin, I mean, God, it's such a pain. So yeah.
Can I ask a question? When you
a cold snare, a polyp, and it's taking its time. You've been patient, but it's not getting through. Do you add heat on in that instance?
No. No. I would always, as I said, straighten, wait, re-grip, and then I use the crop. So I pull it in, open the snare as I gently pull it through the channel.
And the second part was on a patient who's been on warfarin that you're not, you're continuing the warfarin. Would you tend to use more hot snare in these patients just for hemostasis?
No. The reverse, because they'll bleed that night or the next day. Yeah, no. Other than intervention, planned intervention, I mean, other than planned intervention or the unexpected large pedunculated polyp, I mean, I just use diathermy almost never. It's all cold snare.
All right, thanks, Gregor. That's great. Thank you.
We'll move on. We'll get Praveen back to talk to us about cool tricks with a hot snare.
Thank you. So, I mean, I agree. So we're going to talk about hot snare, but I really think that, again, we really don't need heat that often, particularly in routine practice. And even in really large polyps, particularly in elderly patients who are very comorbid, your worry about recurrence is less because it's less clinically significant. And now we have so many techniques to remove recurrence that I think Raj is going to talk about later. So I think cold is really safe. But there are some times when we don't have a choice and we have to get out the diathermy machine, particularly pedunculated polyps with a big stalk. Usually the cold snare won't cut through that. Large adenomas or bulky polyps in young patients where recurrence is more of an issue and you don't want to subject them to continuous surveillance. And adenomas which are less than 20 millimetres but you're worried about high-grade dysplasia or early cancer, they really should be removed en bloc. And particularly in recurrence, cold snare doesn't work as well. So the first trick is to pick the right snare. There's a lot on the market. They come in different sizes and shapes. For EMR, because you're removing them piecemeal, you don't really need to go bigger. It's not necessarily better, and it does increase the risk of causing thermal muscle injury. So I'd stick to smaller snares, 15 millimetres and below generally. For stalked polyps, there's nothing worse than trying to get a small snare over a big pedunculated polyp. So pick a snare that will fit around the whole polyp. And for recurrence, smaller, stiffer snares tend to be a bit better because of the fibrosis. So these are all the shapes available. I don't think a unit should have 40 different snares. So I think pick a couple that you and your colleagues are happy with and then just get used to them. So I generally use a round snare. One of my colleagues really likes crescent snares, which can be helpful. And we have hexagonal for really just ampulectomies. So trick 2, so pick the correct diathermy settings. You should learn your diathermy machine, and it should be in front of you during your procedure. So I don't know why it's ever in the back where you can't see it. It's a safety feature. You should always be able to see it during your procedure. All cutting current is blended except for effect 1. So there's a mix of pure cut and coagulation, even with the yellow pedal. Basic principle is the right colon tends to bleed less than the left colon. So the only real difference when you say right colon settings is the effect, which is the coagulation. And the rectum's very vascular, so you probably want to go up on effect. If you want to cut on coagulation, forced coagulation is your cutting current, which I generally use for a large stalk in a pedunculated polyp. Soft coagulation is hemostasis, okay, so you can't really cut on that. These are the Irby recommended settings. So Q is shaped like a snare, so that's how you remember that one. It's generally setting 3. And these are the Olympus settings for their machine. So a lot of people ask me, when do you lift a polyp? And you have to think about the purpose of lift. So the purpose is to create a submucosal cushion for safety, and it also helps delineate the margin better, particularly in sessile serrated lesions. The purpose of the blue dye is to help differentiate between muscle and submucosa. So muscle does not take up dye, and it's to identify any problems early on. So always use lift when using heat. unless the polyp has a nice big stalk. And that's why when a cold snare polypectomy is getting stuck or jamming, don't switch to heat. You haven't lifted that. It's dangerous, okay? So what should be in the lift? Doesn't really matter, saline or gelaffusion. Gelaffusion tends to stay a little bit longer. Methylene blue or indigo carmine, whatever's in your unit. There's a little bit of a controversy with adrenaline in the right colon. So there have been a couple of studies that have shown more post-polypectomy pain, but it's a bit contentious. And the main use is to prevent bleeding, so it's probably more useful in the left colon. But our unit, we use gelaffusion, a bit of adrenaline, and a bit of methylene blue in all our lifts. Okay. Lifting technique is important. So if it's over a fold, if you lift behind the polyp, it'll bring it towards you. If you lift in front of the polyp, it goes away from you. If you're on fast, like in the cecum, you can just lift straight in the middle. You want to see a blue halo, so you want to see the blue lift surrounding the entire base of the polyp. If you can't see the lift, then don't cut there. And ensure the lift isn't too superficial. So if you get a dark blue bleb, and I wish I had a video of this, it's not enough, it's not in the right space. So I'll just show you a quick video of a lift to demonstrate. So here it's been injected in front, and it's less relevant because this is a smaller polyp. But as you can see, it pushes the polyp behind. Whereas if you... So it kind of can make it a little bit worse when it's over a fold. So you kind of want to lift behind it. Snare technique is important. So I usually start at one side, the easiest side, and work across the lesion. Start in normal mucosa. You want to ensure a nice clear margin and a ledge for subsequent lifts. Try not to create any islands. Islands are difficult to remove, and also it's usually the site of recurrence. And don't be afraid to tent the snare, particularly when you're closing. So it's a similar technique to cold. If you've got an adequate lift, it's safe to do this. And examine the base as you cut. So you can identify early areas of muscle breach, and you can also identify bleeding spots and treat them as you go. So I'll show you where the first cut should be, really. So this is nicely lifted, and as you can see, it starts off in normal mucosa on one side. So this is very safe. It's got a nice safe lift. And then push it away and examine the base. And that's what I mean when I say there's a ledge. So there's a nice ledge for subsequent snare placement. Trick 5, be ready for complications. So complications are inevitable. You should always know where gravity is, so you should be prepared to reposition the patient if you need to, if there's like a big catastrophic bleed. The best tool for coagulation is at the end of your snare. So it's your snare tip. Your diathermy machine should have hemostasis ready to go when you need it. You should always have hemostatic forceps for bigger bleeds in the room. So clips, so they should be ready, but I would try and avoid these mid-resection because they tend to get in the way. So cautery is better. And rescue agents are last resort. So if you put hemospray or Next powder, game over, really. You can't complete the resection, but they should be there if you really, really need them. I'm going to show you a picture of a stalk. I can't remember why this was lifted, to be honest. So I cut on forced coagulation when there's a large stalk, and this is important for the nursing staff who are here as well. So worst thing you can do is pull back the snare fully. So you examine the base. You can see a little feeding vessel there. And just get the snare tip out. Change to hemostasis, like soft coagulation. And then, unfortunately, I cut it off too early. But essentially, this is how snare tip soft coag works. It's pretty easy to use. It's very safe because it's quite a superficial burn. This isn't the best video. I'll say it's not mine. It probably is. Anyway, there we go. Okay? So that's how snare tip soft coag works. If you're using hemostatic forceps, it has to be a bit more targeted. So you need to pick up the vessel, lift it up, and then burn. Okay? So it's much more targeted than snare tip soft coag. And it's more expensive, so, you know. Most things can be treated with snare tip soft coag, I think, during EMR. So perforation. Identify perforations early. Clips are excellent, but don't apply them too early. And you shouldn't have some other closure techniques that you know, particularly if you're doing really large lesions. So assessing perforation, this came out of the Westmead group about the different types of muscle injury. So if you see a nice blue base, you're safe. You don't really need to do anything. If you see a little bit of a white area, then they recommend it's a type 2 injury and you should probably interrogate it further and maybe clip it. And certainly here, if you see a target sign or a big hole, it needs to be closed. So I'll show you a video of an EMR. So it's been lifted. Attempts were made to see the back, but unsuccessfully. So this actually bit is good. So you should try and aim your, the base of your snare at the cut margins. That's what I mean when I say there's a ledge, because you get better purchase on the tissue. So as you can see, there is a little target sign there. And so at this point, everybody freaks out, right? You want to close it, but this is not an open perforation. And you have to remember you have a clean colon, you are on CO2, and I think that in retrospect, this clip has been placed too early because now you have mucosa, like you have polyp underneath the clip, which you now have to remove. So I think my advice, if this happens to you, is that you need to stay calm, clear the area. So remove the polyp adjacent to it, and once it's clear, then you can clip it closed. It doesn't have to be dealt with immediately, okay? Trick 6, so tidy up. So you want to try and prevent recurrence. There's a lot of evidence that thermal ablation of the margins, either with snare tip, soft coag, or APC of the edges, significantly reduces recurrence, so I think it should be standard practice. You want to prevent delayed bleeding. So clip closure of defects prevents delayed bleeding, and most of the evidence is in the right colon, particularly in the ascending and the cecum, but also some in the transverse. Even partial closure is better than nothing, so please attempt it. There's not a lot of evidence for hemostatic agents for this, but maybe it'll come through in the future. So I've got a video of an EMR, but I don't know how we're going for time. Just one. Okay, so as you see, we're just going across the lesion. That one, the snare's probably a bit too far, to be honest, there. And then now we use snare tip soft coag because why would we pay for another piece of equipment for thermal ablation? And then I'm not going to go through clip closure, but this is clip closure. So this is a standard clip and it's a big defect. But with suction, usually you can close it pretty easily. Okay. So I'll just go through take-home points, but most polyps can and should be removed cold. If you're forced to go hot, the snare size is important. Know your diathermy settings and how to change them if needed, and please make sure your diathermy machine is in front of you. Be prepared to manage complications, so have everything in the room. And prevention of delayed bleeding is important, so clip close right-sided defects. Evidence is there for margin thermal ablation, so I think it should be done in everyone. Avoid islands, so have a good EMR technique, and ensure a nice wide margin. And that's all I've got to say.
Just one question. Raghu.
Parveen, good talk. There's one area which I think many people don't do is when you have large-headed polyps, instead of using a large snare, you can do epinephrine volume reduction, and you inject it, wait for a few minutes, go to the cecum, come back, it will shrink, and then you can easily get a 15mm snare around it rather than a 25mm snare, and that's something to think about when
I didn't go through water. Mm-hmm. You mean water-assisted EMR?
No. When you have a large-headed polyp, instead of using a big snare, you can inject adrenaline into it, which
to shrink it.
Yeah.
Okay.
So that's that has been described some time ago, and it's an easy, simple technique. Or even if you mix what you use for injecting the base with adrenaline, it'll shrink it a bit and allow your use a lesser size snare to take it off when large head polyps, especially the volume, the lumen-filling polyps. And then you can see the base as well better once the head comes down, and that's something you can use.
We're done.
Better move on to the next talk.
Thanks.
We'll bring Raj back, who needs no introduction. He's going to talk about zeroing on polyp recurrence. So, last talk before a break. So,
sorry, I realize I'm between a tea break, so I'll try to be quick. So I've really able to talk a bit about positive margins and what can we do. So this is just an example of some of the lesions which we tend to face these days because it may have been resected incompletely. So in this instance, there's sometimes not much choice or very little choice but to try to perform an ESD because we find that these lesions they tend to be pinned down to the muscularis propria, and it's quite difficult to remove them in a piecemeal sort of fashion. So you need to know some definitions, which includes the horizontal and vertical margins. So RO meaning the tumor-free lateral and vertical margins. Then there's R1 lateral, which obviously means that the lesion is at the lateral margin. The local recurrence risk is there, but smaller compared to when there's involvement of the vertical margin, where there's a potential of residual risk and nodal spread. So the ESG have recommended that if it's an RO resection, then it's deemed to be curative generally, and surveillance is recommended. However, if you've got the lateral extension, but no LVI, no poor differentiation, and no budding, then there's a local risk, and repeat endoscopic resection may be an option. Of course, if you've got deep invasion, then it's deemed as non-curative, and you have to discuss additional therapy at the MDT setting. So the guidance is risk stratified, not rigid. So a conservative approach in low risk R1 vertical margins may be a strategy as well. So this is take home, but don't go home yet. I'm just putting this slide basically to give you an idea that you need to first decide if you've got recurrence, whether it needs to be taken off end block or whether end block is not necessary, and the different sort of sizes you need to then determine, and the risk of fibrosis and the different approaches. Right, I'll come to this slowly. So how did we get to recurrence? You need to know about definitions first. So positive margin generally leads to recurrence. Sometimes there's time to recurrence. You may see it early on a surveillance colonoscopy 4 to 6 months, or delayed after 12 months, and the appearance, which could be endoscopic and sometimes histological, meaning on biopsies. How did we get here? You know all of these studies which was driven by Michael, which we've been part of in the last 18 years, I would say, on polyp and hot EMR, the intention to treat analysis to show that more than 90% of them avoid surgery. It's quick. Intra-procedure bleeding is about 10%. Perforation rates are fairly low. Post-EMR or delayed bleeding is about 12% in the right colon, and recurrence these days are about 1 to 2% if the procedure is done meticulously. These are some of the data on with regards to recurrence and the technique. So cold snare polypectomy for SSLs generally. So this is data across the literature over the last, I would say, decade. It's for 4.3% recurrence with cold snare polypectomy. EMR with no snare tip soft coagulation. So sorry, I'm using a lot of mnemonics there. The risk of recurrence is 4.6%. If there's cold snare polypectomy of adenomas, it goes up to about 24%. And EMRs of adenomas, it goes down again to 14.8%. But when you use the STSC technique, the latest data suggests it's about 1.4%. How do we detect it? Obviously, we here on an imaging conference, so it's important to use some of your imaging modalities. This was what was published from data here at the LAMEC to show that you can actually make out recurrence very easily with this electronic chromoendoscopy techniques, as we have been discussing. You can look at this classification if you're interested. And with the caps and the water flush, which we have these days, and the level of magnification with the scopes, we can make out that the left is exhibiting no recurrence compared to the right, where you'll need to treat. So it's pretty straightforward these days. This is validation, so I won't go through in detail. So we can risk stratify recurrence as well, and this is part of the A study on 1,000 lesions, showing that out of 800 of those, so there are some patients who we just could not get in touch with them, but out of the 800 patients who had a first surveillance colonoscopy, recurrence rates were fairly high at 16%, all right? But then when we brought them back and resected these areas, the recurrence on the second surveillance was about 6.7%. And these were then again endoscopically resected. So out of the 800 odd patients, about 1.2% of patients ended up having surgery. So it's quite an effective strategy to use. Obviously, some patients would have to have repeated colonoscopies. But this was 10 years ago. You can also use some sort of criteria based on the size, the risk of intraprocedural bleeding, whether there's high-grade dysplasia, and come up with this SERT or SERT score, meaning that SERT 0 surveillance in a year and a half and SERT 1 to 4 surveillance in 6 months. Or you can use something called the SMSA score. Again, quite complicated. This will be on slides on YouTube, so when you look at it, you can try to sort of figure out if you want to use this in real time. Size, the morphology, the site, and the access, and it'll give you a score. You combine those scores. If it's SMSA2, then the recurrence rates were 5%, and go on to SMSA4, recurrence rates are about 24%. So you can use this score if you want to. Obviously, the other risk factors other than the size, the site, the morphology is whether the lesion is non-lifting, and sometimes, obviously, whether the endoscopist has the experience to remove these lesions. So how do you prevent recurrence? We've discussed endoscopy imaging is key. You need to look carefully after you've resected. Don't be afraid to look at the polyp base, even if it's a small polyp. You know, as Gregor was mentioning, shoot some water into the base to look at the margins very carefully. Consider cold snare EMR for SSLs, as we have discussed. But obviously, avoid all of the other things, such as a depressed lesion or with SMI. Hot EMR is capable of addressing a lot of the lesions as well, but you have to do it well. And ESD and full thickness resection with careful case selection when en bloc resection is deemed necessary. So we've discussed hot EMR. I won't go into detail, but just to say that STSE or snare tip soft coagulation at the edges helps to reduce recurrence rates from about 20% to about 4 to 5%. This was 7-8 years ago now. The latest data, which has come from a multi-center sort of setup driven by Mike, shows that the recurrence rates are about 1.4%. In our practice, this is kind of what we see these days. It's generally between 0 to 1% recurrence rates after a good STSC is done at the edges. So how do you manage this? Cold snare, maybe. So this is a lesion in the duodenum actually, but I'm just showing you that it's sort of been hammered with lots of biopsies, so the folds are kind of converged together. But what we're doing here is just carefully using a cold snare technique and working from one edge to the other, and carefully cutting it just using cold snare and using the water flush as well. I tend to use a bit of adrenaline with cold snares, and I do say this because it allows the oozing to reduce and allows us to assess the margins much better. So we tend to use a bit of adrenaline in our injectate when we do cold snaring. So this is just using a fancy sort of technology called RDI, which some of you may know, and it just helps to sort of look at the base after the end of the procedure. So cold snare could could be an option even for this sort of very fibrotic recurrences. Obviously, hot snare is the way, and this is one of the problems with doing an incomplete resection, and when the lesion bleeds, somebody decided to put a clip, and then you've got polyp underneath the clip. And that can sometimes be quite tricky. So we have to be careful that the snare does not transmit the heat to the clip. So a good careful lift, and then just burning the edges as well as the center if you are worried that there's some evidence of adenoma at the base. You can use ESD as well. This is just a case which was referred elsewhere, and you can see that a hot snare was performed. Probably the issue here is that this may have looked like a hyperplastic polyp, but it turned out to be a neuroendocrine lesion. So we find the scar, and you can't really see anything other than the scar, but we know that that's where the lesion is. And what we then do is we perform an ESD. So effectiveness of ESD for recurrence, basically when a polyp has not been manipulated before, obviously the en bloc resection rates and the curative resection rates are higher, but when it's been manipulated, then obviously the sort of rates of success is about 3/4. All right, so this data does suggest that. This is a nice study looking at salvage ESDs for previously attempted colorectal lesions, PACLS, lots of mnemonics, but just bear with me. Index lesions were resected using these various techniques, including a surgical type transanal resection in 5% of these 415 polyps, quite large polyps. You can see that the curative resection rates is about 73%. So it's not perfect. Patients do stay in the hospital, about 1 in 7 of them. Some of them had cancers and a perforation rate of 5%, delayed bleeding of 2%. So it's not without risk when we tend to do these more advanced procedures. You can also use full thickness resection. This is a lesion which was incompletely resected, but obviously looking at the base, this is a cancer. I think the patient had quite a few comorbidities, so we removed it using the FDR technique. Lots of studies coming from Europe, basically more than 1,000 patients showing that RO resection rates are about 77% and a bleeding risk of 7%. So it's again not without risk. I think it's an imperfect technique. You can use it provided that you've got good visualization of the entire lesion. If you don't, then you're going to run into trouble. So this was a polyp within a diverticulum, which we used the FDR technique to remove. Meta-analysis, 14 studies, 2,000 patients, recurrence rates of 13%, need for surgery of 5%, adverse events of up to 12%. So the other thing we commonly get referred to is patients who've got these polyps in the appendicular orifice, and rates of appendicitis is about 1 in 7. So we have to be a bit cautious when we use the FDR technique, and sometimes it's hard to manipulate in the left colon. How do they compare with ESD? Again, it looks like ESD, a little bit more control. So I think slightly more superior, but this is on recurrent polyps, small series of 15 patients in each arm, showing that maybe ESD is a little bit better than FDR. A larger series looking at a historical cohort of patients, showing that recurrence rates are a bit better with ESD, not a bit, quite significantly better with ESD compared to FDR. So I think it's because it's more controlled, and you can visualize what you're cutting. You can use adjunctive techniques if you need. So this is something called hot evulsion, which we tend to use. We use the endocut eye current and use a hot biopsy forceps. I'll just move to the area. So an incompletely resected area with lots of sort of fibrosis at the base. And this is the hot biopsy forceps being used to perform hot evulsion. Actually, it's just a fancy term, is it? Cold evulsion, hot evulsion. It's just hot biopsies, and you're just peeling the tissue off. Obviously, you have to be careful that you don't peel the muscle off as well. So it tends to be, you have to tend to time it with capturing the area, sort of pulling it off, and then applying some current to peel it off totally. You can also use cold avulsion, not as elegant as hot avulsion in my opinion, because obviously the lesion or the area would ooze, and then it makes it difficult to assess what you're looking at. But then you apply something called the snare tip on that ooze, and then you sort it out that way. There's no difference between previously attempted patients who've had an EMR without EMR. The risk of recurrence is the same. And complications, we did touch briefly on this. If things are tattooed, it's difficult. It becomes one, and then you'll face things like this where you get a perforation which then needs to be closed. So this is a suggested algorithm. Recurrence, decide if you need to remove it en bloc if there's suspicion of submucosal invasion, SMI, or not en bloc. If you need to remove it in a single piece, if it's more than 20 millimeters, ESD. If it's less than 20 millimeters, probably an FDR technique or ESD. Again, as I said, FDRD may not be as controlled as an ESD, although it's sometimes quite quick and swift. If you don't need to remove it in an en bloc fashion, which generally tends to occur in the vast majority of our lesions, try to decide or try to discern if there's fibrosis, whether it's multifocal, meaning the polyp's been hammered quite a bit, which you may need an ESD or FDRD technique, or if it's just a diminutive polyp on a scar, which we tend to see sometimes. And then you can use these adjunctive techniques, as I mentioned, the hot avulsion or the cast technique, because that's quite easy to use and it does work. So be lesion and I guess lesion specific, and be meticulous using those techniques we discussed when addressing these polyps. At the index procedure, I think that's the most important, but we cannot avoid recurrence. It will occur in all of our patients, not all of our patients, but in our experience, it will occur now and again. You can use certain scores if you're comfortable with it. And if it's a positive margin, it's probably going to lead to a recurrence or residual polyp. And then you should try to look at it with some techniques which we discussed, and then treat it using that algorithm which I described earlier. So with that, thank you. And we'll probably take one question and then break for tea. Thank you. Any questions, Gerald? No?
Yeah.
Okay. Oh, yeah, Gregor. If you can hand the mic. Thanks.
Raj, in the world where we're now clipping a lot of defects and then coming back and looking at them 6 months later, do you want to comment on distinguishing between clip nubbins and recurrence?
Yep. Thanks. That's a great question, Gregor. And it tends to occur now and again. So when you're faced with that, just use your imaging techniques and look at the surrounding area first, and you'll find that the pits in the colon, as you saw in Parveen's slide earlier on, is rounded. And with granulation tissue secondary to clip artifact, those pits will also remain rounded, but a little bit larger than the surrounding. All right, so that's one key sort of strategy to understand that we're dealing with granulation tissue instead of recurrence of adenoma. The adenoma will look like an adenoma, a brain-like pattern. So you'll find those pits being sort of gyrated or villus-type pits, and that's when you know it's an adenoma. So once you have discerned or decided that, the next thing to do would be to see if that clip is loose enough for you to remove it. And sometimes that could be the case. Sometimes the clip is pinned down to the muscularis propria. That gets tricky, because then you have to make a call whether you're going to try to lift it off and sort of slowly ease off the clip off the base, or whether you want to not do that and leave it to an advanced endoscopist to try to see if they need to resect it using an ESD method. Because sometimes those clips remain there for some time, and I think it's because they're stuck to the MP region. But the key here again is imaging. So imaging will give you an answer with regards to whether it's granulation tissue, which is quite common as well, versus adenomatous tissue. And you can see it quite clearly using those techniques. Okay, we better break for tea and then we'll be back. Thanks. Hey, Gary. Welcome back. Okay, welcome. Welcome back. No, excuse me. Welcome back. So we'll get started with the next session. So I'll just introduce our two chairs. So we've got Professor Rob Bryan, who's the head of IBD at the Queen Elizabeth Hospital, very prominent researcher. And Rob will be co-chairing this session with a new addition to the South Australian family, Akira. So Akira is working at the Flinders Hospital as well as the Queen Elizabeth as an interventional endoscopist. So they'll take charge for the next session. Thanks, Rob and Akira.
So I would like to introduce the first speaker. The first speaker is Dr. Niroshan Monwela. Niroshan is an expert interventional endoscopy at Royal Perth Hospital, who is leading the field of third-space endoscopy with a reputation extending nationwide. Today he will discuss about the pros and cons about EMR and ESD in the colon in the Western settings. Please join me in welcoming Dr. Monwela.
Thank you. Thanks for the introduction, Akira. And thank you very much, Raj, for having me here. It's great to be here. So let's dive right in. I mean, colonic EMI and ESD should and can we meet halfway? It's like the infamous battle, isn't it? So it'll so soon be revealed who's Neo and who's Agent Smith. So why does that matter? I mean, we all know that large non-pedunculated colorectal polyps comprise of 1 to 3% of all polyps. And our goal ultimately, whether we use EMR or ESD, is organ preservation and avoiding surgery. Two main strategies, obviously, to do that, EMR and ESD, we have to determine which gives the best balance of safety, efficacy, and efficiency in every situation. So, EMR technique, I mean, we've heard the talk from Praveen. We know that it's submucosal lift and snare excision. It's often piecemeal for lesions larger than 20 millimeters, and it's technically straightforward. It's widely reproducible. The learning curve is very short, and it's proven time and time again. It's a very good technique. As you can see in the video, it's even a larger polyp like that with adequate lift you can take off. So this is compared with ESD. You don't have to work so hard. You can do it with your one arm when Agent Smith is fighting so hard. Compared to that, and I won't go into detail, Honji will do that, but technique overview is circumferential incision and submucosal dissection. It allows on-block resection regardless of the size. So that's the key thing. So that's the balance that we need to strike. It gives superior histologic staging. However, there's longer procedure time and there's a steep learning curve, and it's not for everyone, and it's not for every place in the colon either. So what does the evidence show about EMR outcomes? You can get complete clearance rates in more than 90% of benign lesions. Procedure time is short, and most of the patients go home the same day. Delayed bleeding rates are very low, and perforation rates in good hands is even less than what's quoted there. ESD outcomes, it has a superior on-block resection rate in even larger polyps, very low recurrence rates. But the procedure times are higher, and the higher adverse event rates intuitively. Recurrence after EMR, I won't go into too much detail. Raj talked about this. Recurrence rates are much less than what's quoted here because of the newer techniques of snare tip coagulation, etc. And even if it recurs, they're usually small, amenable to repeat endoscopic therapy, and we saw that it rarely requires surgery. Now, there are modern enhancements to EMR, which makes it even more preferable. One is snare tip soft coagulation, as you can see in here. What you do is with the tip of your snare, the current I use is soft coag effect 360 watts, and you go around the margins, ablating the margins. And that's shown to reduce the recurrence rates considerably. The other is pre-cut or hybrid EMR. You don't have to have a knife. You use the tip of the snare itself as a knife, and you circumferentially incision around it, and then it gives, to borrow a word from Perveen, a ledge to capture the polyp around it, and you can get a good en-bloc resection like that. We just spoke about it. Underwater EMI is not, underwater EMI is not, I don't think it's taken off that much in Australia, but it's a very good technique. It's got a proven track record. Even larger lesions you can remove safely without needing injection. And cold EMR for selected lesions, especially serrated polyps, we don't need to use hot EMR anymore, and bleeding risks, delayed bleeding risks, and perforation risks are negligible. So, what's head-to-head? Jeremy Jark's group published this in 2024, the Resect colon study. They chose lesions more than 25 millimeters, more than 15 centimeters proximal to the anal verge, and no endoscopic features of SMI. Primary endpoint they selected was recurrence at 6 months, but if you delve a little deeper, we can get some other points of data. Surgery after cancer diagnosis was 6 out of 177 lesions in ESD arm, 11 out of 182 in the EMR arm. So it's comparable. However, there were 2 other patients that went to surgery because of adverse events related to ESD procedure, so 8 out of 177. And the submucosal invasion rate was 6% in keeping with other available studies. And if we take the whole cohort, and if we postulate that all of them underwent ESD, remember these are lesions 15 centimeters or above, number needed to treat to prevent one surgery for cancer is 60. So that's a big number to utilize such a complex procedure like ESD. So then comes the question, what about the distal colon or the rectum? We know that rectal PCPs are larger, they're likely more granular, more likely to have nodular component, therefore either invasive cancer inside or fibrosis because of the movement artifact. And they're more likely to have TVA histology and cancer more common, as you can see in this chart. And it's been shown that these are more likely to harbor submucosally invasive cancer, just like this lesion that we encountered recently, even with benign looking pit pattern in the nodule, this had invasive cancer in there. And predictors for missed submucosal invasive cancer are lesions larger than 4 centimeters, a dominant nodule, and the distal location. So when you talk about a practical algorithm, if a polyp shows benign morphology, EMI is still first line and effective. And if a lesion is suspicious of superficial cancer, then you can consider en bloc with ESD. And fibrosis, obviously, ESD is superior. And you have to match technique and expertise and the center volume to the technique that you use. So can we meet halfway? EMR remains in the colon the workhorse for most colonic polyps. ESD is very good, excellent for selected high-risk lesions, and most patients benefit from safe EMR. And the key thing here is these 2 techniques has to be complementary, not competitive. So can we meet halfway? I think we can possibly meet 80% down the colon, and let's shake hands on that. Thank you very much.
Thanks, Roshan. Okay, so we'll move on to the next talk. Our next speaker is Associate Professor Hong-Chi Yip. I think we don't need to introduce him again. I think this is his fourth presentation already, so been very busy. So I think we're going to be talking about ESD versus EMR from more of the AGM point of view. Okay,
thank you, Akila. So it's a tough task because Niroshan has made the scene so nicely, and it seems like there's no winning for me. Anyway, actually this debate has been going on for so many years. The latest one I witnessed was between Michael and Yutaka Saito back in 2025 in APDW, so just basically 2.5 months ago. And, well, after the fight, this is what happens. They are still making consolations, and obviously you see Raj was actually there, and he was asked to vote on who is the winner, but I forgot whether you raised your hand or not. But anyway, it has been an interesting debate, but to me, I fully agree with Niroshan. I would rather say it's not a fight, we're friends. So, and ultimately, it's about our patients, not about who wins or whatever. And also, the second thing is about the affordability of our healthcare system. So first about the target colonic lesions. I think we need to go back to some basic questions. So how good are we in assessing possibly invasive cancers within the colorectal lesions? And also, even when it's a colorectal lesion, how good are we in predicting the depth of invasion and the possibility of lymph node metastasis? I think these are the basic important principle behind whether or not we are going for an en-bloc resection or whether or not it's a piecemeal resection is still acceptable. So these are data that comes slightly older, but we know that particularly for different subtypes of LSTs, they actually harbors different risk of submucosal invasive cancers. And I think it does make sense when you think about whether or not you resect them en bloc or whether you resect them in piecemeal manner, because if you resect the cancer in a piecemeal manner, number one, it's very difficult to assess the pathology, the margins and everything. And you might be cutting halfway within the cancer, which would make the recurrence rate, a cancer recurrence rate, much higher. In fact, unfortunately, so as already mentioned previously, the JNET2B, which we commonly use, it's not that good. So JNET3 is perfect in terms of determining deep submucosal invasive cancer. But for 2B, even within experts or non-experts in combination, the overall accuracy is still not that good. And not to mention that even when you explain that JNET classification to outside of Japan in this particular study, they actually found that within experts or members within the ESGE or JGIS non-JNET members, the overall sensitivities remains slightly lower, particularly for JNET2B lesions. So going back, I think in principle, well, if we are to choose, en-bloc resection, of course, is ideal because it helps to determine the margin better. You can have the whole specimen for the pathologist to assess. And in low-risk patients, it will tell you much easier whether or not you need surgery or not. Of course, you have a chance of cure and you have a lower recurrence rate. In fact, if you look into the data, this is a previous study back in some years ago from Japan, which looks into the local recurrence rate. Not to say which particular method is better or not, but just to say piecemeal resection in general would give rise to a higher local recurrence rate, which is quite obvious and easy to understand. And in fact, in this, another study coming out from the Americans, from the Ohio clinic, actually they look into 254 colonic polyps which underwent EMR. So the recurrence rate, in this case, not only local adenoma recurrence, but cancer recurrence rate was 2.4%. And unfortunately, all of them occurred after piecemeal resection. So I do believe for high-risk lesion, there is a meaning of performing an en-bloc resection. And I think, well, don't need to expand too much. If you look into data coming out from Japan, it's obvious that they are able to reduce the complication rate to a reasonable, very low rate, 3.3% of intraoperative complication and 3.9% of post-procedural delayed hemorrhage and perforation. And overall, the need for surgery was 0.5%. And most importantly, the organ preservation rate was 98.1%. So these are excellent outcome data from Japan. Of course, you may argue whether or not we can replicate the same thing in the Western scenario, which probably will need more discussion. But this paper was quoted by Raj just now. So this is coming out actually from a large multi-center study across the globe. I didn't see any Asia, but most of them from Western large-scale centers, 415 in total for ESDs for previously attempted colonic lesions. Majority of them underwent prior EMR. And you can see that the outcomes was actually, I think, quite reasonable, even though there is still a proportion of post-procedural complications of about 6%. But still, I think it is reflecting that the performance of Western endoscopists in performing ESDs is getting much better and better. And this paper, again, was quoted just now by Niroshan, showing that if you do a head-to-head comparison between EMR and ESD, in fact, obviously the R0 resection rate would be much higher, comparing EMR versus ESDs, and there was really a trend towards higher periprocedural complication rate in terms of perforation and bleeding, but the outcome is not so much different nowadays. So the next question, I think it does matter, is whether location is pointing towards what we should choose. So this paper was from Japan back in 2022. Interestingly, even though there has been a lot of argument saying that right side colon has much lower risk of submucosal invasive cancer, but this actually suggests otherwise, because if you look into this data, numerically there seems to be a lower number of SM invasive cancer in the right colon. But if you look into the different morphology, in fact, except for the LSTG, which shows a much lower risk of submucosal invasion, all the other morphologies like non-granular type LST or even non-LST, they showed a significant higher risk of SM invasion, almost comparable to those in the rectum. So we couldn't just use right side as the single consideration factor. We still have to go back to the lesion morphology. And this actually was also supported by another recent published data from the French. This was recently published. And again, they look into comparison between rectum and colon. And they actually also found that there was actually not much of a difference in between the two groups in terms of submucosal invasive cancers when they matched it. So when they matched the two groups in terms of the morphology and everything, then it didn't show any difference. So, of course, the next thing is the consideration of scenarios like lesions with significant fibrosis, like previous EMR, or even lesion like this that grows next to the appendiceal orifice. So I do think that these lesions are suitable targets for ESDs because that gives you a much better chance of getting a good en-bloc resection with cure for these patients, or even lesions that is next to a diverticulum. So, so I would also put up to this final slide to say that actually I think we have already met somewhere in between, because this paper was published 2 years ago. It's a consensus between the World Endoscopy Organization. Again, you see Michael's name on it, you see Rash's names on it, and you see a number of Japanese names on it. So they agree to, well, at least finally they agree to this algorithm. So in JNET2A lesions, if it's an LSTG homogeneous, then in the proximal colon, they agree that you can do en bloc or piecemeal. Probably doesn't matter that much. In the rectum, they actually advise, if possible, if technically available, then you can consider en bloc resection by an ESD approach. If it's JNET, if it's a non-granular or a mixed type granular LST, then probably it will be better to do an en bloc resection. For those with 2B, I think there's not much of a debate. We should attempt en bloc as much as we can. And of course, for JNET3, then these are the cases possibly referring for surgery. So I think should we meet halfway? I do think yes, especially for colonic lesions. And for low-risk lesions, I think piecemeal and en bloc resection probably equally effective. But for high-risk colonic lesions, en bloc resection will be preferred. So on that note, I think as endoscopists, we should learn the techniques of ESDs. And recently, there are a lot of new adjuncts that will help us in performing these procedures safely with high efficiencies. And or if you have an appropriate centers of referral, then these cases should definitely be referred to them for consideration. And ultimately, I do think you also need to balance on the cost and burden to the healthcare systems tailored to the specific situation, say in Australia. So with that, I would like to conclude. Thank you.
Next up, we have the colorectal histopathology MDT, and I'd like to introduce Professor Andrew Ruskovich, who is a senior consultant pathologist at Assay Pathology and also working at the University of Adelaide and University of South Australia. Professor Ruskovich has a special interest in gastroenterological pathology, particularly in precursor lesions of the colorectum, and is a founder of co-founder of the Colorectal Cancer Tissue Bank. His interest in familial colorectal cancer, including Lynch syndrome, resulted in several publications, and his laboratory has also been involved with the identification of a concept of serrated pathway for colorectal cancer. And his lab also offers testing for MSI and mismatch repair genes in a diagnostic setting. Apart from being a regular reviewer for several journals, Professor Ruskovich has served as a panel member for the NHMRC and is an examiner for the Royal College of Pathologists. I'd like to welcome Professor Ruskovich to the stand. Thanks.
So we'll get cracking, but it's not common normally for the speaker to introduce the chair. So this is Dr. Jivanesh Naidu. He's a senior consultant at the Queen Elizabeth Hospital. So thanks for joining us, Jeeves, as the chair. So I know we're running short on time, so we'll try to make this as quick as possible. This is just a few slides. So I just want a show of hands. When you see this sort of lesion, what do you think this is? Anyone for option 1? Just show of hands. Option 2. So this is the Paris classification. No? Oh, there you go. Cameron. And he's correct. So that's 2A plus C, sort of slightly elevated but depressed in the center morphology. All right, so that's the Paris classification, which we probably didn't touch much on today. That is the center of the area which we had looked at. All right, that center which shows a bit of blood. What would the JNET classification be here? Anyone for option 1? Show of hands if you can. Option 2? Option 3? Yeah, I do see Honchi and Amol and Gregor, so that's correct. So that does show that the vascularity is present. You can see that. So if you had chosen option 4, you'll find total distortion or amorphous pattern in the center. So the vascular pattern is seen here, but it is not regular. It is irregular. All right. So JNET 2B, as you know, has got almost a flip of a coin type accuracy with regards to whether there's submucosal invasion or not. Even with the Japanese, and after extensively teaching the Europeans, they performed even worse. But what is important here is to look at the gross morphology and obviously the magnification component of the most abnormal area, and then make a call as to how this should be removed. And in this case, it should be removed in a single piece in en bloc fashion. This is just another case. It's not a video, but you can actually see that you've got two nodules at the side and then a little bit of a depressed area in the center. But if you look at this area with greater clarity, you would find that this is regular. So this is in keeping with possibly a tubular villus component of this lesion. But if you look on the left-hand side or towards the 8 to 9 o'clock position, you'll find very typical classical demarcation line, which is always described in the stomach, but you can actually see it in the colon really well. So that area over there in the circle is the normal sort of tubular villus component, and that area is the cancer. All right, so it's very important to differentiate this large lesion, because you would want to take it off very carefully in a single piece and not in a piecemeal fashion. Just by looking at this area, you would think that it's okay to take it off in a piecemeal fashion. Just another case. Again, if you see this sort of lesion, you're not going to attempt any sort of endoscopic treatment, because I can see everyone putting their hands up. It's a JNET type 3, which is in keeping with an invasive cancer. All right, so that's the JNET classification. The JNET 1 and 3 is pretty specific and pretty good. JNET 1, unfortunately, does not tell us whether it's a sessile serrated lesion or a hyperplastic polyp. It's the JNET 2s which are a little bit tricky. If it's regular, it's still okay to piecemeal the area, but if it's irregular, then you have to consider if you want to take it off in a single piece, which will need obviously an ESD type technique, or EMR if the lesion is less than 2 centimeters in size, or if you're using an underwater technique, then maybe you can go up to 25 millimeters. So we'll come to the histopathology side. This patient has got a metastatic prostate cancer. One of my colleagues in the audience would know this patient quite well. So this was performed maybe about a month and a half ago. The patient had anemia and melena. Endoscopy was unremarkable. We found this 11 to 12 mm lesion in the sigmoid colon. It wasn't bleeding. Obviously, that's some scope trauma, which makes the magnification component a bit tricky. So one tip you can use when you want to look at the surface pattern of these lesions is to reduce the water flush pressure. All right, so just turn to your back. You'll see the foot pump pressure. Reduce the pressure, and the force of the water will reduce, and the ability to look at the surface would be probably better than when it starts bleeding, because once it starts bleeding, it's hard to discern it. This is a JNET type 3 lesion. You can actually see a demarcation line. If you actually look hard enough, you would see a demarcation line at the inferior part of this lesion. So we decided that the patient had already had a good bowel prep. This lesion was about 11 to 12 millimeters. We went on and performed an ESD during the index procedure, which was not very difficult to do. It was quite straightforward, and then we closed it up with a few clips. So Andrew, what do you think this is?
So this is a resection specimen that you can see the tumor is occupying the central part of this slide, horizontal margin on both sides, normal mucosa. Deep margin of resection is at 6 o'clock, and the next slide will show us that this is gland-forming tumor, and it's transforming into mucinous adenocarcinoma. This is at the deep aspect of this specimen. And there is no budding, there is no high-grade morphology, and the margin, deeper margin, is on next slide, which is about 5 millimeters. It would be good to have a little bit of muscularis propria here, so I would give you the Kikuchi level, but that wasn't your intention to do it.
No, yeah, we could see some other organs.
I think it's probably at least SM2, if not SM3. But there is something else. Next slide. First of all, it's probably not very obvious, but if you could point to muscularis mucosa on the right-hand side of the picture, yes. And there is a slightly in the middle of this, there is a focus. Yes, this one. This is lymphovascular invasion, which will be better shown on next picture. So this is tumor sitting in the lymphatics in muscularis mucosa. And we know that muscularis mucosa is part of mucosa. That's different. This is invasive tumor SM2, SM3. In addition, we have mismatch repair deficiency. This is staining for MLH1. And in summary, so this is PT1A. Depth of invasion was measured as 3 millimeters. Width of the tumor is quite substantial. It's 11 millimeters. Deep resection line is close, but it's free. There is lymphovascular invasion present. So this patient, this tumor has a significant risk of nodal metastasis.
So I think we put this up at the MDT with Liz chairs, and the risk was put at about 20%. But given would you agree with that, Andrew?
Usually the risk would be about 20%, but the presence of vascular invasion is actually probably shifting it a little bit.
Higher than that.
Higher.
Unfortunately, the patient does have other things happening, so we have elected for now to monitor the patient closely. So this falls obviously outside the criteria of curative endoscopic resection, given that the depth of invasion is more than 1,000 micrometers, and of course you've got lymph vascular invasion. So this is another case, positive FOBT. A biopsy which was performed was a TVA with low-grade dysplasia. The patient had an MR and a CT, which were unremarkable, and the lesion was sitting in the proximal sigmoid, if I'm not mistaken. So you can see a granular lesion, a flat 2A type granular lesion. A little bit of a video showing that that's part of the lesion there, but it was circumferential in certain segments. So we decided to perform a piecemeal EMR in this setting, and that is the sort of area at the end where we also applied some snare soft coagulation. Try to leave bits of normal mucosa in between. This is not a complete STSE because there are some areas which we had not quite burnt, but that was the best image we had at the end. Obviously, with a circumferential sort of lesion like that, they do come back with strictures. So what we preemptively try to do in these patients is to provide them with a steroid enema and bring these patients back at a 2 to 4 weeks duration to preemptively dilate the area. And then this is the view at 8 weeks, which was looking much better. This is all just granulation tissue. It's not JNET 3 or 4 or whatever, because you can't really assess that it's not a polyp. We took biopsies, targeted biopsies from the so-called stricture, and that's come back as just granulation tissue. So the pathology was obviously submitted before the patient came back at 4 or 8 weeks.
So this is one of the sections from this piecemeal EMR. A lot of tissue for examination because the lesion was big. This slide shows you the background lesion, which was traditional serrated adenoma. Very nice finger-like projection with serration and serrated crypt profiles on the left-hand side. Vascularis mucosa and submucosa are included in many of these specimens, and it's orderly. Next slide, we will see that is clearly dysplastic. It's pretty blue. So this is probably somewhere between low and high-grade dysplasia, but in other areas, like in this one, it's clearly high-grade dysplasia. The pink crypts, that's just to show you the contrast between non-dysplastic or minimally dysplastic and high-grade dysplastic epithelium. In following slides, you can see that there is a quite complex architecture. Now, it doesn't resemble of your traditional serrated adenoma. There is a gland fusion in the lumina of those glands. You can see necrotic material. So this is what we decided to call it as focus of intramucosal adenocarcinoma. This term is not used by everyone, but in our institution we're using this. Now, that focus was only on the surface, far away from muscularis mucosa, so there was no, in our assessment, no chance of getting into the lymphatics in the muscularis mucosa. So, traditional serrated adenoma with high-grade dysplasia and focal intramucosal adenocarcinoma.
All right, thank you. So we have elected to simply survey this patient. Obviously, she's coming back for another reassessment in a couple of months' time, and hopefully things would be sorted by then. Strictures are less of a problem in the colon compared to the upper GI, especially in the esophagus, but equally important. So it's good to bring these patients back for preemptive reassessment and dilatation if necessary until the inflammation and the mucosa starts healing. So that's a good strategy to use, because for the first 2 weeks after the resection, circumferentially that is, these patients remain really well. Only later on, once they start developing a stricture, they run into trouble. This is another case of a patient who has had this so-called ascending colon polyp. There were biopsies which were taken, and it came back as a granular cell tumor. So it's a bit tricky. It's in the ascending colon, and the lesion measured about maybe 13 to 14 mm in size. I just wonder whether Niroshan or Honchi can comment on what would you do with this sort of lesion. The patient's well, patient's 60 plus, I think, and biopsies were granular cell tumor.
I think there's a couple of options. I think it's in kind of like the upper limit of the FTRD kit. You can do that as well, but I think it looks amenable for straightforward ESD lifting at run.
Right.
Yeah, I agree. I might choose to do an ESD rather than FTRD in this case.
Akira?
It's hard to decide, but I would go for ESD, I think, still.
So they all yes. So I was hoping Andrew can tell us with pathology. So maybe you can answer that, Andrew. The malignant potential.
So granular cell tumors, most of them are benign. When they're getting bigger, small proportion of them, probably under 2%, may behave in malignant fashion. Usually, when they are clearly malignant, they in metastatic sites, and if you have histology from them, they will have necrosis and mitosis and so on. But on biopsy, if you biopsy this, it's unlikely that we can actually predict the behavior and nature of this particular tumor.
So I guess the options were leave it alone, try to resect it endoscopically, or submit the patient to surgery. We had discussed this at the MDT, and rightfully, or not rightfully, tried to take this off using the FDRD technique. It actually was maybe measuring about, at the cusp of the full thickness resection device, so about 14 to 15 millimeters. But this was as hard as a rock, right? So we could not pull it into the cap. So in contrast to adenomatous type tissue, they're normally quite loose on the bowel. But in this instance, because it's submucosal, we could not take it off. I'm not sure why this is not playing. So we had to remove the entire FDRD device. And I must say that we had an issue with the timing of this procedure. So we had to make a call whether to abandon it, to do an ESD, or to try to tackle it using a snare polypectomy technique. So I'm just, the video is not playing very well, but I felt that the lesion was moving quite well and freely off the abdominal, off the bowel wall. So we took it off with a snare technique, and obviously you can see that there's muscularis propria there. A bit of ooze which we just settled with the snare. And then what we then did was, so that was the end result. So it was moving quite freely. I must say that in retrospect, perhaps I should have attempted an ESD. The issue with this, as we discussed yesterday, is that timing was an issue. We didn't have much time on the list left, and we were running really late, which is not a good reason, but sometimes we probably have to abandon it if we feel that there's not enough time for the procedure. Anyway, the base was closed, lesion retrieved, and sent for histopathology.
So this lesion is centered into submucosa, luminal aspect on the left-hand side. The deep margin resection is clear here on the right-hand side. If we look at the surface of this lesion on next picture.
Next slide, yeah.
Yes, that's a little bit of erosion. It's probably biopsy related. You're lucky that you get tissue from forceps biopsy. Quite often those lesions are a little bit too deep and we don't have the tissue and we cannot tell you. In this case it was a little bit different. Next slide shows the characteristic feature of this tumor. So there is a very low nuclear atypia and abundant eosinophilic cytoplasm with kind of like a granules. If we look at that picture, on the left-hand side, this is Pars D stain, which shows you those granules staining with Pars D. Those granules are actually elements of myelin from Schwann cell, because this lesion is neural in origin. Initially was described as granular cell myoblastoma, and there was suggestion that were from muscle. But they quite often occur in tongue or head and neck, anywhere. S100 is positive here, and SOX10, which is nuclear transcription factor, regulating differentiation in neural and melanocytic tissue, confirms the diagnosis. granular cell tumor. The other name, granular cell schwannoma, probably better reflecting where this lesion coming from.
So with that tissue, right, Andrew, so what's the risk of metastasis? Now you've got the entire thing.
We cannot say that.
And how would we follow up this patient?
Well, if the lesion is completely resected, that's probably the best option. And as I said, only a small proportion of those tumors are proven to be behaving in a sinister manner, and the only definite sign of this is the presence of metastasis.
Okay. I'll just quickly go through these lesions, but this was another lesion which is in the rectum, which was, we had the benefit of having biopsies, or maybe sort of a partially resected lesion which has healed over, but we do sometimes see these sort of lesions as well. We had the advantage of having biopsies, and so we performed an ESD.
So again, this lesion is mainly in submucosa, but in the left upper corner you can see it's actually extending into the mucosa, which is attenuated, still intact. So this is neuroendocrine tumor, well-differentiated neuroendocrine tumor in past rectal carcinoid. Deep margin on the right-hand side is clear, a little bit higher. It's much closer, but there is no transection through the lesional tissue. Classical histological pattern, kind of trabecular solid nested growth pattern, neuroendocrine differentiation confirmed by synaptophysin, and grading of the lesion is done on the basis of Chi67, which is here less than 3%. So for rectal ESD, for management purposes, each report should include size of the lesion, submucosal depth of invasion. Here we know it was only submucosa. Grade, presence of vascular invasion, none in this case. Margin freeze, and also if there was main muscle invasion, because that changes T-stage, and management. We didn't have muscularis propria, margins were clear, so that's it.
Okay, and this is just another example of how common these things are. So they're assumed to be hyperplastic in nature, they're removed, and then when histology comes back, somewhat there's the neuroendocrine component to it, so it sometimes gets quite tricky to remove them, especially if there's also sometimes there's tattoo underneath and all sorts of things which makes it a bit tricky. So don't disregard neuroendocrine lesions in the rectum. They kind of look like hyperplastic polyps, but they've got this yellowish discoloration. And last case for Andrew, this is a large polyp which was referred for an ESD, which we did not perform. So we looked at it very carefully, and I found that the pits were slightly larger than the surroundings, but not in keeping with any JNET type classification. It just looked quite engorged and quite, for want of a better word, prolapsed.
Yes, so this is rectal mucosal prolapse. For us, it's very simple diagnosis. You look at the lesion, there is no adenoma, there is no dysplasia, there may be serrated crypt profile presence, and more importantly, you see those smooth muscles coming out from muscularis mucosal and getting into the subepithelial subepithelial plane, just under the surface epithelium. Next slide will show the same. In next slide, if you can. Okay, so those are smooth muscles, and it doesn't pose problems to us, but from my experience, it's quite often those cases coming with suspicious diagnosis of adenoma, high-grade dysplasia, serrated adenoma, and not uncommonly, even cancer. So it's probably great mimicker of more sinister processes.
Right, so that was the final diagnosis. We didn't do anything for the patient, of course, and asked her to maybe not strain so much when she passes motions. So I think we won't go to case 9. We're running slightly late for time. So thanks very much, Andrew, for your expert insight.
Next, I would like to introduce Dr. Cameron Bell, who's actually been introduced earlier today, so I'll make this one brief. Dr. Bell is a senior consultant at Royal North Shore Hospital in Sydney and has an active interest in colon cancer, and will present the 2025 colonoscopy clinical care standards for us today. Thank you.
Thank you. Thanks again, Raj, and lovely to be here. I'm sorry, I said before, from sublime to ridiculous, this is banal, but Raj asked me to update you on what's new in these clinical care standards. So these are the updated version from the initial ones in 2018. Gregor, I think there was a minor modification in 21 or 22, but these were re-evaluated, and I'm not going to go through them in huge detail, but there are 9 standards if you're not aware of them, and each standard has an opening remark, and then there are interpretations of what that means for the patient, for the clinician, and for the health service undertaking the colonoscopy. And they carry some clout because the Safety and Quality Commission, these things, courtesy of their affiliation with the Safety and Quality Commission, can be part of accreditation. So it's not just a lack of recertification for your colonoscopies that can get your unit and potentially your hospital closed, but if your hospital is not making an effort in this direction, the accreditors look askance. So we, nurses, doctors, surgeons, colonoscopists, think of we're the burger in the sandwich, but the new things in this set of guidelines are really about the buns. We're more interested in the burger, but the changes have been mainly in the buns. I'll mention them at the end, but there were some explicit statements for the first time about Aboriginal and Torres Strait Islander treatment in this cancer prevention process in terms of cultural appropriateness and safety. And in the buns, the most enhancements focused on the before and after, with a concentration, really for the first time, on equipment quality, photo documentation, electronic result upload, result sharing, and communication. So some of it I'm going to skip through quite quickly, including everything related to anaesthesia and sedation. So each slide, the bit at the top is the statement, and none of these changed. So I'm not going to waste your time by going through them again, but the statement one regards initial assessment and referral. The new stuff is relating to that communication beforehand. So the referrer, the primary health practitioner, the GP, is required to evaluate the likelihood that the patient will benefit from the scope. They're supposed to inform about costs and what to expect, and I thought that was interesting and odd. If open access is an option for a patient and their GP, the GP needs to consider whether that's suitable. Both the referrer and the receiver of the referral need to be aware of the guidelines pertinent to this in terms of qualification for colonoscopy or indication for colonoscopy, both with regard to the surveillance colonoscopy guidelines that were reviewed in 2019 and also in the revision of part of the total big picture colorectal cancer guidelines in 2023 regarding what is now regarded as a moderate or substantially increased risk of colorectal cancer based on family history sufficient to warrant screening by colonoscopy, not fecal occult blood test. And we, as colonoscopists and colonoscopy services, are exhorted to ensure protocols are in place to review the referral, determine its appropriateness, and to prevent stuff-ups to provide required referral information, preferably using a standardised template. Nothing's more annoying than getting a bulky referral that's got cholesterol and HbA1c and no information at all about previous polyps or histology. So moving along, this is standard 2 is appropriate and timely colonoscopy. Nothing's changed again. For the rest of this, I'm just going to concentrate on the clinicians with, when we come to 7, the hospital. So we're invited to consider disease epidemiology and whether the scope will influence management as a result, and we're obliged to ensure that triaging and scheduling is in place according to locally approved triage criteria, which for us in New South Wales in terms of symptoms is a dog's breakfast. In terms of informed decision making, the clinicians should now specifically mention splenic injury amongst potential complications, and it's specified that the discussion of adverse events, risks and benefits, pros and cons, if you like, to the patient should be individualised. As Gregor said, you've got to split your prep, but that's not new, and if you're not splitting your prep, and I were an accreditor, I'd fail your service. But the new thing in these is that it's specified that the patient have a contact if things are going wrong or if they're unclear about what to do. And the new thing since 2018 is that we specifically need to ask not just about not just about anticoagulants, etc., but also the use of GLP-1 and agonists. In terms of sedation, I'm going to talk about this because no one in the room's interested. In terms of clinicians, the statement, as I said before, hasn't changed a whit, and there's not really much anything new for colonoscopists apart from the recertification requirements, which, correct me if I'm wrong, Gregor, but they haven't changed since they were introduced. But I'm assured that the 25% and 4% ADR and SLDR benchmark or thresholds will be reviewed and probably revised upwards. In terms of 7, there's a bit of stuff here. In terms of the procedure, not only are we expected to comment on the prep, but we're asked to use a validated tool. I think most people use the Boston bowel prep score, and we're also required to report patients who've come from a positive bowel cancer screening program test to upload their information to the National Cancer Screening Registry as soon as possible, and I have to admit that sometimes I'm a bit lax there. The bit for us, though, there was an enhancement here in terms of the equipment used to perform the colonoscopy being of adequate quality, to ensure safe and accurate visualisation of the bowel with photo documentation. Any adjunctive technology should be used in an assistive sort of manner and according to local policy. And clinicians, of course, remain accountable for safe and high-quality care regardless of what tech they use, and for ensuring that their practice meets professional obligations. Now, when it comes to the hospital, none of this first stuff has changed, but in terms of what's required for the hospital, there's a bit more being specified in terms of what the hospital is expected to do, and it leaves out the bit that I think they needed to do. So the hospital's supposed to establish procedures to collect and periodically monitor data, to review and share organisation and clinician-level data findings as part of quality monitoring, to review list sizes periodically as part of procedures to monitor the quality of colonoscopies at the healthcare service, and to ensure a process is in place to act promptly and effectively on any results suggesting substandard quality. And this is where I think the process fell down, and I was part of it, but I just don't think this is good enough. What administrator, private or public, is going to be able to interpret that and say, well, hang on, 15 colons in a morning is probably not quality? I'm not going to say any more about it, but I think it's obscene. And this gives you some clout in approaching your service to say, listen, the standard of equipment that I need needs to be safe and consistent with high quality performance for visualisation and photo documentation. You can't be writing handwritten reports anymore. And so in some instances this will give you a little bit of clout when you go to your administrators. Discharge, there's a qualification here about if no responsible adult is available, the sedationist/anaesthetist can exercise their judgment in deciding alternative disposal, excluding driving and public transport, and considering whether admission to hospital afterwards is appropriate. And just finally, reporting and follow-up. This wasn't specifically mentioned last time, but if the indication for the procedure was symptomatic and hasn't been explained by the result, that further investigation or treatment is required and should be specified. And again here, upload the report and results to the patient's healthcare record, My Health, the National Cancer Screening Registry, and full communication with all clinicians involved or interested in that report. Now, I'll finish up, but it would be remiss not to mention the explicit new considerations for cultural safety and equity relating to First Australians. All of these are designed to promote equitable access to care, considering or taking into consideration cultural safety and equity, recognising potential barriers to access like language, remote location and travel. Now, this is not going to be relevant to some people as much as it is to others, but in South Australia and the adjacent Northern Territory and parts of WA, I'm sure this is more relevant than it is to me and Gregor in metropolitan Sydney and Melbourne. But nevertheless, we should be aware of this. We should be aware of the potential stigma associated with the procedure of the bowel prep and with the bowel cancer diagnosis, and we should be more inclusive in terms of involving ATSI health officers, the patient's family and their kin and the community, depending on the individual's wish. So I will stop there. I didn't mean to rush that last bit, but it is an important new element to the clinical care standard. Thank you. What? I think we'll move on. Good, excellent.
Can I just ask Cam just one question? Oh. Sorry. So, do patients? Do we need to consent patients before they?
Yeah, Liz asked me this yesterday, and so I rang Anne, who's the big boss at the Safety and Quality Commission, and asked her specifically what level of clout these have. Like an institution's management of, I think, delirium and something else she mentioned, this does carry some sort of weight, but to an extent these are aspirational, and any deviation from this would be noted and considered, and in the situation we discussed yesterday, that would be allowable. I mean, high-quality procedures are great, but quantity needs to come into it at some stage, as long as they're not super rushed.
Thank you. I've got the privilege of introducing Ned Young. Ned Young is a gastroenterologist here at the Lowell Mac. I'm sure he needs no introduction to most of you. He's got expertise in both endoscopic imaging, advanced resection techniques, as well as inflammatory bowel disease and IUS, and he's here today to talk to us about IBD, colitis, dysplasia, and intestinal ultrasound. Thanks, Ned.
So thanks, everyone, and thanks, Prof, for the opportunity to speak today. I've been asked to speak on three topics that kind of link endoscopy and inflammatory bowel disease, which is quite a lot to get through, so I'll get straight into it. The first thing I was asked to look at is to provide a simple, I suppose, overview of endoscopic scoring systems and disease activity. And I'd like to start by endorsing the use of the UCIS as opposed to Mayo score in ulcerative colitis for this reason. So it does have high intra and inter-observer reliability, but most importantly, it's a far more specific and precise tool. If you look at the patient on the left, I'm not sure if that mouse is actually projecting up on the screen, is it? Yes. Sorry, if you look at the patient on the left, you can see Mayo 3 with ulcers, but UCIS 8 with significant intraluminal bleeding, total obliteration of vascular pattern and deep ulcers, as compared to the patient on the right, still Mayo 3 with these superficial ulcers here, but scoring a UCIS score of obliteration of vascular pattern, no bleeding, and only superficial ulcers. This matters because in the acute severe UC setting, it accurately predicts the need for rescue therapy and stratifies patients to their risk of requiring emergency colectomy. So the patient on the right with a UCIS score of less than 5 would have had a less than 30% chance of needing rescue therapy, whereas the patient on the left would have had an up to 80% or more chance of receiving rescue therapy. Patient on the right would have had a less than 10% chance of colectomy versus at least 30 or more percent for the patient, probably higher on the patient on the left. The score is obviously more complicated than the Mayo score, but if what we have here at Polyp is just laminated posters of the UCIS on the wall of the endoscopy suite, which makes it fairly straightforward to report. In the interest of time, I won't go through this in great detail, but you'll just have to believe me that it also correlates with the specificity and precision of being able to monitor disease severity over time, correlates with longer-term outcomes in terms of colectomy-free and relapse-free survival. In Crohn's disease, the two most commonly reported scores are the SES-CD score and the Rutgers score for post-operative disease activity. So starting with the SES-CD, I won't go through the scoring system in detail because the spoiler is I don't use it and don't know how much role it has necessarily outside of the research setting, but happy to hear otherwise if people don't agree with that. It's a fairly complex tool. Even with a poster on the wall, it can be quite difficult to interpret some of these extent of ulcerated versus affected surface. It hasn't really been validated against any longer-term prediction of disease progression or long-term outcomes. It also doesn't include key factors such as the length of the disease the length of affected segment, as well as the depth of ulcers, which are important predictors of longer-term outcomes. And then importantly, you can have very mild but very diffuse disease that can score similarly high on a SES-CD to very severe but focal disease, so it doesn't necessarily make a meaningful prediction of their longer-term outcome. To simplify it in Crohn's disease, these will be too small to read, but there is good evidence that targeting mucosal healing in Crohn's disease is, I think, most of what matters from an endoscopic perspective. This meta-analysis is probably the biggest volume of evidence on this. They had 11 studies. The majority of them defined mucosal healing in Crohn's as just the absence of ulcers, so that's fairly universally accepted as the target for mucosal healing. And those who achieved that at their first follow-up colonoscopy had higher rates of long-term clinical remission, increased disease-free surgery,
lost connection.
Can you speak without your slides then?
The graphs.
Surely you memorized it.
I can keep going. Oh, it's working.
There you go.
Hopefully that's going to come back. No. All right. So I'll keep going. They're too small to read anyway, so you just have to believe me. So yes, targeting absence of ulcers improves rates of long-term clinical remission, disease-free, surgery-free, disease control, and long-term mucosal healing also. For the RUT-GIT score, this is, as I said, a post-surgical score. It is very useful in the I0 and I1 context where these patients are considered not to have disease activity and don't need advanced therapies except in the prophylaxis setting. I3 and 4 is more severe active disease over the pre-anastomotic ileum and clearly needs advanced therapy or surgery. The I2 group, it's still a bit unclear as to what should be done with that group. They've modified the RUT-GIT score to include I2A and I2B, trying to differentiate between anastomotic-only lesions compared to lesions in the upstream ileum. And you can see that when that happened, there was an increased risk of endoscopic progression and surgical recurrence in those with I2B, so disease in the upstream ileum. However, subsequently, prospective evidence in the American Journal of Gastro kind of went away from the RUT-GIT score and started scoring a purely anastomotic score versus ileal score. And you can hopefully see the green and blue lines at the top of that graph are the variable anastomotic scores, which had no influence on their long-term clinical recurrence-free survival, as compared to the bottom lines, which is anyone with active disease in the pre-anastomotic ileum. So I think it may be that in the long term we start scoring more on whether they have disease in the ileum as opposed to at the anastomosis. It then becomes even less clear what to do about that group with isolated disease at the anastomosis, because there's a hypothesis about this being ischemic and not necessarily Crohn's related, and so not obviously requiring advanced therapies, but those with ulcers on the anastomosis are at higher risk of surgical recurrence in the long term, plus there's almost never ulcers over non-IBD related anastomoses, so there probably is some disease related component there. So I think the RUT-GIT score, I0, I1 and I3, 4 is useful. I2 is still, I think, quite unclear. So the next point is looking at dysplasia detection. This has been touched on a little bit with chromoendoscopy, which has become more controversial as endoscopes have advanced further and guidelines are getting a bit less clear on whether they're recommending dye spray chromoendoscopy. So I wanted to look at that in a bit more detail. So the largest study is this meta-analysis of randomized controlled trials from the American Journal of Gastro, where they had almost 1,000 patients comparing dye-based chromo versus high-definition white light. And they found almost twice dysplasia detection with chromoendoscopy versus white light. There was a trend, but no statistical significance for high-grade dysplasia, but I suspect it probably reflects the study being underpowered despite being so large, just because that's a rare phenomenon. The theory about, as scopes have advanced further, is that the ongoing benefit for chromoendoscopy may actually just be additional time of inspection with the process of going through and systematically spraying the mucosa. And so this group, the Helios trial, had more than 500 patients randomised to segmental reinspection with high-definition white light versus chromoendoscopy, and interestingly found no difference between the two. There was a trend, probably numerically, with more dysplasia in the chromo group, which is hard to know what to do with, but they did include various different endoscopes, including the HQ190 scopes, and anecdotally using the 1500 scopes versus 190 scopes for IBD surveillance, I think is quite a stark contrast, and I think it'll be interesting with time. I think the high definition white light group will come higher and higher, and again, I'd be keen to hear what people say on that. Virtual chromoendoscopy, or MBI, most commonly initially was not very successful with first generation MBI in IBD. was also not very successful in general screening in colonoscopic surveillance, and is hampered by a few limitations that have hopefully looked like been addressed with second-generation MBI. It's just too early, I think, to have much evidence about that. There was one echo abstract last year where they had almost 200 patients with chroma or NBI and found no difference in dysplasia detection, but that's probably still developing, I think. Finally, for dysplasia detection, artificial intelligence, I think, is clearly going to be a big thing in IBD dysplasia because it's so subtle and hard to detect. Actually, is a lot further along than I realised with a study from Gut a couple of years ago now, where they actually validated their AI model in 30 real-time colonoscopies and had pretty impressively high dysplasia detection. So I think that's probably closer than I thought, but still not here yet. Finally, touching on intestinal ultrasound, obviously has a lot of applications, but linking it in with intervention, the main thing is in looking at small bowel stricture and Crohn's disease. And the biggest body of evidence about the accuracy of this came from this quite impressive study from Hyderabad published in the American Journal in 2025, where they had more than 400 patients with small bowel Crohn's. They did an IUS and then a small intestinal contrast IUS, so they had 500 mils of PEG before the ultrasound, compared it to a CTE or MRE within 24 to 48 hours. In this cohort, interestingly, despite being a fairly severe small bowel Crohn's cohort, only 15% were on biologics, so quite different to probably what we would have here, and may explain how they found so much good pathology in the study. The main evidence comes from the top right on that graph. You can see with IUS alone, very high accuracy for disease activity, extent, abscess, fistula. Stricture was high, but did have an incremental benefit with the small intestinal contrast. The small intestinal contrast ultrasound and MRE were very well correlated for bowel wall thickness and disease length. The mean difference for bowel wall thickness was 0.7 millimetres, which is incredible. The mean difference for stricture length was not as impressive a number at 2.8 to 3 centimetres when you think about 5 centimetres being the cutoff for endoscopic dilation generally. But that was including all comers for disease length, and on ultrasound, if the stricture is extending beyond the window of the ultrasound, which is usually about 7 centimetres, it can get probably less accurate guessing along across multiple windows. So when it's determining suitability for endoscopic dilatation, the accuracy is higher, and that was borne out in that study as well. The other thing I wanted to highlight was this Stratton randomised trial, which took almost 80 patients with ileal Crohn's strictures and did an IUS and MRE at baseline and 12 months, and they had various formulations of adalimumab in the meantime. The thing I wanted to show was that MRE overestimated stricture length at baseline, so the mean stricture length on MRE was 6 centimetres, on IUS was 4, and endoscopically 1.8, and so if overestimating stricture length, you would be potentially excluding people from endoscopic dilatation based on potentially inaccurate MR. I think anecdotally, we have quite a few patients where the MR will suggest that disease segment is longer, and on an ultrasound you can see ongoing thickened bowel wall, but you can see the lumen opening up over a shorter stricture, so you can understand how if it's not opening up at the exact time of the MRI, it doesn't necessarily get picked up. And I think that has important implications for endoscopic therapy. So depending on how I'm going for time, I've got a couple of IOS videos just to show how it can kind of influence management. Hopefully that's playing here. So you can see here a scan. This is a young girl that was in actually at the Lowell McEwen just recently, who presented with obstructive symptoms and pain, has a long history of ileal Crohn's and a previous ileocecal resection and anastomosis. On her CT, she had a 15 to 20 centimetre segment of inflamed ileum with upstream dilatation suggesting obstruction. By the time this scan was done, she'd been in hospital for a week on steroids, has a number of other social factors, and after a week of steroids was still in extreme pain, had a very distended abdomen, in her mind was not getting better with steroids and needed surgical management. So we did the ultrasound to have a look and correlate that. And on the ultrasound, hopefully, you can see there is some prominence of the pre-stricture ileum there. This is coming through into the stricture itself at the end of the loop. And you can see the bowel wall thickness is actually not overly thick. There's no Doppler in this, but there was not really any Doppler within that segment. So definitely not accounting for her pain and her abdominal distension. So just looking on at some of the measurements, her upstream ileum was 1.6 centimetres in diameter, with 2.5 generally being the cutoff for pre-stenotic dilatation. The diameter of the stricture, the luminal diameter, was about 0.5 centimetre, so tight, but definitely not a pinhole stricture. And the stricture itself extended over 3 or 4 centimetres, so it was potentially amenable to endoscopic dilatation down the track. We then looked at the rest of her bowel, and this is, I wasn't aware that the expert in constipation ultrasound was going to be present, but this is a ultrasound of her right colon, which you can see significant shadowing. You can see the diameter extending well beyond the field of the ultrasound. So she had a massively dilated or fecally loaded colon. And I think what had happened is her ileal disease had responded to the steroids, and with the antiemetics and opioids that she had from her pain, she'd become massively fecally loaded, got better with glycoprep and went home, and in theory would be amenable for an endoscopic dilatation down the track for her stricture. If I have time for 20 seconds more. So this is a second case, just to illustrate cases where endoscopic dilatation wouldn't be suitable. So this was a young guy who had his first presentation of ileal Crohn's, with a CT showing about a 10 or 15 centimetre segment of inflamed ileum and some pre-stenotic dilatation. He was systemically well, not febrile, inflammatory markers were not too bad, but on this ultrasound, in deciding his longer-term treatment path, you can see, if my mouse is projecting, yes, you can see in the deeper wall of the ileum here, you can see this deep fissuring, kind of loss of all of the wall here, and then underneath here, big phlegmon and collection. So rather than aggressive immunosuppression and potential dilatation down the track, he had antibiotics and EN and didn't respond to that, and so ended up having an upfront resection of his disease segment. So to summarise, I think I fully endorse the use of the UCIS score. Personally, I don't use the SCS-CD score, and I think probably its use is mostly in the research setting. The RUT-GIT score, I think, has benefit, but definitely some weaknesses. Chromoendoscopy is still officially endorsed generally, but I think the segmental reinspection evidence is quite reassuring, and personally, I'm now trying to get a 1500 scope and doing segmental reinspection with MBI on the second pass, and I would be interested to hear what others are doing. And AI will clearly eventually come in, and I think hopefully have shown how intestinal ultrasound can help to evaluate strictures and guide endoscopic or other therapy.
Thank you, Ned. Are there questions, Raj?
No questions, but happy for you to...
I just was going to ask one. You've talked about dysplasia surveillance and the controversy surrounding chromo versus white light, MBI. What about biopsies?
I think that you mean like random surveillance biopsies?
Versus targeted, and what's your approach?
Yeah. I don't do any random surveillance biopsies. I only do... Well, sorry, I do disease monitoring biopsies, so like just biopsies in each segment, but not any dysplasia surveillance biopsies. I think my understanding is since high-definition white light even has come in, that the incremental yield of doing random non-targeted surveillance biopsies is so low. Yeah. Personally, my impression on chromo and random biopsies with how good the scopes are getting now is that I find that all of those things actually distract from the time that I'm spending looking at mucosa, and so I try to minimise the time I'm doing anything else apart from looking for lesions.
Any comments, Cameron?
Yeah, could I just ask, has any form of dysplasia surveillance, however you're doing it, has any of it been shown to have any impact at all on cancer development Because up until a couple of years ago, people were arguing about this or that, and none of it made any long-term difference.
I don't have the answer to that question. Yeah.
I don't know either, but rates of cancer are dropping, I suppose.
Yeah.
But that
Yeah.
probably relates to therapy more so than our sort of surveillance tools. But it's a good point. Any other questions? Hamish?
Thanks, Ned. You had to cover a lot, and I probably missed some of it. This might be a silly question. When you are looking at dysplasia surveillance methodologies, and then you are quoting sensitivity and specificities, are you comparing that to a gold standard, which is random biopsies, colectomy, or subsequent cancer development in a longitudinal sense? I'm just...
So most of the studies look at a dysplasia detection rate as opposed to like a missed rate in any form. And so if you take the chromo group and the high definition white light group, for example, the chromo group having 30% versus white light group having 28% and implying an element of miss rate from one to the other, but I don't think anyone's done, Yeah. Any studies with then random biopsies, the incremental benefit of random biopsies being so small that it's not added additional benefit for that. I don't know that anyone's done a look at colectomy specimen study.
Maybe it would be very ethical.
Yeah.
If unneeded.
Thanks. Thank you, Ned. We'll let you off the hook there. Thank you very much. So I'd next like to introduce another person who needs no introduction from the Royal McEwen Hospital, Liz Murphy. She's a colorectal surgeon. She's led the colorectal unit here at the Lowell Mac since 2012. She's an active academic and has great expertise and interest in proctology. And so we're looking forward to this. Thanks, Liz.
Thank you. Thanks, Raj, for asking me to speak about this. It's actually quite a pleasure for a colorectal surgeon to talk to gastroenterologists about proctology. So I could have really called this talk what your colorectal surgeon would like you to know about proctology, because that's really what it's all about. So I guess what I hope out of this is that things you see, obviously you may not necessarily treat them yourself, but you can tell your patients what they need and what might happen for them if you do see something and you diagnose it, either during a consultation or a colonoscopy. Oh, wrong way. No, what are we doing? Okay, so I'm going to talk about a few different proctological conditions, and we are going to veer a little bit up into the rectum as well as the anus. Probably each of these I could talk for about 15 minutes on each, so it's going to be a pretty quick whip around, but I'm certainly happy to ask any questions at the end. So obviously hemorrhoids, fissures, abscesses, fistulas, not really going to go into Crohn's because we don't have time. Just mention rectal prolapse and a little bit about AIN and warts, and obviously how to avoid SCC and a bit on pruritus ani. So this is obviously the anatomy we're looking at. I'm sure everyone here is familiar with this, and probably the most important bit to look at on the slide is the last sort of 2.5 to 4 centimetres, which is the anal canal. And around the anal canal, as we know, we've got an internal sphincter and an external sphincter, and quite importantly, between those two sphincters and the intersphincteric space are sort of about 5 to 10 different anal glands around the anal canal, and they're certainly responsible for some of the pathology that we're going to talk about today. So hemorrhoids, the picture on the top of the slide is really what you guys are pretty familiar with when you retroflex your colonoscope at the end of your colonoscopy. But we see them in lots of other different ways. And when I talk to patients about hemorrhoids, I actually say to them that these vascular cushions in the anal canal are actually really part of your normal anatomy. And everybody has some hemorrhoidal tissue. It's just when it gets big and becomes symptomatic that they're problematic. So certainly not all hemorrhoids need treatment. The way we classify them is really as whether they are internal when they're remaining within the anal canal, or whether they're coming to the outside, and then that's really an external component of an internal hemorrhoid. And I'll talk a little bit about the sort of classical description of what we used to call external hemorrhoid, which is really now a perianal hematoma towards the end. So obviously some pretty ugly hemorrhoids at the bottom, and we hopefully don't get to that point. But this is really the classification that we use for hemorrhoids. So we have grade 1, which are hemorrhoids which are symptomatic, usually bleeding, usually not painful, but will usually remain within the anal canal. We have the grade 2, which is those which prolapse when someone strains, but then will reduce spontaneously. Grade 3, where they need manual reduction, and grade 4, where they can't be reduced. And these are important things to ask your patients because they help you determine how to treat your hemorrhoids. grade 1 and grade 2 hemorrhoids, if they're symptomatic, can be treated quite easily, but the grade 3 and 4 ones are more challenging. So obviously they present with bleeding. Many patients will present with an anal fissure with pain and bleeding and say they've got hemorrhoids, but in actual fact, when they have pain, it's much more likely to be an anal fissure. So often patients obviously will describe a lump, describe bleeding, but one of the symptoms that often can give you a clue that, you know, hemorrhoids are going to be a bit of a problem is the itchiness, because when the hemorrhoids secrete mucus, that causes itchiness. And certainly when we talk about pruritus ani a little bit later on, that's often caused by hemorrhoids. So as I said, we treat them based on the symptoms and on their size, and always really important to talk about conservative measures first, which is, I'm sure I'm preaching to the converted here. Really important to boost your fibre, and also really important to make sure patients have really good toileting habits, because certainly straining, staying on the toilet for too long, using your phone or reading a book or a magazine on the toilet, all these sorts of things will improve your chances of getting increase your chances of getting hemorrhoids. And you know, sometimes it's worthwhile giving people some information on that, and even in some cases getting them off to see a physio to help with that if you think it's a big problem. We do know that many people will improve with conservative measures. If you can improve their toileting, improve their constipation and their diet, they won't actually need treatment for their hemorrhoids, which is obviously, you know, saves us all a lot of work. If they don't improve their conservative treatment, then the next sort of thing we move into are fixation procedures. And sort of historically, the first thing people would do is inject hemorrhoids with phenol and almond oil. And I know quite a few gastroenterologists do this. I think probably a better fixation procedure. So when we talk about fixation, what we want to do is obviously reduce the size of the hemorrhoid, but we also want to fix the mucosa to the submucosa so the hemorrhoid doesn't prolapse, which is often what people are worried about. Hemorrhoidal banding is actually a much more effective way of doing this than actual injection. So I'd certainly recommend, if there are any gastroenterologists who don't know how to band, certainly ask your friendly colorectal surgeon, and hopefully they'll be very happy to help you. We certainly are here at the Lal McEwen. There's nothing worse for patients coming for a colonoscopy for PR bleeding when the only thing they have is hemorrhoids and their hemorrhoids don't get treated. And for us, we're just as busy as you guys, so we'd much rather you treated their hemorrhoids. You only get $15 for it in private practice. It's really not worth our while. We'd much prefer you did them. So if you need any help, please ask. Okay, hemorrhoid surgery. Occasionally we do try and avoid operating on them and doing an operation, because historically the operations are actually really painful, but certainly for those which fail to respond to conservative therapy and they're really symptomatic and they're really worrying the people, then you may need to do an operation. So the historical gold standard procedure for hemorrhoids is a hemorrhoidectomy, and it works really well, but it's incredibly painful. And people will often describe it as being one of the most painful things they've had, worse than childbirth. So we certainly have done lots of other things to try and make it better. We use different techniques, such as using an ultrasound dissector, using laser. But the reality is the operation is painful. It does work well, but patients are in for about a month of feeling uncomfortable. So some of the things that you might see around that we do sometimes to try and do a less painful procedure is Doppler-guided hemorrhoidal artery ligation, which you can see at the bottom in the middle of the slide. And with this, it's done under general anaesthetic as well, but we use an ultrasound probe in the anal canal to find the hemorrhoidal vessels, which we suture, and then we'll mucopexy, which means we sort of pull the hemorrhoid up into the anal canal with a suture. So this is not as effective as a formal hemorrhoidectomy in reducing your symptoms, but certainly is less painful. For people who have a lot of bleeding and aren't so worried about prolapse, this can be an option. Stapled hemorrhoidectomy, I just really mentioned to dismiss because we really don't use it very much anymore. You can still actually get the equipment that you use to do it, and it's the same sort of stapling device that we use for doing an anterior resection. Certainly it was very popular in Europe, but one of the issues with this is that there was an increased risk of recurrence compared to excisional hemorrhoidectomy, and there were episodes where people would have really quite intense urgency and even sepsis after the procedure, so I really don't do it anymore. So obviously strangulated internal thrombosed hemorrhoids, incredibly painful if you do see a patient with this. Basically, initially it's conservative therapy, so laxatives, pain relief, ice packs, but sometimes they will need a hemorrhoidectomy. And there is some evidence that if they are really bad, they probably will get better if you do a hemorrhoidectomy, though obviously sometimes can be difficult to organise. So external hemorrhoids, this is what confuses people a lot. A true external hemorrhoid is probably better known as a perianal hematoma, and it's actually from the external hemorrhoidal plexus, usually if someone strained or coughed, and one of these little vessels will burst and form a little hematoma under the perianal skin. If you do get these within the first 48 hours, they can be treated surgically quite effectively with the hematoma being evacuated. Beyond 2 days, then that's not likely to be effective as the actual hematoma is organising, and they'll just have to settle down, usually with the same sorts of therapies we use for the strangulated internal hemorrhoids. They do leave a residual skin tag. So anal fissure. As I said, often what people will have when they complain about hemorrhoids is that they've actually got an anal fissure. So it's a linear tear in the mucocutaneous lining of the anal canal. When it occurs acutely, it's usually due to constipation, though occasionally people can have it from quite profuse diarrhoea. And the classical position is in the posterior midline. This is the upside down sort of patient in prone at the top of the slide. Actually, no, it's not. It's the other way around. Sorry, they're actually in lithotomy. So it's usually at 6 o'clock. And that's the commonest place for an anal fissure to occur. Women postpartum, when they've had really difficult deliveries, can have anterior fissures. If you see someone who's got lots of fissures, then that should make you think that perhaps there's something else going on. So certainly it can be seen with STDs and certainly with HIV. So as I said, presenting with pain and bleeding. If people have acute fissure which isn't treated adequately, then they can get a chronic anal fissure, and that will have a classic triad of the fissure, where you can often see some internal anal sphincter fibres in the base. They often will have a skin tag on the outside and a hypertrophied anal papilla on the inside. So how do we treat these? 50% of these will get better just with conservative therapy if they're an acute fissure. So if you get people to crank up their water, fruit and veg fibre, 50% of them will actually get better without any other therapy. If they don't get better, then we would tend to use things like GTN or topical nitrates. And if you compare these in studies such as in the Cochrane review up on the slide, where they looked at many randomised controlled trials comparing topical nitrates to placebos, they are much more effective than a placebo. Certainly, obviously, you'd be doing all the other conservative therapies as well. The problem with topical nitrates, which as many of you will know, is that they give people quite severe headaches, and many people can't tolerate them. So instead of these, we often will use a calcium channel blocker, such as diltiazem or nifedipine. And to be honest with you, most colorectal surgeons would probably use a compounded ointment of nifedipine with local anaesthetic, and that can be super effective, particularly for people who've tried GTN already. Botox, we do use that quite a bit. It's a bit of a... no evidence, it's like an evidence-free zone, basically, Botox for anal fissures, and we don't really know how much to use. So the standard Botox bottle will have 100 units in it. Initially we'd start off with 10 or 20, now people are putting in 50 or 100 units of Botox, usually in different spots. There's no real sort of particular strategy which is used by everybody. Botox certainly is worthwhile using if somebody has failed with nitrates and other conservative measures. And there is actually some good evidence that if you keep on with the GTN or a calcium channel blocker and add in Botox, you actually have a better result. So it's certainly worth thinking about. Anal fissure surgery, some people don't respond to all of the things we've talked about, and then we need to do an operation. And the classic operation is a sphincterotomy, which is done under general anaesthetic, and we divide the internal sphincter. This has a small risk of incontinence, so for some people who are worried about incontinence, we might actually do a sort of like a plastic surgery, muco or anocutaneous flap, if then they are at too high risk of incontinence to have a sphincterotomy. Abscesses. Obviously, you guys probably see them a lot less than I do. Oh, I probably don't see them as much as some of the registrars here might. But certainly, they're usually due to one of those little glands I talked about earlier getting blocked off, much more common in Crohn's disease and with immunosuppression. And if they discharge to the skin, can also cause a fistula, which I'll talk about in a minute. So they can make people really unwell. People can really have septic shock from a deep abscess. What types of abscesses do we have? So basically, the really common one we see is type B, which is a subcutaneous abscess. You can have a large ischiorectal abscess, which is type A in the ischiorectal fossa. One of the ones which is really hard to diagnose are the intersphincteric abscesses, or C, where people will present with pain and some infective symptoms, but perhaps not with a lump on the outside. And then D, which is a submucosal abscess, less common. The way we treat these is not with antibiotics, it's with an operation, and usually will need to be done in theatre with a general anaesthetic. So fistulas, obviously a communication between the anorectum and the perianal skin. History of recurrent abscesses, purulent bloody discharge. Probably, as far as classifying fistulas, we get quite caught up in how we classify them, and sort of subcutaneous ones are very superficial. There isn't actually one on this slide, which is just really going underneath the sphincters. The more common one we see, as well as subcutaneous sphincters, subcutaneous fistulas, is a transsphincteric fistula going across the actual sphincter complex. Then there are the more complex ones, which are extrasphincteric and suprasphincteric, C and D. Probably for the benefit of this audience, it's probably better to think about the low, easy ones to treat and the high, complex ones to treat. So the low, easy ones to treat, we can treat usually with a fistulotomy, and the more complex ones need some more complicated procedures. This is sort of a quote from a very famous colorectal surgeon, and what he's reflecting really is that we find these really hard to treat. Many of the more complex operations we do have a fairly poor cure rate of about 60 to 70%, which is not great when you're a surgeon. So in anything in surgery where there are lots of different operations, it's usually because there is no perfect operation, and this is the same with anal fistula surgery. But what we really want to do is cure the fistula without making somebody incontinent. So sometimes we use aceton, which you can see on the picture here, which is a very fine little plastic tube. It keeps the fistula open, drains the pus, but doesn't actually deal with the problem definitively. A fistulotomy, which this picture is describing here, is where we actually divide the actual fistula tract. And this is very effective for people who have low fistulas, but we obviously need to be careful about their continence. An advancement flap is a more complicated operation where we raise a flap within the anal canal and we move it down and put it over the fistula to try and stop the fistula recurring and close the internal opening. And certainly this is quite probably has been one of the operations we use for more complex fistulas. Success rates are about 60 to 70%, but certainly some people can have worse continence afterwards. A lift procedure, which looks a bit complicated on this procedure, on this sort of picture, is really where we get in the intersphincteric plane and we excise the gland and the tract in the intersphincteric plane and then close the defect internally. And this again has about the same sort of cure rate as a advancement flap. Rectal prolapse, obviously, hopefully you won't see too many of these. If you do, really they need a referral to a surgeon. I think we saw a great slide in the MDT about somebody with solitary rectal ulcer syndrome or internal rectal prolapse. And I guess the symptoms to be cautious about, obviously this is easy to diagnose and obviously needs to see a surgeon. But if someone has a history of a lump that you can't see, they might have some obstructive defecation, bleeding and incontinence, then it's really important to think of perhaps a prolapse which isn't really coming to the outside yet, and that can certainly be referred to a colorectal surgeon. So just to finish, I've got a couple more slides. Some warts, obviously we do see them from time to time. They are a STD caused by HPV. If you see them, important to think about other things than other STDs. They can be associated with anal intraepithelial neoplasia, and we haven't got time to go into that today. But certainly in colorectal surgery, we are now looking at people who have AIN, which is in the picture on the bottom, where the tissue looks abnormal. It might be white, might be irregular, might feel hard. And certainly if you see this, you should really refer it to a colorectal surgeon because patients do have a risk, particularly if they have a high-grade AIN, of progressing to SCC down the track. And that is certainly what we're seeing on the slide at the moment. A horrible-looking anal cancer, we really would like to avoid these. So just last slide, pruritus ani. It's annoying to have to look after because it's hard to treat. Obviously primary pruritus ani is when we don't have a cause, secondary is when we've got a cause such as hemorrhoids or a skin condition. One of the most worrying things about this is people come and they've tried many different creams and ointments, and these are actually usually making it worse. So often the best thing you can tell people when they have this is to actually just try and keep the area clean and dry, and that's probably the most important thing. Obviously exclude things like worms. But certainly in some people who actually don't get better, there is some evidence that injecting methylene blue around the anal canal can actually improve their symptoms. So I'm done. Sorry, it was quite a quick whip around, but thank you. Any questions?
Thank you. These wonderful talk. Any questions? I think we'll leave it in peace because time's against us. I think we've got one last talk for this session. We've got a very well-known radiologist, Ramon Pathy. He works across both private and public. We all are grateful for Ramon's reports. They're very pedantic and nuanced. He himself has referred to himself as handsome in his bio. So we look forward to seeing him. Thanks, Ramon.
Oh, there you go. It's Ramon Radiology. Is it this? Ramon? Yeah.
Yeah.
Okay.
That's the one.
Thank you. Thanks.
What do I press to make it move? I just touch this thing.
Yeah, just
down arrow?
Yeah, down arrow. Oh, sorry, side arrow. Yeah, side arrow.
Side arrow?
Yeah.
Yeah. Cool. All right, I'll keep this brief because I'm painfully aware that I stand between you and lunch, so I don't want to get killed in a stampede. Thanks, Raj, for the opportunity to speak to you all. I'll keep this fairly straightforward. So Raj has asked me to give you a rundown on GI radiology and how it relates to the everyday endoscopist. For those of you who go to your MDTs and see a lot of images, this will all be pretty basic, but for those of you who don't or don't see a lot of images, there are a few pretty pictures in there. Nowhere near as graphic as Dr. Murphy's pictures, I've got to say. I'm sorry, but we'll do our best. So we'll start from top to bottom, and you can cut me off at 12 to 15 minutes or whenever you get too hungry. We'll see as far as we can go through the GIT. So starting at the top, this is what the endoscopist sees from the beginning. So the oral cavity and the pharynx, which is generally a muscular tube which gets in the way of you and the esophagus, where you can start to, do the work that you do, and then down to the stomach and duodenum, and then the jejunum and ileum, which are generally the sort of hidden area of the GIT for many, many decades, although that's changing, and then the colon from the reverse end. From the radiology aspect, yes, we do assess the oral cavity and the pharynx, but to be honest, it's better done by you guys or the ENT surgeons who can actually see it. We do see some pathologies in there. Esophagus, we've got a couple of modalities, mainly barium, which is, again, sort of a bit of a dying art, but does have some indications that are still primary, and CT. The stomach, again, in the old days we used to use barium, but there are further and further reduced indications for barium. We mainly use CT if we assess the stomach really at all. Duodenum, we've got barium, CT and CT angio for various indications. The jejunum, where we mainly use CTE and MRE, we'll go into that a bit later, and CT we can assess the colon. If we get time in the next 12 minutes, we'll show you some pictures. Right, pharynx and esophagus, I won't dwell on this too long because you're probably all hungry. Mainly we use barium as a primary method of assessing things, so either mucosal lesions, which is quite rare because it's better assessed clinically, but often the GPs will refer to us because it takes a long time to get a specialist appointment. We do see other things like diverticular, which is probably the main indication for doing upper sort of pharyngeal type barium, and also swallowing assessments where it is actually quite useful, mainly run by the speech pathologists. It's a nice picture of a zinca diverticulum in the pharynx, so that's the kind of thing that we sort of see. And when we're doing motility assessment, we're mainly looking for laryngeal penetration and aspiration. Esophagus, obviously you're a gastroenterologist, you're very familiar with the esophagus, so in more detail than I am. You obviously see it from the inside, but from a radiology perspective, the main areas where we can value add are the submucosal and the extrinsic areas. So we're not going to sort of teach you how to look for mucosal lesions, which obviously you see that a lot better than we do. This is what it looks like on a barium, so you've got an irregular circumferential stricture in the mid-esophagus there. And then we can also sometimes pick them up on CT as well, where we either stage or sometimes we do see them rarely as incidental findings. Just one quick note on barium. It's actually really hard to get barium these days, so I know a lot of people still refer for barium studies, but it's actually not bloody commercially available. In a lot of cases, it is quite limited, and the problem is that we have to then use substitutes which don't have the mucosal adherence which barium does. So over time, both because of the reduced demand for these types of studies and the reduced quality of the study that we can offer you, they are sort of really heading on the way out. So especially with barium meals where you really need good mucosal adherence and barium, the substitutes are not as good. Right, a few lesions in the esophagus. So large fleshy sort of lesion, quite pale, a couple of vessels on it, looks sort of benign. Endoscopically, that's what you see. This is what we see on CT. So this is, any takers on the crowd what that is? Correct, someone said lipoma. No one did, but anyway, we'll just go from there. It's like an auction, trying to pull teeth. So large fat density, you can see it's of a similar density to the submucosal, the subdermal fat. So that's a classic lipoma. There's another lesion that looks very similar. So this is what you see endoscopically. Again, pale fleshy lesion pushing up from the submucosa. Looks like the same sort of lesion, but on CT you can see it's quite a dense lesion. So if we get a little arrow, there we go. Yeah, so you can see it there, little speckles of calcium. So the differential for this would be either a GIST or a leiomyoma as opposed to a lipoma. So it is worth doing a CT to check what it is. If you do see these tiny speckles of calcium, that's fairly pathognomonic for a leiomyoma, whereas a GIST usually won't have calcifications. Sometimes I think clinically you guys see ulceration, which points more towards a GIST. Another esophagus, again, clearly looks very different to the other esophagus, esophagi. Darren will call me up on my Latin grammar, I'm sure. Submucosal lesion, but on a very dusky and edematous-looking esophagus, so quite different. Usually the answer is in the history, and you often have a more elderly patient with sudden onset of pain as opposed to dysphagia, and they're often anticoagulated, so that is a nice submucosal hematoma. From an imaging point of view, it looks very similar to the other lesions I've just shown you, the leiomyoma and the GIST, because it's a uniform sort of density. Submucosal, you can see it squishing the lumen. How do we know it's a hematoma? A couple of different ways. Number one, you can follow it up, so it disappeared a few weeks later, whereas obviously a fixed lesion is not going to disappear. And sometimes on a non-contrast CT, a hematoma will actually look hyperdense, which the other lesions won't. Extraluminal lesions are very, very common. There's a whole range of them, mostly neuroenteric cysts and posterior mediastinal lesions. I'll try and keep this quick. You can get other paraspinal lesions. Sometimes we'll see something like this, retroesophageal aberrant subclavian artery, which can be a cause of dysphagia, or you may see a pulsating abnormality on your scope. Right, functional imaging of the esophagus. That's a nice example of a corkscrew. You probably won't see a better corkscrew esophagus. That's what you guys see on the inside. And obviously these are more in elderly patients with dysphagia. Right, to the stomach. As radiologists, we tend not to like imaging the stomach for obvious reasons. It's an organ that can go from the size of your fist to the size of a football in 5 minutes with the addition of a pizza. So from an imaging point of view, it's very difficult for us to make any great comment on the stomach. So it can vary in its size, its position, its orientation. And this is an entirely normal stomach, but it looks extremely thick-walled. So it's very hard for us to assess the stomach without distension. We do have some options if we do need to assess the stomach, and so we use gas-producing agent. So it's a combination of an alkali and an acid. The patient drinks it, produces a whole pile of carbon dioxide, distends the stomach like a beach ball, and then we actually get really good detail. Again, the problem is that the commercial agent is very hard to produce, is very hard to obtain these days, so we are struggling actually. We'll often just get the patient to scull half a can of Coke, or maybe eat some bicarb and then wash it down with some lemonade or lemon juice. So that's what it looks like when we distend the stomach, and we do get some decent pictures. This is what happens when we don't distend the stomach and radiologists start calling pathology, which looks like an asymmetric lesion on the gastric wall, but really when you distend the stomach, all it is shown is just to be some prominence of the incisura there, so that's quite normal. So if there is a stomach lesion that you really want us to assess for, you can ask for what's known as a fizzy CT, where we try and distend the stomach with some gas. The main indication for assessing the stomach is deeper pathology, which we know you guys can often miss on your superficial biopsies, and that's mainly sort of linitis plastica and infiltrating stomach disease. So that's what it looks like on imaging. We can actually pick this reasonably well because the thickened wall of the stomach has more of an enhancement and a uniform density and that sort of bland loss of the fold pattern. So that's an example of linitis. And there's the sort of the normal stomach there towards the fundus. Some more pictures. And sometimes we'll see some hypervascularity associated. Again, we don't get referred for obvious reasons, malignant pathology of the stomach too often, but occasionally we can sometimes see it as an incidental finding. So that's a malignant gastric ulcer with some sort of heaped up edematous edges. It's perforated through there but walled itself off, and so it hasn't presented as an acute gastric perforation. To the duodenum, again, you guys can get a scope most of the way through the duodenum, so you'll pick all the mucosal pathology. We'll be sort of better at picking the deeper pathologies and sometimes the extraluminal pathology as well. We tend not to use barium very much anymore for obvious reasons. We're just losing our skill at barium because we don't do it as often, and the detail is just limited. Whereas MR and CT have got some advantages. We still do sometimes use it for diverticular disease of the small bowel, but the main indication for barium in the duodenum is looking for SMA syndrome. Again, it's a fairly rare condition, but there's a fairly classic appearance where you have stomach with the barium coming through the duodenum with dilatation of D1 and D2, and there's a sort of a sharp vertical obstruction around the mid-D3 area. And sometimes if you get really lucky when we do real-time fluoro, you can actually just see that pulsing and the peristalsis trying to push against it. So that's the case of SMA syndrome. Right, jejunum has always been considered the barren wasteland of the GIT, but no longer with the clever people like Raj and Jeeves and and co, who are able to assess the small bowel more adeptly with your scope. You can get it much further. I'm sure Kira's probably done hundreds of these things. So we've got the small bowel, there's the jejunum. It generally looks thick-walled and presents us with a whole range of diagnostic problems. And again, radiologists overcall jejunal thickening all the time. And as you know, if you've ever been to an MDT with me, it's one of my pet hates, trying to sort out what is abnormal from normal. And unfortunately, pathology there is fairly rare. So we are overcalling a lot of times and probably resulting in over-investigation. But that's between me and my colleagues. Try and get the next picture. There we go. So, yeah, if we are going to look at the jejunum, we can use CTA if we've got occult bleeding, we've got MRE, if we're looking for inflammation or strictures, and then you guys have obviously got your capsules and your double balloons. There's a nice picture of what you guys can do from an antegrade or a retrograde approach, so that's very impressive work. Jejunum diverticular disease we do see quite often. It's one of the rare causes of abdominal pain, but you can have jejunal diverticulosis with overgrowth, and then you can also have jejunal diverticulitis as well, the inflammatory version thereof. There's some examples of jejunal Crohn's disease on MR, so some concentric thickening, stricturing, dilatation. Those are the features we look for in the jejunum. That's the mucosal and submucosal enhancement and a little bit of a comb sign. Those are terms you've probably heard if you turn up to an IBD MDT. Again, relatively rare in the jejunum, but you do see it from time to time. The ileum, again, you guys are able to get there with your retrograde or even further with double balloon. For us, again, one of the things that we suffer from as a limitation is distension. So under distension simulates all sorts of pathology or exaggerates it when it's not really there. So in order to get adequate diagnostic sensitivity of the small bowel, we need to distend it, and we do that with oral solution. Here are just some quick examples if you haven't seen too many. If you're not IBDologists, this is a nice example of the comb sign that you'll see and a hamburger sign. So a really thick, inflamed small bowel. That's what it looks like on T2 weighting. So these are different sequences, and sometimes we look at diffusion. I know there are some good articles comparing diffusion weighting against contrast-enhanced MRE, so we can try and ideally avoid gadolinium if we can. Diffusion is not as sensitive as contrast. Contrast is still better, but in patients who are pregnant or allergic, no one's really allergic to gadolinium. For the rare cases where we can't use it, diffusion is a good substitute for contrast imaging in MRE. Occasionally we pick up some other pathologies. That was a complex Meckels diverticulitis, which was actually missed on CT and then referred to MR, where we can see some outpouching, some thickening, and there's the lumen there. Right, lunch is not far away. Large bowel. We've got a couple of options. We do obviously a lot of abdominal imaging with contrast CT where we can pick some pathologies, but in non-distended bowel the sensitivity is reduced, but we certainly still see some incidental rectal cancers, colorectal lesions, inflammation, that sort of stuff. Ideally, if we're going to assess for malignancy, we want to do a CT colonography. So that involves preparing the bowel with catharsis. It involves gastrograph and tagging, so we can separate fecal material from lesions, and then it involves distension. So we've got to distend the bowel up. So it's uncomfortable, but most patients tolerate it pretty well, and it's a pretty quick test. When we evaluate our colonography, we look at it in 2D, so in our standard sort of multiplanar sort of views, and there's some example of a concentric lesion in the ascending colon and a sort of a raised polyp with central ulceration that's raised from the lumen of the bowel, so that's what it looks like. And what we're looking for is the density of the tissue as well. So we often see lipomatous hypertrophy of the ileocecal valve. You'll obviously see it clinically, and sometimes you want us to evaluate that with CT. So what we look for is the density. Is it fat density or is it tissue density? There's a quick example of a CT colonography when we do the 3D reformation. So this is called the fly-through view, where you actually literally fly through the bowel. My technologic skills are limited, so I can't show you it sort of weaving its way through there like Luke Skywalker and the Death Star in the final images where he's going through the canyon. But that's what it looks like. So that's known as the endoscopic or the fly-through view. The other thing we also use is called the fillet or fillet view, depending on whether you want to sound French or not, where you literally slice it open and look at it almost like the pathologist would see a specimen, and that's where that same lesion there sort of opened up. Last of all, we're reaching the lower end, so lunch is imminent. Rectum and perianal imaging. Obviously, Liz showed some excellent and graphic pictures that are going to live with me for a very long time. Ours are much more black and white or occasional shades of yellow, where we look for all sorts of things. So rectal cancer staging, we get pretty good at that because we can obviously see the tumour, but the depth and the penetration of the tumour into the mesorectal space and assess it with its surgical or downstaging type options. We can see the nodes, we can look for venous invasion, and we can look for local organ invasion with MR much better than we can with CT or any other modality. Perianal fistulae, again, Liz had a nice diagram. I didn't want to go too much into perianal disease, but we obviously evaluate those for the extent and complexity of perianal disease, particularly in Crohn's. Now we're almost at the end. That's just an example of rectal cancer, so a large semi-annular tumour with serosal penetration, an adjacent nodal mass and some early EMVI, just abutting the uterus there, but no, clear fat plain, so no local organ invasion. Perianal fistula, again, I won't go through all the various 4 types, but that's just an example, and that's what they look like. So a thick, angry, fluid-filled channel. There's not a ceton in this one. This one climbs outside of the anal sphincter complex and then turns through it, so that's more of a supralevator type fistula. Transsphincteric would sort of head alongside it and turn in, and the intersphincteric go up through the space lower down. I don't think my technology is going to work, but let me see if it will. Oh no, that's always never a good sign. No, all right, well, I'll finish it there. But what I can say is if you've got about 90 seconds spare while you're having lunch, I don't advocate using YouTube. However, put in Simpsons and colonoscopy into a YouTube search, and it's 90 seconds of your life that are well worth it. And that is the end.
Thank you, Ramon. Are there any questions, or Raj, you?
So Ramon is on call today, so if you've got questions, you can find him next to his cat, I think, reporting.
That's Ramy's cat.
Oh, Ramy's cat. Thanks very much, Ramon, and thanks to the chairs for hosting this session. So we'll break for lunch now, and we'll be back here at 2 p.m., if that's okay. Thank you all. Okay. Welcome back for the last stretch. So for some of you who probably just came in late in the morning, this is the last session. So it's session 5, looking into the endoscopic future. And you've got the QR code up there. So if you want to take a picture of that and try to link in to ask questions, we'll have those questions coming to Gerald on Slido. And we'll try to answer those questions at the end of the session, given that we're running a little bit over time. Just like to update everyone that in total we had 110 on-site registrants over the last 2 days, which is great. So there was about 90% attendance rate yesterday and close to 100% today. Obviously, some have left because it's Saturday. And online, as of a few minutes ago, we had about 344 people logging in online over the last, I guess, 24 hours. So that in total is hopefully going to touch about the 500 mark, which is fairly good for our symposium. So thank you all again for making the time to come. I'll hand this now to the chairs. So we've got 2 of my very close colleagues, Dr. Damien Harding and Associate Professor Asif Chinarata from the Lal McEwen Hospital, both of whom are hepatologists, but also obviously gastroenterologists. And we've got Dr. Brian Kirkby, who's a general surgeon, who's joined us in the last year or so. So all 3 of them will be chairing the next session. Thank you. Oh, okay. You want to take a group photo? Oh, yeah. They're all feeling quite sleepy after. Yeah, after the session. Okay.
Thanks very much, Raj. And it's because of Raj that they allowed a couple of hepatologists into a meeting talking about endoscopy. So thanks for that. Hopefully we can learn something. The first speaker is a delightful chap from WA, Neroshan. Neroshan and I were registrars in Perth a number of years ago. Since our time as registrars together, he went on to do fellowships in interventional endoscopy in Toronto, further training at Sir Charles Gardner in Perth, and he's now one of the lead interventional endoscopists at Royal Perth Hospital. He will now talk on the topic of how to close holes. Wasn't that what you were talking about, Neroshan?
That's right.
Very important for hepatologists that do endoscopy. Thank you.
Thank you very much. Thanks. Thanks for the introduction, Damien. Good to see you after a long time. I won't go into detail about studies on this talk. I know it's just after lunch, so we'll get to the videos very, very soon. But it's an important topic. I mean, by nature of what we do, we inadvertently can sometimes make holes, so we are prepared to identify them. We should be prepared to identify them, and sometimes, things like peg fistulas we have to close, so we have to be prepared to do them as well. Now, the talk will be in three main areas: when to close, and how to close, and what the evidence says. So, prophylactic closure after resection, we have to think about who benefits. We have to stratify the risk by the location and the lesion or what the therapy we are doing, whether it's right colon or duodenum, and the size and whether they are on antithrombotics matter because of the bleeding risk. And you also have to think about the feasibility of complete closure. So that's prophylactic. So this is when part. In therapeutic closure, when it happens acutely, you have to be able to match the device to the sizing of the arteriogenic perforation. And the timing is critical, whether it's an acute arteriogenic perforation or a delayed leak, etc. And if it is a delayed leak and an abscess formation, just closing is not enough, and it sometimes can be detrimental. You got to think about drainage and contamination control as well. And we'll go through a little bit about evidence. So why do we elect to close prophylactically? So one is the most common serious one of the most common serious adverse events after large colonic edema in ESD is delayed bleeding. The risk is higher in the right colon, more than 20 millimeters in size, and if they're on anticoagulants. So there is evidence supporting prophylactic closure in these selected circumstances. And the other reason why we have to close is acute perforation, EMR or ESD. And one of the most important aspects of this is anticipation. Depending on how technically difficult or easy the case is and how the case progresses, you have to anticipate whether it's going to happen and recognize it early if it happens. That's the key thing. And again, the device choice depends on where you are and how big it is, etc., and the tissue quality. So leaks and fistulas, I won't go into a lot of detail about it. One is I don't have a lot of experience on chronic fistula and post-op collections and things like that. But one of the most important aspects is closing alone is rarely enough. You have to think about drainage, either EBT or drainage tubes, etc. Acute leaks is a different matter. Sometimes closing is enough, but chronic fistulas is not. So prophylactically, again, we've touched on this before, right colon, larger lesions. If complete closure is feasible, I always close on the right colon. Now, colorectal ESD defects, it's not entirely necessary to close rectal defects, but if you have, we'll get to a video about that. Depending on how the case progresses and the end result, you may need to close rectal lesions, but above the sigmoid have a lower threshold to close. And the risk modifiers come into play as well, anticoagulants, antiplatelets, etc. And therapeutic, again, important thing is identifying quickly, reduce contamination, suction out the contents, and if it is chronic, think about drainage as well. Now, if it is the size matters of what you're trying to close. If the size, by size I mean when it comes to especially less than 10 millimeters, not the EMR defect. It's rarely necessary to close a defect a post-polypectomy less than 10 millimeters. But if it is a perforation, if it is less than 10 millimeters, through the scope clips would be enough. But if it is more than that, which we'll come to in a video, you might need to think about other modalities like an over-the-scope clip with its inherent use of a grasper or anchoring devices. And if it is more than that, more than a 2 centimeter, for example, freehand EFTR, it's very rarely or almost impossible with through-the-scope clips and even with over-the-scope clips. So you have to think about things like tacks or suturing devices, and the way you close matters as well. But those kind of defects, you know before you go in, because it's very rarely that you'll put a 2 centimeter perforation in a EMR. Cavities and leaks we talked about. So there's a lot of there's ample evidence about the benefit of closing, but the key thing is that the benefit is strongest when the baseline risk is high. If the baseline risk is low, there's no added super advantage on closure. This is post resection. And obviously, the effectiveness depends on the expertise and the completeness of the closure. So, what does the guideline say? in the colonic sphere, prophylactic closure after mucosal defect of EMRs of sessile lesions is encouraged after conventional EMR, not cold snare polypectomy or piecemeal cold. There's almost no need for closure of even a large, 4 or 5 centimeter sessile serrated lesion if you take it out piecemeal cold. Now, suggested don'ts: you don't need to prophylactically clip conventional polypectomy sites less than 20 millimeters and in the left colon, but take that with a pinch of salt. You have to cater to the lesion, cater to the occasion, and if you think they need to go onto their anticoagulation straight away, that's a different scenario. So you have to be able to modify the guideline. Guidelines are just guidelines. You have to think about the patient and the procedure and the result in front of you. Always consider cost effectiveness. You don't have to necessarily close just because you can or you feel the need to. Just always think about whether it's effective closing a defect, because if the risk, like I said before, if the risk is already low to begin with, there's no added advantage of closing. Talked about twice now, but the proximal location, the size, comorbidities, whether they're on anticoagulants play a part. So let's go into videos. So now, one of the key things in defect closure is what we call the zipper effect. Now, what that means is you start at one edge of the lesion and then you close it consecutively with subsequent clips. But with the new tools that we have, like the Mantis and the dual action tissue clip, you don't necessarily have to follow that. You can oppose the edges in the middle, and then it'll give you nice two sides of tissue opposition where you can use the conventional clips to do. So this is an example of that. You can see this is a Mantis clip. You can capture, mobilize, and deploy. So I've dragged it across, and it's very important that you capture some of the submucosa underneath as well. I'll come to that in the next video. But then when I close that middle of that lesion, you could see that there's nice two lines on either side of it that you can close with whichever through the scope clip that you have. And it's very important for complete closure. So you can see that if I didn't put that last clip, there was a little defect in there that could bleed from. So it's important to, once you commit to it, just completeness is important. And this is another one. Again, I go to the middle of the lesion. you saw that there's submucosal tissue captured in there. On this one, you'll see, I bring it across, but you can see that it's only the mucosa that's supposed. So I let it go and then push the clip in to capture that submucosa to get that tamponade effect, and then close the rest of the lesion. It's very important to keep that in mind. I don't know whether all of you have used Extract. It's another device that you can use. So Extract has 4 screwable tacks. So that's one of them. So you place them outside of the lesion. So that's the first tack. And then the second one. So you have a little handle that you can screw it in. It's about 0.5 millimeters, that the thread that goes into the mucosa and the submucosa. Third one placed on the opposite side, away from the defect. And the fourth one, and after that, there's a suture that goes through all those tacks. You pull that in, converging the tacks together, and you cinch it off with this plastic tack, which stays in place. It's effective when you choose the lesions carefully. Lesions more than 2 centimeters, it's going to have some gaps because it's only 4, as you can imagine, it's only 4 tacks, and lesions larger than 2 centimeters might not close properly with this one. So this is the dual action tissue clip. You've already seen this clip in videos. So it has 2 independently mobilizable arms with 2 handles. You can open them independently. You hold one edge and close, go to the other. But in here, what I'm demonstrating is you can see that it's only the mucosa that has dragged onto the other side. So if you leave that and if you just oppose the mucosal edges, there's still a bridge underneath it, and it will not be effective, and it won't save you from bleeding. So you have to, with something like a dual action tissue clip, you can't remove that either. So you have to, with subsequent clips, you have to make sure that you capture that submucosa as well. Now, one thing I like about interventional endoscopy is you always have to think outside the box. Now, this is an ESD that I did quite some time back. We don't have dual channel scopes. Inadvertently, this is not the primary lesion. The primary lesion was a net. And within that area, there was a submucosal lesion as well. So I thought it was quite close, so I'd take it off. But you saw that I had to partially cut the MP as well. And this is in the cardia. We didn't have mantis clips back then. I'll just stop there for a minute. And I had to have a way of closing this defect. So this technique is called King's closure, and you have to have a dual channel scope for that. But what I did was I put the polyloop outside the scope, and then attached it to the defect edges with clips. And subsequently, you could deploy the endoloop, closing the edges together. And this patient did well, no bleeding or delayed perforation. And the clips, all of the clips could be removed in subsequent endoscopies. Again, thinking outside the box. Now, this is a GPOM. Now, the problem with, at least what I had was, it might be different under expert hands like Amol, but what I had was, once you've done the myotomy, the mucosal edges of the GPOM is played out. So when you're closing, there is a risk of mucosal edges turning on each other, and it might not heal properly. So what I thought was, if there's a way to tent the mucosa up, that might give me better position and better grasp from the clips. So I call this snare-assisted clipping. So what you do is you load a snare into the outside of the scope and deploy, before deploying that clip, release the snare and catch the stem of that clip with that snare. And then when you gently pull on the snare, it creates that mucosal tent, and subsequent clips can easily go in. And then you capture the snare with the next clip, move it into the previous one, and then it gives that nice mucosal lifting. So you have to always think outside the box when you're doing interventional endoscopy, and it applies to your resections and especially for closure. So I could close this with I think 5 clips. So what about duodenum? It's a small lumen, but the consequences are big if you don't take care. I think we've covered part of it in previous talks and yesterday. Delayed bleeding and perforation is very high, especially in large lesions. So you have to think about whether you can achieve complete closure. You have to plan ahead, use carbon dioxide, make sure you achieve stable scope position, think about other modalities that you can use as well. I'll quickly go into a couple of more videos. Now, when we talk about adverse events, Dr. Bape told you about that it's almost always predictable, and this proves that point. So this is something that I did some time back. And now you can almost predict what's going to happen. This is an atrophic stomach. Banned EMR is a big no-no. I learned that the hard way, but once it happens, you have to deal with it. So as you can see, there's independent structures moving through that. So you have to suction. There was the risk of not only mucosal gastric contents, but the band was falling in that. So you have to quickly get ready. And I thought I'd use a Ovesco clip for this. So this grasper is again like the dual action clip. It has 2 independently mobilizing arms, and then you pull the defect back into the clip, but you have to make sure that all the defect is in that, and just deploying the clip is not enough. You have to go back and make sure that it's properly secured, because OTSC is a one-way street. Once you've deployed it, unless you have the removal device on hand, which is never, you can't remove it. So you have to be done. So this is the last video. So this patient is just bear with me. Sorry about that. So this patient had a rectal EMR. It was a malignant polyp, but it was a low-risk malignancy, so we didn't go on to have resection. But 9 months later, there was recurrence, so sent to me for EID. And there was, as you can see, there's spot tattoo right here, not only in the submucosa, but it was in the intermuscular plane as well. So during the EID, there was obviously full thickness muscle defect. So usually you don't have to close EID defects in the rectum, but I think the colorectal colleagues will agree with me. This is in the anterior wall. Now, in males, it's not a big problem, but in females, the pouch of Douglas comes very low down. So you have to be very careful when you're doing the procedure. Plus, I was not comfortable to leave this exposed. But what it demonstrates is that even such a large defect, with the tools that you have today, you can close very confidently. I think that's probably enough time. I'll close with this one. So in 5 lines, so close prophylactically if the baseline risk is high and complete closure is feasible. For perforations, identified, that's a key thing. Act immediately, suction, remove contents of the gut, and choose the devices carefully. For leaks, prioritize drainage if it's chronic, and infection control. Closure alone is not enough, and technique matters. Make it tension-free. Be careful when you're closing. Sometimes you have to inflate to see what you're closing, but deflate when you're closing. And always have a bailout, have your friendly surgeons close by. And just a reminder again, AGW comes to Perth after almost 2 decades, so hope to see you all there.
Naroshan, thank you very much. That was a fantastic presentation. My colleague Asif, inspired by all the other speakers, ran out to deal with an endoscopic emergency that we have in theatres this afternoon. So hopefully he's taken some learning points with him.
Is he a hepatologist?
And a gastroenterologist, Raj. Our next speaker coming up now is Amol, who needs no further introduction. He's going to talk to us about the particularly interesting areas of metabolic and bariatric endoscopy. So thank you, Amol.
Good afternoon, and thanks, Raj, once again for this honor. Metabolic and bariatric endoscopy, not something which I do very regularly, and I had to ask a lot of my friends and colleagues for many of these slides, so I don't want to take much credit except for putting them all together, probably. But let's try and understand what we mean by metabolic and by bariatric, because I think both these terms are used interchangeably very often. So bariatric procedures are primarily directed towards weight loss, and any metabolic changes that may be seen later on are usually secondary. Whereas metabolic procedures are primarily directed towards euglycemia and diabetes control, and they may or may not result in associated weight loss, and that's very important to understand. So chronic obesity, we all know that it's a chronic, progressive, relapsing, and a multifactorial global crisis. And the global prevalence is 37%, and in India, we have about 82.5 million obese. That's huge. And is the leading cause of cirrhosis currently, liver cancers, and probably that's where all, we as gastroenterologists are getting into this domain space to treat these patients. And the global cost burden, again, huge. That's how it is. And this obesity is basically just a tsunami waiting to strike. I think it's hit a lot of countries and is still hitting all other areas. And when we look at the obesity problem, what we are seeing is the fatty liver that we are seeing is only the tip of the iceberg, because there's so many things which are under the surface which we are actually not addressing when we are talking only about the fatty liver. The current management of obesity, we all know, is directed towards lifestyle modifications. There is pharmacotherapy, and there's a whole lot of discussion that goes on pharmacotherapy. And then there is endobariatric, there is bariatric surgery. But there is a huge gap in between which needs to be addressed. Some hard facts that we need to understand. Lifestyle modifications, yes. Many of us can lose weight, but more than 80% regain that weight within 5 years. Only 10 to 20% can maintain that reduced weight. And there are significant personal, psychological, or logistic challenges in just continuing lifestyle modifications. Less than 1% patients undergo bariatric surgery because the complication rates are still significantly high. The procedures are irreversible and it is still expensive. Most insurance do not cover it completely. And that's the real world situation, that less than 1% get surgery and less than 1% take medications. And 99% there's an unmet need. And that's the gap. And that's the gap that we try and fill in when we talk about endobariatrics. So the spectrum of obesity treatment, it starts with lifestyle modifications, we all know. Then with pharmacotherapy, and there's a lot of discussion on GLP molecules. And then we have the surgery, but this is where the endoscopic therapy fits in. So before we go into what we can do, let's look at the ideal patients where endoscopy is actually useful. So patients with obesity who have not responded to traditional lifestyle interventions, and basically class 1 obesity, BMI 30 to 35, are with associated comorbidities are usually the more commonly ones. And class 2, class 3, still surgical candidates, but many of them who do not want surgery or who are non-surgical candidates, those can become candidates for endotherapy. And endotherapy can also work as a bridge therapy in many of these to bring them down to a level where the surgical risk becomes acceptable, and then they undergo something more definitive. Patients who are unable to tolerate primary pharmacotherapy and combined with medications, and patients with a history of bariatric surgery, but after that they have weight gain, and that is how these are the patients. So when we look at bariatric and metabolic endoscopy, we have two areas that where actually endotherapy is focused. One is in the stomach, which is predominantly directed towards weight loss directed therapies. And the second one is the small bowel directed therapies, which are more towards the metabolic. We'll take one of them, each one of them. So the first one and the simplest one is, of course, the balloons, the intragastric balloons. And there are several FDA-approved balloons which are available. And again, what are the indications? BMI 30 to 40, obesity-associated comorbid conditions, and also as a primary or bridge therapy, and in NASH cirrhotics, patients listed for transplant to improve opportunities for actually to bring the weight down so that they become better candidates to get a liver for transplant. They become good candidates. And of course, there are these contraindications that we have to rule out. Another very important social indication in India, particularly, I don't know how much it is applicable over here. Young girls, obese girls of marriageable age, and they do get balloons, and they lose weight, and then within 6 to 8 months, they'll get married, and then they get the balloons out. So that's how it is. So this is how the procedure is done. So it's a very simple procedure, actually. You pass the balloon, the patient is under propofol, and you pass the scope under endoscopic vision, but it's actually direct, just like a nasogastric orogastric tube. And to pass it under vision, it's a pretty bulky device, but you just place it there. And then you fill it up. Some of them are the refillable balloons as well. And it shows significant improvements. And actually, removal of the balloon sometimes is a little bit more challenging, because there are these special needles, and these balloons, mind you, they are latex balloons, but they are the lining of these balloons it's pretty stiff, and they come with and the needles come with a specific stylet, the needle, and if you can't get it in and very effectively, sometimes it can become a bigger nightmare to remove these balloons rather than to put them in. So that's something which is there. Total body weight loss at 6 months and 12 months, again, it can be, you can see there is a significant reduction in the weight. What is more important to understand is that after 6 to 12 months, it's going to plateau down, and most importantly, the balloons need to be taken out after 6 months, or some of these balloons can be left inside for up to a year. But the benefits are, it's a non-permanent, it's adjustable, it's also reversible. However, because of that, it can become a temporary solution, and some patients do have nausea and abdominal pain. Sometimes these balloons need to be taken out for persistent vomiting. Endoscopic suturing, when it came in as a big thing for a primary endoscopic sleeve gastroplasty, as well as for a revisional Torre procedure, where after a Roux-en-Y gastric bypass, the outlet becomes wider, and then there's that needed reduction. So what is the ESG procedure about? So BMI, even higher BMI candidates can undergo the ESG procedure. And the contraindications are, of course, gastric lesions or a large hiatal hernia, and that is what is important. So how does the ESG perform? So there are several techniques, but basically the principle is to plicate the stomach, starting in the antrum at the level of the incisura. And then several designs of the plications are used. and we placate on the greater curvature. And the important thing is, it's not just the breadth of the stomach which is reduced, but also the length of the stomach is reduced, because of which approximately 30% of the stomach is retained, but about the stomach is converted into a gastric tube. And it is pretty effective how it's actually done. So don't want to just rush through the videos, but that's how it is. So how does ESG work? So it reduces the appetite. Basically, it reduces the volume as well as accommodation, which initially results in satiation. And also, it reduces the gastric emptying time. And it slows it down, which gives more satiety. And both these factors are important. And this is how we can see it, the volume and accommodation. So we can see that the gastric volume has gone down, and the gastric emptying also reduces. That is how it is. So there are further hormonal changes with a decline in the leptin and prevention of rise in the ghrelin secretion also. And the clinical effects are increased fullness, decreased hunger, and which leads to greater weight loss. So the outcomes, when they have compared ESG with lifestyle modification, this is the classical MERIT trial, which was published in Lancet. So the excess weight loss, again, and total weight loss both reduced significantly. And not only that, but comorbidities also reduced significantly in all these patients at 1 year and 2 years follow-up. The ESG has been shown to be quite safe, with only about a 2% serious adverse events. That's how it has been. Perigastric abscess and occasional bleeds have been reported, but that's how it. ESG has also been shown to provide long-lasting effect up to 5 years, with about 82% patients reporting about 15 to 16% weight loss at the end of 5 years. And along with combination therapy, sometimes these results can further be augmented. That's how it is. So, and in this meta-analysis, we can see that at the 12 months and at 24 months, the total body weight loss was significantly lower, and the adverse events were only about 2%. More importantly, I think from a patient's satisfaction scores point of view, 80% patients have shown to be there is documented findings that they would recommend treatment to somebody else suffering from obesity. Now with the GLP analogs coming in, this is a controversial topic. Which patients go for semaglutide or these molecules versus ESG? And it has been shown that ESG produces more weight loss than semaglutide alone, and ESG may be a more cost-effective solution than semaglutide over 5 years. And a combination of ESG plus GLP-1 actually has shown superior results. So this was a study with liraglutide, and then again, this was a randomized study in Brazil, 2 groups, and this was shown that the combination therapy resulted in superior weight loss as well as the lower mean HbA1c levels. So that's how it is. Comparing ESG with the laparoscopic sleeve gastrectomy, so ESG has been shown to be non-inferior for the weight loss, and the comorbidity resolution and safety profiles are quite comparable. So these are some of the advantages of ESG over intragastric balloon or a laparoscopic sleeve gastroplasty. Basically, it has all the advantages of a lap procedure, but it is still potentially reversible, and it's a daycare procedure, and it can further be upgraded to surgery if required. So these are some of the prerequisites for endobariatric procedures to be performed, because we cannot take them lightly just because these are daycare procedures. We need to screen these patients with a high-definition EGD, eradicate H. pylori, and the rest of the workup has to be as for bariatric surgery. Some mandatory consults with nutritionists, fitness planners, and psychologists are important, and we cannot just take shortcuts in these just because these are daycare procedures. And this is something about weight gain post-bariatric surgery. So these are, weight gain can occur in 15 to 30%. And this is where the Torre procedure comes in, because this can result in further weight reduction in up to 30%, in 10 to 15% patients at 5 years. So that's how it is. And this is how, using the suturing technique, we can reduce the outlet by just using plicating sutures. So that's how it is. Coming to the small bowel therapies. So the glucose metabolism, initially there was a thought process that the pancreas is responsible for the glucose metabolism. But now there is enough evidence that the metabolic control is actually in the duodenum and not so much in the pancreas standalone. And when a food bolus passes into the duodenum, actually there is an interplay between incretins and anti-incretins. And basically based on the incretin response factor and the decrease in incretin potential, the interplay actually leads to euglycemia. But in patients with diabetes, and particularly type 2 diabetes, this changes, and there is insulin resistance that is demonstrated with a rise in the blood sugar levels, triglycerides, and leading to NASH. And it has been well documented that the nutrient passage actually goes down over there. So when we're talking about insulin resistance as a root cause of metabolic disease, so endoluminal intervention in the duodenum can reduce the insulin resistance. And these are 3 procedures which actually revolve around that. So the endobarrier came in initially. It was kind of a sleeve which was about 50 centimeters long. It was placed at the pylorus like a stent. And it actually was a very impressive technique which would cover the duodenum and prevent absorption in the initial 50 centimeters of the duodenum and the jejunum, 65 centimeters of the jejunum and the duodenum. And the results also were pretty good, but the problem was that some patients developed liver abscess, and because of that, the primary device has been pulled back, and hopefully, probably in the next few years, we'll have something new that will come in. But duodenal mucosal resurfacing is something which is coming up in a big way, and the hypothesis is that basically the duodenal mucosa undergoes changes based on and leads to dysfunction based on the dietary patterns. And once resurfacing is performed using various procedures, this is how it is performed. So this is how a thermal DMR procedure is performed. So using a radiofrequency ablation technique, there is submucosal injection to prevent from deeper injury, and then there is a circumferential mucosal ablation that is performed by raising the temperature to around 80 degrees. And with that, we can see that within 3 weeks, the mucosal regeneration occurs. And there is significant response. That is how we can see that everything actually, from HbA1c to all the parameters, along with the ALT, AST, and probably weight, everything goes down. Weight may not be that much, but most of the other factors go down. And the REVEAL study actually showed that DMR reduced weight loss even after GLP-1 was discontinued. And that is how it can actually improve the effects of GLP-1 acceptance and prevent long-term GLP-1 this thing. Magnetic jejunal bypass is another, but still in the developmental thing, where we can pass scopes from the oral as well as the anal side and probably create an anastomosis using magnets. Still some work going on that. And the last topic would be the beta cell targeted smart GLP-1 adeno-associated virus gene therapy, which is coming up in a big way. Still, probably the first human patient will be recruited in 2026, but these are the principles because, based on the insulin resistance and this thing, there is a beta cell failure. And because of progression and poor persistence, this is how we can see that the current therapies can give us, it gives us a drop, but then gradually it goes up. So the route of administration would be an EVOS-guided approach where we inject into the pancreas, and with that, with the mechanism of action, that human GLP-1 and insulin-derived promoter and secretory features, that is how it's going to change. So that is, it has shown good evidence in animal models, but further studies still to become available in humans. So potential advantages of metabolic endoscopy, well, there are plenty. We can see that. Some key takeaways. So metabolic endoscopy and endobariatrics, there's an exciting approach for treatment of morbid obesity and type 2 diabetes. And intragastric balloon and ESGs have been well-established and well-researched techniques with impressive long-term outcomes. Balloons give excellent short-term and medium-term, whereas ESG gives longer-term outcomes, and long-term outcomes of ESG are comparable to laparoscopy as well. Combination with pharmacotherapy is quite an interesting area, and it's further improves outcomes, and new upcoming modalities are exciting. But still, I think the optimal patient selection is vital to success, because I think treatment of obesity remains a teamwork and a team issue. Thank you so much.
Thank you, Amol, for a fantastic talk. I'd now like to welcome George Balalis. George is a specialised bariatric and upper GI surgeon with advanced skills in laparoscopic, primary and revision weight loss surgeries, as well as complex hiatus hernia repairs and reflux surgery. George also performs endoscopic bariatric procedures, including outlet reductions and endoscopic sleeve gastroplasty. He works privately as part of a comprehensive and holistic multidisciplinary team at Morph Clinic based in North Adelaide. He is also a general surgeon on the acute surgical unit at Lyell McEwen Hospital, with a particular passion for working with and supporting younger surgeons. Thanks, George.
Thanks a lot. Apologies, a lot of my slides are the same as Amol's. I just come to a different conclusion at the end. And I think a little bit like Honchi has said before, I'm very fortunate to be a surgeon as well as performing interventional endoscopy, which I think really is a great opportunity and a balancing act in regards to working with others and what's best for the patient. That's
okay.
Yep. There you go. Cool. Yep. Easy. Disclosures. So I think obesity is a little bit like hiatus hernia treatment. So obesity surgery is to metabolism what hiatus hernia surgery is to reflux. Medication can treat reflux, absolutely. However, hiatus hernias, and particularly patients with water brash or volume reflux, pantoprazole or other PPIs in particular can only neutralise acid. They can't fix the actual problem. Medication can treat obesity, however, again, not as effective, does not change the anatomy. Weight regain is inevitable if they are stopped, as well as patients struggle long-term to change their routines. So you can see here, this is a patient from this week. The hiatus is displayed in black, and then in the second photo, there is no hiatus hernia after the operation. I thought when discussing this talk and doing a little bit of research on what's been new in this area, I thought I'd ask ChatGPT. You know, why not? So I put it in, bariatric surgery, will it stand the medical endoscopic onslaught? The short answer, luckily, yes, but it will change a lot. The long answer we're going to talk about in the coming slides, all right? We'll see if I agree with ChatGPT. So ChatGPT, this is all from verbatim. Medication and endoscopic treatment, particularly good for early stage disease. BMI 27 to 35, minimal comorbidities, surgery-averse patients. Prior to consideration of surgery, then they may continue on. And it is also an effective adjunct, and we can see that later on in regards to TORS or ESG. But medications for weight regain, plateau or relapse can also be used. And really saying that surgery works better, it is definitely better for severe disease, as medication is not really a cure, and surgery provides a biological reset. And there are a lot of side effects for medicine. So for medications, there's costs, there's weight regain when stopped, there's muscle mass loss, and the side effects. best outcomes are with surgery. But what will change? So fewer primary operations, more complex surgery, and surgeons who don't adapt will struggle. Surgeons need to prescribe GLP-1s, perform endoscopy, manage revisional disease, and work in a multidisciplinary practice. Lucky for me, that's exactly what I do. I think it's really important to be with another surgeon, with Dr. Burma in particular, for myself, as well as have a multidisciplinary team around. So general practitioners, endocrinologists, psychologists, dietitians, exercise physiologists, bariatric nurses, all for the best of the patient. Regular blood tests, regular follow-up. It's really important. It's not just about the operation. It's not just about being a surgeon in a silo. You really have to work together with others. So current options. So we've heard diet and exercise 0 to 5%, very unlikely to continue to have that weight loss long term. Medications, real world outcomes around that 10 to 15% total body weight loss. And we'll go through one or two of the main trials showing this. Intragastric balloon. The intragastric balloon that I perform is called the Allurium balloon. It is a non-invasive gastric balloon, so different to the Orbera or the bib that was performed in the videos. Allurium balloon, very safe, very easy to perform, and done via fluoroscopy. I do this in an endoscopy suite, but outside of a scope, as well as then endoscopic treatments, ESG, TOR, and then surgery. So, surgery has the best long-term outcomes and the best weight loss, 30 to 35%, and the risks of surgery are around the same as a laparoscopic cholecystectomy. So if anyone has had a lap chole or knows somebody who's had a lap chole, same risks apply for weight loss surgery. That's in Australia. Surgical options. All right, so who is a candidate for surgery? It's pretty straightforward. For me, 18 years or over, BMI greater than 35 or BMI greater than 30 with a comorbidity, and then we run through some preoperative assessments and make sure that active eating disorders, active psychiatric illness, and we screen people out and try and help them from there. Sleeve gastrectomy, pretty straightforward, removing 70 to 80% of the stomach. The dotted line indicates the resection line. Low risk operation, 1 to 2 nights in hospital, and then routine follow-up. Gastric bypass, this is a single anastomosis bypass, far more common than a Roux-en-Y gastric bypass, both in Australia and internationally now. Better weight loss outcomes, safer for the patient, and a more efficient operation. Bypassing 150 centimetres of the proximal small bowel. So this is an intraoperative picture of a single anastomosis bypass. Much longer pouch, much smaller pouch in regards to width, and connected to the small bowel. Both operations around that 30 to 35% total body weight loss, good long-term outcomes. Important to choose your patient correctly and to provide all of the operative treatments for patients. It's an intraoperative picture of a sleeve gastrectomy. Bariatric surgery provides better glycemic control. Early referrals are really key. A patient who's referred, if they become a diabetic or are diagnosed with diabetes, the earlier they are referred to surgery, the more likely they are to be in remission. We're very lucky in Australia to have the BSR data. So Professor Wendy Brown from the Alfred started this with Monash University many years ago. It records around about 90% of all weight loss surgeries performed in Australia. It is a voluntary registry. Most surgeons are a part of it. I provide data to the registry. It demonstrates very good long-term outcomes and very safe outcomes for patients. So you can see 1.5% 90-day complication rate for sleeve gastrectomy, 3 to 4% for a bypass, and then around that 30 to 35% total body weight loss out to 4 years. So yeah, again, one anastomosis gastric bypass, slightly better weight loss outcomes, all actually quite similar. And I think it's important I show patients this in a consult. It's really useful for them to understand. 70% of patients no longer need insulin for their diabetes after 1 year of surgery. It's as simple as that. Reduce cancer, decreased mortality. There's been a recent systematic review and meta-analysis comparing surgery with GLP-1s. So absolute effects, 25 fewer deaths, cardiovascular events, and 23 fewer heart failure events, which is a 43% relative risk reduction for surgery compared to GLP-1s. I think this is also really important. This is a study out of the Cleveland Clinic. This is a centre who provides medications to patients at a very discounted price or no cost at all. So cost is not actually a factor. Semaglutide or tirzepatide, majority of patients did not get to the top dose, and majority of patients discontinued their medication within 12 months. And the average weight loss was around about 11%, 11.9% or 8.7%. This is real-world data. This is not a multi-centre trial that looks at patients every week, and this is the real-world data, a little bit like our BSR. And again, the complication rates of bariatric surgery are very similar to a laparoscopic cholecystectomy. This is from a registry. This is clinical data. In regards to medications, I think it's really important to sort of understand maybe how they fit compared to surgery. I think it's really good to start people on medication, start that process, particularly if they're a little bit anxious about surgery, they're not ready for surgery. It can provide some patients with excellent results. The problem is the far majority of patients do not get those excellent results. And then I think it's really important to make sure that we discuss with our patients the fact that medication is, at the moment, for life, and you really need to make sure that you preserve your muscle. I'll show some data from step 1 in the next slide, describing the evidence for that. Also, a little bit of a side note, I thought I'd put this up. This came into my feed in the last couple of weeks, and is being looked at, I think, by APRA at the moment. But, you know, there's been a Black Friday sale and discounts on GLP-1 programs in Australia, which I think is predatory medicine. I don't think there's any role for that in our society. So changes in body composition. This is a really important sort of DEXA scan result from step 1. So that's semaglutide data. Demonstrating, so DEXA scans before and after semaglutide for 52 weeks. Out of the 13 kilograms of weight loss, it was great. 8 kilograms of the weight loss was fat mass, but 5.3 kilograms was lean body mass. Really important, and this is as good as it gets. This is not real-world data. This is high-level trial data. So far more likely to have worse outcomes in the real-world setting. So just important to remember that a lot of that weight loss is actually muscle mass. And if patients do unfortunately stop their medication, they're gaining back fat mass. They're not gaining back muscle mass. As we know, it's very difficult to gain back 5 kilograms of muscle mass. And these are long-term outcomes that are going to impact on our society. Again, this came up on ABC News this week. And I think, again, as clinicians, it's so important to talk to patients about the risks and as well as the benefits and how to best look after them. So a patient was refused medication by their GP, jumped online the same day, got that script and was hospitalised for an acute flare-up of her eating disorder. So, you know, these are the things that we face at the moment. In regards to endoscopic treatment, I do perform endoscopic treatment. So again, it's a photo of an overstitched device. There is a pose-2 device as well. We don't have that in Australia. So this is usually the device we use. So intraoperative pictures comparing the sort of volume of a stomach compared to after the ESG. Restricting the volume by around 40 to 50%. Durability is good. There are results out to 5 years. The weight loss around that 10 to 13 to 15%, depending. And the variability is a little bit more than surgery. It is a technical procedure. I think there is a learning curve as well. So good evidence for ESG. We've seen those results with AMO already, particularly for class 1 or class 2 obesity. And the MERIT trial, great trial. This is sort of the impetus for me to begin doing ESG after this trial, mean total body weight loss of 13%. So unfortunately in Australia, quite an expensive procedure, not funded by any private health, not able to be rebated by superannuation, and not available in the public system currently. And I think absolutely right, Emil said this already, cost effectiveness at around 3.5 years to semaglutide. However, there is quite a large upfront cost. I think transoral outlet reduction is great for patients after bariatric surgery. Can be used for weight regain, bowel reflux, or even dumping syndrome. I've actually modified my technique slightly after this case. I do circumferential APC and then overstitch afterwards, and you can see the outlet's quite small compared to the start. Around 5 to 10% total body weight loss and durability at 5 years. Future directions. So again, magnetic surgery is coming. I was very fortunate to be part of, I was one of the surgeons. There were 3 centres in Australia, myself, a surgeon in Sydney and a surgeon in Perth, part of the MAGD trial, looking at magnetic treatment to create a duodenal ileostomy. We were doing this after a sleeve gastrectomy, but you can do it at the same time. We're waiting on approvals. It is FDA approved. It is being performed clinically in America. Unlike the resurfacing, the duodenal resurfacing is not available clinical. It's purely in trials. This is available and is being performed in America at the moment. So you can see a magnet. I get them to swallow it. Very similar to the Allurium balloon. Swallow one of the magnets. You can see it's in the left pelvis, so that, it means it's somewhere in the small bowel. I've got to go looking for it. And then the patient is taken to theatre. Another surgeon or endoscopist brings down the other magnet on a specific device. So you can see the endoscopic picture. We're bringing in one of the magnets, and then I'm docking the magnets together to create the anastomosis. So that's me operating, trying to find the other magnet. So we call it surfing. You sort of surf the magnet up the bowel after working out your limb lengths, and then they connect. And through tissue necrosis, create an anastomosis over the next 2 to 3 weeks, and the patient passes those through their GI tract. I do think that the future lies with surgery that is a hybrid endoscopic and laparoscopic or robotic even, because there is then that opportunity for very safe surgery tailored to the patient and what's best for them. And this is just a picture of the anastomosis on the repeat endoscopy. So I think in summary, yes, medications are safe, and for the majority of patients, that is the case, and they are an option, particularly in the lower BMI range. It's really important to ensure that you educate your patients and then to progress on to other treatments if that is not beneficial. The overstitch is a reasonable option for patients who do not want surgery or are not fit for surgery. And there are also long-term comparisons in regards to medications. New guidelines for surgery demonstrate lower BMI criteria because of the safety for surgery, same safety as a laparoscopic cholecystectomy. And I think it's always important to perform these operations or procedures in expert hands with a multidisciplinary follow-up.
Thanks, George, for another excellent talk. I'd now like to invite Sion Shin. Sion Ho Shin is an interventional endoscopist and gastroenterologist at the Lowell McEwen Hospital. He has fellowship in interventional endoscopy at Sir Giles Gardner Hospital in Perth. His main interests are in pancreatico-biliary pathology with ERCP and endoscopic ultrasound guide interventions. And Sion's going to talk to us about endohepatology, EUS's next frontier. Thanks, Sion.
All right, thanks for the invitation to talk about endohepatology. I've sort of modified the title as is endohepatology the next US frontier or an expensive hobby. as a sort of an inflammatory, as to provoke an inflammatory response from the audience to a degree. Or it could be somewhere in the middle. So an example of an expensive hobby in medicine, and I had permission from Liz Murphy to say this, is an example would be a rectal manometry. We'll do all sorts of rectal manometry for what value. Sometimes it doesn't change any management, but all you get is a couple of numbers about what the rectum and the anus is doing. So I'll move on to disclosure and bias. So I have no conflict of interest, which perhaps is a conflict of interest, because I share no interest with Cook Medical, which means I may be biased against using the equipment, which is usually involved in endohepatology. And this is my political stance, somewhere in the center right. But this is my political stance in medicine, sorry, so I'm not a Trump supporter. So what is the hype about endohepatology? So Damien, sitting right next to me over here, could refer a patient for a gastroscopy wanting a screening for whether the patient, his chronic liver patient, has gastric or esophageal varices. But he may say, well, whilst you're at it, can you take out your US scope and take a piece of liver tissue out as well? And if you're going to poke the liver anyway, can you take some portal pressure at the same time? And if you see some gastric varices, might as well just embolize and coil embolize it, and he'd be very happy with all those results when he sees the patient back in the clinic. And perhaps even do an endoscopic sleeve gastrectomy as well. And that might be all in one single anesthesia, which is very convenient. So the outline of the talk today will be about what EUS-guided liver biopsy is about, portal pressure gradient measurement through EUS, and also EUS-guided gastric varix management, and go into more details about those things. So EUS-guided liver biopsy is performed with various details and techniques, but generally most will prefer to do it with a 19 gauge, the biggest EUS needle we can have, with typically an FMB core needle biopsy, a Francine type of needle, which is Boston rather than Cook. And we tend to use a wet suction with heparin to avoid having a blood cast in the needle channel. And the advantage really is that during the biopsy, you can use Doppler to avoid vessels and any other important structures on the way when you take the liver tissue sample through the FMB needle. Obviously, you will have to puncture through the capsule of the liver, and generally you'll do a 3 or 4 slow actuation in the liver to take the tissue sample. So when you look at the evidence of whether the EUS liver biopsy is superior to a percutaneous liver biopsy that we often do by the bedside, you can almost find evidence supporting either way, but this is an example of evidence that supports the EUS-guided liver biopsy out of India, multi-center single-blind RCT, where they compared to a percutaneous liver biopsy. And you can see on the right side that the aggregate specimen length is almost double, or more than double the percutaneous liver biopsy. And you have a lot more complete portal tracts on the biopsy sample. And what's most important is that it's a lot less painful. So the patient will wake up and almost feel as if nothing's been done. But having said that, there are adverse events, fortunately very little. So you do still have somewhere about 1 to 2% chance of bleeding because you're still going through the liver capsule. So you do still have bleeding complications, and some of this other results that I've highlighted down here is just the technical differences between whether you use an FNA needle or FMB core needle. And there's a trend towards less bleeding complications with FNA needles, but only a trend and not a clinical statistical significance. So what are the advantages of EUS-guided liver biopsy? Obviously, the most important part that we see is that it's a lot less painful for the patient, and it's a faster recovery compared to a percutaneous liver biopsy where the patient's bedridden for about an hour or two. And you can take a targeted liver biopsy if you really desire. And for me, the actual advantage for me is that you can, on real time, avoid the kidney, gallbladder, lung, pleura, and the vessels along the way. And at the same time, whilst you're at it, obviously you can do portal pressure measurements at the same sitting. And obviously you don't have to go through 10 centimeters of subcutaneous fat in an obese patient if you have to do any US-guided. The disadvantage, some will argue that EUS-guided liver biopsy is not as adequate compared to the percutaneous liver biopsy, but I think that's just dependent on the experience of the person doing it or the technicalities of it. But overall, I would say it's probably non-inferior or sometimes superior. But the major disadvantage is the cost. Obviously, percutaneous liver biopsy is done by the bedside. You don't need an anaesthetist or any of the equipments that we use with the EUS. But if I had a choice between whether I do a US-guided biopsy or a percutaneous biopsy, I'd certainly prefer US, mainly because my last percutaneous biopsy showed complete nephrons rather than portal tracts. So once you have that sort of traumatic event, you kind of stop doing percutaneous liver biopsies. So next, I'll talk about the portal pressure measurement. So the importance of portal pressure gradient measurement is that traditionally, the gold standard is you have an interventional radiologist go through the jugular vein, go into the hepatic vein, take a measurement out of the hepatic vein, put up a balloon once it wedges up into the sinusoid and take a wedge pressure. And the difference is what we call the portal pressure gradient. And the important numbers to remember over here is that anything above 5 is considered portal hypertension, but it's more clinically relevant once that number hits 10. And once it's much higher than 10, you'll start to have variceal bleeding problems. But if you get the number down generally below 12, the risk of variceal bleeding is significantly reduced. The way we do US-guided portal pressure measurement is usually you sit somewhere in the stomach or the duodenum, get a visualization of the liver and the portal vein. You puncture with the 25-gauge needle into the liver, which is a fantastic organ to tamponade any bleeding. And going to the portal vein, you pass the Cook manometer through the 25-gauge needle, and the manometer will take the measurement of the pressure in the portal vein. And then you take the needle out and then re-puncture into the liver, into the hepatic vein. So you have to puncture the capsule twice and repeat the same pressure measurement. And the difference between those two measurements will give you the portal pressure gradient. So I'll quickly go through the history of this US-guided PPG measurement. So Jason Huang, Kenneth Cheng, and Jason Samarasina from University of California are the first to pioneer this technique. They've done animal studies since 2014 and prospective human studies since 2014 all the way up to 2020. And then there are a couple of large studies that show what the US PPG measurement does. So in their case, they've looked at patients with chronic liver disease, and they looked at the presence of various portal hypertension symptoms and signs and correlated with the pressure gradient measurement. So in this example, you see the patients with high-risk cirrhosis generally had much higher portal pressure measurements of 10 compared to patients who had low clinical risk of having cirrhosis. Same thing with varices, sitting at 15 versus 4 in those without varices. And portal hypertensive gastropathy, also another reflection of portal hypertension, obviously, which raised the portal pressure measurement. Their second publication, many years down the track with much more patients over time, has also shown that portal pressure measurement, direct portal pressure measurement, gradient measurement in clinically cirrhotic patient, thrombocytic patient, portal hypertensive gastropathy and varices also demonstrated much higher gradient compared to before. But what about the comparison of transjugular measurement that we traditionally did with our interventional radiology colleagues? So this is an example out of a study out of China where they looked at portal pressure gradient measurement by EUS and also at the same time a transjugular wedge pressure measurement. And you can see the Pearson correlation coefficient sitting very close to 1 where they're very comparable. In this case, it's a bit funny because the transjugular wedge pressure is the gold standard and the direct EUS measurement is the comparator, where I think ideally it should be the other way around because the wedge pressure is an estimate rather than a true measurement. So what is the clinical role of actually measuring the portal pressure gradient? Is it just another rectal manometry phenomena, or do we use this number to guide our treatment? So obviously, if you have a high portal pressure measurement, you think about initiating treatment, or perhaps if you didn't have portal pressure gradient, high portal pressure gradient, you could cease treatment. You could escalate or dose titrate certain beta blocker therapy, or you could prognosticate. But most importantly, I think it has a crucial role in peri-op assessment of patients with chronic liver disease, where what are the risks of developing portal hypertension and decompensation of their chronic liver disease. So it will play a major role in that sense. And also, occasionally, you will have patients who have PBC, granulomatous disease, or non-cirrhotic intrahepatic portal hypertension, where the wedge pressure will not be very accurate, and occasionally you have NASH patients will also mimic those sort of problems where the wedge pressure is inadequate to assess the portal pressure. What is the downside? It is very operator dependent, it is very equipment heavy, and there is very much a lack of portal pressure gradient guided randomized controlled trial or evidence in guiding portal pressure treatment, such as use of beta blockers, and also very expensive. I think one of those manometers will cost a couple of $1,000s just to open. Now we'll move on to the final part of the talk where we talk about gastric varices. Whenever we see gastric varices, it's a very high mortality bleeding problem, and it is prone to recurrent bleeding even after treatment. And our standard care for many, many years has always been endoscopic hystoechoral injection. But the problem with this is, one, it's not an effective solution, and often it will lead to embolization to the lung. So since EUS-guided coil and embolization came about, it has taken off as probably the gold standard in treating gastric varices. This is an example of how gastric varices are treated through endoscopic ultrasound. And as you can see on endoscopic ultrasound, you can see this large gastric varice, which looks to be about 4 by 3 centimeters in size. So if you wanted to inject it just blindly with the endoscopic glue, I don't think you'll succeed. So this is an example of a 19-gauge needle puncturing into the varix, a coil going in with the stylet, and then flushing with sterile water, and then there will be a second coil that goes in there, followed by a glue injection. So one of the biggest prospective studies came out of San Francisco, where they looked at 152 patients with gastric varices, and they've essentially had very safe and effective data that's much better than the previous historic data of endoscopic glue injection. So US coil glue technical success rate can be up to 99% in hands of excellent endoscopists, and it is very effective in obliterating the gastric varix. It has some risk of adverse events, but very much acceptable. So last year was a publication of a meta-analysis that looked at 5 prospective and retrospective cohort studies along with 1 RCT that does show finally that US-guided gastric varix obliteration, coil embolization to be more specific, is superior to blind endoscopic injection of hystoechoral in terms of rebleeding rate, re-intervention rate, but unfortunately, it actually surprisingly didn't show a statistically significant reduction in embolism, although there is a trend towards that favors the EUS-guided. EUS-guided gastric varix treatment certainly is probably the way to go in this day and age. So in conclusion, a liver biopsy by EUS is certainly feasible, safe, but the cost effectiveness really does hinder its use. And you would probably want to combine its use with something else endoscopic at the same time to make the cost worthwhile. Portal pressure gradient measurement is a useful information at times, especially in perioperative risk assessment, whether the patient will decompensate or you want to do a TIPS procedure prior to that hemihepatectomy or a gastrectomy for surgery, a gastric cancer surgery or something similar to those along the lines. But for everyday cirrhotic patient, I can't see that the PPG measurement is going to add on to the daily management, nor will it guide the beta blocker titration or prescription or cessation of it. You will also have occasions where transjugular approach is not possible because of whether you've got thrombotic disease or there's neck contraindications, and US PPG guide measurement may be a much more useful tool. For EUS-guided gastric varixes, it is the more effective and safe treatment, but having said that, if you see a large gastric varix that's not bleeding, it's probably best you bail out, not inject anything, get a CT abdomen, and think about doing a BRT or TIPS rather than straight to gastric EUS-guided coiling. But the unfortunate side of it is there's only 2 of us in this hospital that does EUS, and I don't want to be on call for 180 days per year coming in treating gastric varixes. So there will still be a use for Sangsec and Blackmore tubes and need for interventional radiology. Thank you.
Thank you, Sarah. Thanks for a great talk, and I'm not sure if you convinced Liz Murphy that we need to pay for this yet. Last of all, I'd like to ask Raj Singh to come back to the podium and give our last talk, which is AI, hold ground, embrace or be left behind. Thanks, Raj.
Thanks, Brian. While we're uploading the talk, there's just a few questions here. So I think Sean's answered the last question. It was, should glue be stocked in all gastro units for varicose bleeds or be at least at hand? Only in preference for EUS and varicose treatment. I guess it can be on standby, I suppose, Sean, but as you said, you're not going to be on call. Did he say 365 days or 180? If Derek was on long-term visiting, yes, 360 days. There's another question for both George and Amol. The elephant in the weight loss room is diet, especially a non-keto, low-carbohydrate diet. Any comments? Perhaps George?
Yeah, I think I wouldn't use the word diet, more routines, but any improvement in routines, whether that be healthy, nutritious whole foods, high in protein, low in carbohydrates, of course is going to be mandatory and part of the process regardless of treatment, and that's why it's very important to liaise with dietitians and to continue to make improvements that are sustainable.
There's a question for Niroshan. To close a large defect, can you reduce the size by clipping within the defect first, then opposing the edges?
Sorry, Raj.
So to close a large defect, can you reduce the size by clipping within the defect first, and then opposing the edges? I guess kind of like the origami technique.
Yeah, I was about to say, that has been described by the Japanese who are crazy when it comes to interventional endoscopy, but I don't tend to do that because, like I said multiple times, if I do that, I'm not entirely sure whether I'm able to complete it, and a prong of a clip in the middle of a muscle defect is the last thing you want to leave hanging, and if you can't completely close it, then it adds to the risk of delayed perforation. So I wouldn't personally do that, but it's been described.
So just one last question, and I think it's for the chair.
Yep. So this is maybe for Damien. So what limits hepatologists referring patients for weight loss treatments?
Can you repeat?
What limits hepatologists referring patients for weight loss treatments? What are the main limiting factors?
Nothing. There aren't any. That's the quick answer. So, we've got a metabolic liver clinic here. We work very closely with other cardiometabolic clinicians, and we do send quite a lot of referrals to the public and sometimes private bariatric services. So, no, we work together. Just on the bariatric topic, just one comment regarding muscle and semaglutide. I've seen that data several times. I think you've got to be very careful when you talk to clinicians and patients about muscle in obesity. There's been studies demonstrating loss of muscle mass with the use of GLP agents. What they haven't done is compared them with loss of muscle mass with surgical weight loss. If you lose weight, you will lose muscle, you will lose fat. There is an issue if you look at very large population databases, for example, NHANE's data from the States, looking at people with type 2 diabetes compared with other members of the population, they have greater muscle mass. Doesn't mean they've got greater muscle function or they're fitter. Probably one of the more important things with metabolic disease is to look at objective measures of muscle function, not just mass.
Great point. There has been trials previously for muscle mass loss with metabolic surgery around about the 20-25% mark compared to around 39% is what we saw in step 1. I agree completely that muscle mass loss is not always consistent in regards to function. On the flip side of that, in regards to the type 2 diabetes population, we all know very well that the outcomes with GLP-1s and weight loss in particular and other cardiometabolic improvements are far less than those who do not have type 2 diabetes. So there's a lot of, I guess, variable factors to consider.
Yeah, but if you've got a patient who's had bariatric intervention, surgery, medical intervention whatsoever, and they lose weight and they lose muscle mass, if they gain muscle function and gain other functional improvements, then that's a win. Particularly if they had issues of fat infiltration within muscle, myosteatosis, and so on. I think it's important to look at the functional outcome here.
All right, thanks, Damien and George. So we'll just, I realize this is the last talk, so I'll try to crack on, and then just to let everyone know, don't leave the hall, we'll just take a picture and then you can go on. There's also the hands-on component for people who have registered. So there are 12 nurses and 12 medics who have registered for it. But please feel free to sort of go through the unit and look at the various models, and if there's time, you can also have a hand on looking at some of the models which has been, so we've got the the Mikoto models, which are here for the first time in Australia, so that will be demonstrated in the units. So I'll just sort of look at the AI timeline, and this is kind of what I sort of looked at and found when apparently AI was born in 1955, so older than most of us. There was something called an AI winter, which I'm not sure what it is, but anyway, for some of us who are older, we could have sort of remembered about Deep Blue, the supercomputer beating Garry Kasparov. It was a big thing that time at 1997 when Kasparov was the big gun in chess, and obviously he was beating Karpov, if you're old enough to remember. And then Siri came about in 2011, and then Alexa in 2014, and it's just gone, I guess, grown by heaps and bounds. So AI in GI has got many different components, and you can see there that there's deep learning, text-to-speech, speech-to-text, image recognition, which we are very familiar with. Robotics, you saw Honchi present some of that. Natural language processing, and you can look at the exponential research explosion of various AI technologies within the GI realm. And you can see that this is in 2022. I think this curve is off the charts now and outside the computer, perhaps, with the number of publications in AI and GI. So I'll try to talk on AI in GI oncology, given that this is the theme of our last 2 days, and present the state of play in upper and lower GI, problems and barriers, and the future. Like George, I tried to look at GPT and typed in AI in GI oncology, and this is the strange picture which came about. Yeah, so I've got no clue what that means. But anyway, so we'll try to look at upper GI and then go down to lower GI. And I won't bore you with details because we've got a lot of details. But whenever you see something which is beyond 95%, just take it with a pinch of salt. This is with squamous cell cancers, though. But if we have some sort of idea that what we're looking at is actually not a weird patch or erosion, and it's actually a cancer, as what the AI system is telling us here, that may be useful. So this is in squamous epithelium, and presented by this Chinese group and published in Digestive Endoscopy. In Barrett's esophagus, we've got a lot of information, and this is from Jin Tan, who is relaxing in New Zealand and hopefully listening in. But Jin basically said that it's like, where's the Wally, right? Or where is Wally, rather? 80% probability that this person looks like Wally for dysplasia and Barrett's. And then, obviously, Jin found Wally with 99% probability. So dysplasia is tricky in Barrett's, we all know. We've done some work on the accuracy of dysplasia and Barrett's in a systematic review. Again, won't bore you with details, just to say that the sensitivity and specificity with some of these modalities, which is not in common practice yet. There's 1 or 2 sort of tools which are being marketed, but it's got fairly high sensitivity and specificity. But the problem arises with things like low-grade dysplasia and indefinite for dysplasia. These are some of the latest studies, and you can see that the number of patients gradually have increased, and so has the number of training sets and test sets. This is our own data called the EMBARK study, which we have been doing together with some of you in the audience here. And this is some of the performances which we can have, something called a vision transformer and then a heat map of dysplasia. But this is all retrospective. That's why we're getting fairly high accuracies with that. So it's not in real time yet, although we have plans to sort of see if this can work in real time, and we're quite close to that. So a dysplastic area would appear to be discolored like that in a heat map. And it's hard to find dysplasia. This patient has a submucosally invasive cancer in Barrett's. You can't really find it. It's hard to see. But as we look at just random sort of close views with narrowband imaging, high magnification, and underwater technique, we found this lesion here. This measures less than 1 centimeter in size. I think it was about 0.5 millimeters in size. We just perform a straightforward EMR. Not everything is ESD. And that area there basically was then remodified based on AI-type algorithms and corresponded with histology, which shows a submucosally invasive cancer. So the aim of this sort of AI systems is to help us detect these lesions without the reliance of, I suppose, experience. So we are trying to look at systems, and this is the same patient, and you can see the input data on the left and the output where the discoloration occurs. And you can sometimes see that there's water around that area, and there's a false sort of positive. area, but that's the main area we want to direct our eyes to, perhaps to biopsy. This is just another example of another patient. Obviously, it looks like an erosion, but if you look at the various sort of pictures, you can find that's the heat map, and the output is what we want to look at, and we want to direct our eye to try to pick up these dysplastic areas. So this is work in progress in conjunction with the University of Adelaide and the machine learning team there. In gastric cancers, we don't have as much experience. This is with our Eastern colleagues, mostly from China and Japan, but you can see fairly good accuracy rates as well. This is something called the EndoAngel ME, which is quite extraordinary, actually. So it enables one to sort of pick up if an area is there's erosion there, but it tells you the diagnosis, so non-cancerous in this sort of erosive areas. And if you look at the lower video, you can see that it's telling the proceduralist that this is going to be a dysplastic or cancerous differentiated cancer as well. So these have got fairly good, I guess, sensitivity and specificities, but this is in an East Asian population where they do see a lot of early gastric cancers. Blind spot monitoring is the other thing which can help, especially with training. So this system is called Y-Sense. And what it does is you can see a cartoon on the left-hand side, and the scope's being put down, and it's basically telling the proceduralist that perhaps they've missed the fundus. You have to look carefully. So you can see the color being put in the cartoon next to the procedure, and it's slowly picking things up. And if you've got a complete procedure, then obviously you get that full stomach sort of color, the small bowel and the lower esophagus. So it's been shown to be quite a good technique or a good sort of device to use. You can have more details if you want to look at this, which we wrote up together with Sean, who just spoke before me, on other lesions as well. So AI in colonoscopy, you heard a lot about detection. The theme or the feel is that it increases ADRs by 12%. So, we've got our national standards of 25%, so you may want to increase that to 37%. This is the latest data on systematic review and meta-analysis. The levels remain about 20% increase. It improves adenoma miss rate by 45%, but sessile serrated detection rates remain kind of in the middle. All right, so that's a problem, and it does increase a bit of the withdrawal time. So this data was from GI endoscopy 2 years ago. So we also need to, I guess, characterize polyps. We've seen a lot of imaging in the last 2 days, but if you have a system which tells you whether it's invasive cancer or whether it's just an adenoma, highly magnified. This is almost magnified to an extent where the pathologist would look at this, but on an end-on view. So obviously this is a hyperplastic polyp, and the system will tell you that it's non-neoplastic. So this may come into play in the future as well. Different devices have been used, but it's quite interesting to look at how these devices do in real-time practice. And when they were compared with two of these systems, so one is the EndoBrain and the other is the CAD-Eye, about 4 years ago, you'll find that the endoscopies and the AI assistants with characterization, so I'm not talking about detection, it's with characterization, it's kind of the same. So they perform almost similarly. And you'd be worried if your accuracy rates are about 88% and at least not beyond 95%. So we can't differentiate hyperplastic polyps from SSLs, and there's a problem with differentiating superficial cancers, which can be submitted to endoscopic submucosal dissection or EMRs, and from deep cancer. So CADX, which is the characterization tool, cannot do that confidently. We've done some work on this, and this was preceding our Barrett's work, but it's quite interesting to know, once you look at this sort of data, you kind of know that if you've got data, and if you don't build firewalls between the training and testing set, and no firewalls between the internal and external validation sets and the testing sets, if there's overlap, you're going to get almost 100% accuracy rates, and that is false. All right, so we only learned this as we are doing this sort of things, and we found that with the data which we had used for colonic polyps, this was 6-7 years ago now, we found that our internal and external validation was around the 90 to 94% range. However, we decided to move towards Barrett's related work because there was a lot of industry push to have other colonic type devices in the market. So we thought that it's better to take our ideas to Barrett's esophagus. So one of the things, as I said, we have to avoid is data leak. You know, we should not use data from the future. And as I said, if you get this sort of sensitivities and specificities, you'll be worried that there's a data leak, meaning your device is great, but when you use it in real time, it's going to be absolutely horrible. So AI and colonoscopy, we have discussed this time and again. It's technique first and then AI second. So meaning this is with regards to detection. So your full inspection, prep quality, and be deliberate with withdrawal remain key. AI cannot see what you do not show the system. So if you don't expose the mucosa, it's not going to see the polyp, all right? Though we'd like it to. CADE does improve adenomas in trials, ADRs, as you've seen, 12% initially, and now latest meta-analysis up to 20%. But this is only in diminutive polyps, small polyps, less than 5 millimeters. Does it matter? We don't really know. CADX, more work to be done. CAQ is quality, and as I said, if there's visualization and cleanliness tools which are coming, we probably could incorporate this into our day-to-day practice. And I think the most useful would be if you can sort of dictate to the so-called AI system about your computer report and not go down to the system and keep typing them. That will be quite useful. So I'm going to talk about the future and some problems. This is generated from the internet, and these systems are so clever now that they can tell you when the cecum is reached, Boston bowel preparation scores, and if we have something which can incorporate all of this, detect, characterize, and have quality involved, that would be the ideal system. Obviously, it's not yet there. And obviously, if you miss this sort of large polyps, you better not be doing colonoscopy. Auto-labeling, that's good. This is a system which, this was just published a few months ago, where the system automatically detects the start of the procedure, whether a snare was used, biopsies was used, the end of the procedure, and auto-dictates a report. So maybe this is something which would be great for us, but I think there's still more work to be done. It's called the ARC1 system. Maybe we have a system which can recommend surveillance intervals. So this is quite interesting from China, which looked at Angel AS, which was significantly better than physicians, with predicting surveillance intervals. 99%, again, obviously you got to look at the data with more detail, but this is just basically compiling the report versus the report and the accuracy of the histology, and then predicting surveillance intervals. I won't go into that. We have got multiple platforms, white light, NBI, TXI, BLI, 4K, 8K. There's so many things. So I think all this needs to be amalgamated. There's, people are just specifically concentrating on squamous, and then somebody else like us doing it in Barrett's, then someone else is doing it in the stomach, and then you've got a duodenum. So then all needs to be combined. There are too many false positives. In this study, there were 27 false positives per colonoscopy. I think there's more, and I'll tell you, at 4 p.m., you'd probably want to switch off that sound and those boxes. You keep dreaming about them at night, and, you won't be able to sleep. So people just switch them off because there's so many false positives. This is just an example of AI picking up the ileocecal valve. If you're not aware, you're going to take a snare and cold or hot snare it or whatever. You don't want to do that. It's also picking up the AO, appendicular orifice, which you don't want to do. obviously the main issue is here, and it's a scar. This is not a polyp, it's just a fold. So it's scar tissue from a previous EMR site, which when we further interrogate and evaluate, we know that the pit pattern is regular, so it's not a recurrence. It's also picking up the snare, as you can see there. So we don't want that unnecessary boxes. False negative is also an issue. This is a lesion which is deliberately being shown to AI, but it's not being sort of picked up because in the algorithm, it's not sort of it's not being told that this is actually a lesion. So this was a neuroendocrine tumor which was removed. And this is a nice sort of video from Doug Rex in gastroenterology. He's trying to show the AI system this is a sessile serrated lesion, right? But it's not putting up the box. The box is not there. It refuses to put the box. So he's trying his best. He's injected some fluid. Still, it's not sort of picking it up. Another sessile serrated lesion you can see on that side. You know, he's trying to show it. Please tell me it's there, but it's not. So that's the problem. And if we would sometimes miss those sort of things. This is a nice one. I'll just try to freeze that. So big polyp, nothing, but AI picks up small polyp. So, you know, so cost is the other issue. This is a nice Markov microsimulation model. So we have AI. We're going to pick up more polyps, right? Because we're going to detect them more. So we're going to reduce cancer as a result. So that will lead to colorectal cancer incidence, incremental reduction of 5%, mortality of 3%, reduction of $57 per patient. But the savings would be great, $300 million per year. But if you look at the analysis, you'll find that there's a difference, that the upfront cost is also $250 million. So who's getting, this is in the United States, a microsimulation model. I'm sure that is much more now with tariffs and all that. So probably $1 billion a year, who knows. But anyway, somebody has to put up the cost, upfront cost, all right? Trust is the other issue. This is something I've worked out in the last few days after looking through many of the AI papers. There's actually no thinking in these AI systems, just memorizing rules from training data. Right? You got to understand that. So machine learning, somebody says fancy statistics. They use regression models and whatnot. It's fancy statistics. We may think the machine is learning everything, but it's just spitting out data. All right, so there's a risk that we can overfit models, and it may not fit with other sort of data sets. All right, so you heard about this garbage in, garbage out theory. So if your data is rubbish, your model is great, what comes out is rubbish, the other way around. So you've got to have good, clean data. You've got to have a good model, and you'll have a good result. This is simplified, of course. So you need ground truth and you need good data, but sometimes we don't know where the data has come from, how it's been determined, who annotated the data. We don't know how well it's used in intended clinical use. You know, it's out there in the market before we can even sort of capture and find out what it's all about. We really don't know how. They call it the black boxification, which I'll come to, but we don't really know what the AI system has been trained on. How many centers? Is it in the east? Is it in the west? Is it in the north? Is it in the south? The endoscopy settings, we don't really know. So big data should kind of mimic real-world practice, you know, and that is one of the problems with the AI systems. So you just imagine a 15-minute endoscopic procedure has 27,000 images, if you have all these images in a source, someone has also mentioned that data is now the new gold mine. It's like cryptocurrency or something like that. So if you've got good, clean data, it's going to be quite interesting to see how it goes with regards to AI. So people say, we have got 10 years of data there. It's really large sample size, all right? But AI adds nothing to black and white cases. All right, what we see as a polyp and what we see as stool doesn't add anything with AI. What we need is AI in gray cases, right? That's where the problem is. We need all those gray cases. We are not sure. We need AI to tell us what it is. And a lot of the AI systems now are black and white. Okay, there's very little gray in it. This is just, I know Gerald has clicked that thing twice, but I'll just let you know that there are benefits, as we know with AI, but in non-randomized controlled trials in the real world, there's actually harms. There's longer inspection time, and we tend to remove non-neoplastic polyps unnecessarily. All right, so we don't want to do that. In real world, there's actually this benefit and harm sort of thing has not been fully sorted out yet. Confidentiality is the other thing. Liability is the other issue as well. And you've seen this from Honchi or Amol. It can also sort of help with therapeutic endoscopy. I mean, this is a POEM procedure, right? So you got a vessel there. You don't want to cut that. You want to avoid that. So AI is telling you what to do and what not to do, all right? Yeah, he just avoided the vessel, so that's good. So it may help in the future in therapeutic endoscopy as well. So some of the barriers, last few slides, bear with me. Some of us view the systems as early technical or technological development, so we want to wait and see. We expect prices to drop. The returns of investment is uncertain. We sense a little pressure so far to purchase this from patients or local competitors. Some of us believe we are better than AI. Endoscopy is measuring their ADR, believe that their ADR is adequate, so they don't want to adopt this. And obviously, we mistrust AI development. As I said, the black boxification, another new term I sort of found out. So we don't know what really AI is in some of our systems, which we actually use in our units now. So we need to consider whether there's real-world data out there. There's also this concept that if you're going to train our trainees with AI, we may lead to de-skilling them. So if your AI system is dysfunctional, you find that suddenly you can't find polyps. So it may be the case, who knows. We also need to continuously upgrade our algorithms. Our iPhones, our watches, our Samsung phones, whatever, has got all those updates every few months perhaps. But an update in an AI system in your respective units may take 5 years or 3 years, we don't know. Unless you've got a cloud-based sort of system, which is coming as well. So large language models do not know the stakes of medical decisions, right? So these models learn on words, and they don't really know the stake. We've asked some of our colleagues, and we looked at this systematic review to see how it is. And generally, endoscopists, nurses, medical staff have a positive attitude of AI in endoscopy, but are concerned with the costs and the medico-legal considerations. This was published in GI Endoscopy last year. So you can look at how to implement an AI system in your unit. If you are interested, you can look at this paper, which we co-authored. So I will leave you with this. Our human intelligence-based endoscopic systems, I think, is still the present gold standard. It is often imperfect, sometimes biased, but I think it can be really good if we learn how to interpret the images which we see. AI today could be a solution looking for problems. So as I said, statistics, maybe in fancy clothes. There's no intelligence or thinking going on, in my opinion. I think it's all data. It's all data-driven. It often generates satisfactory results, but rarely great. It accepts possible quality for faster speed and maybe fewer humans. Many people want to sell you the product, but also slurp up your medical data. So we as humans, I guess we should keep humans in the loop, stay skeptical, use AI in selected cases, and we should demand repeated validation in your own environment. Somebody sent me this as well. So I'm just going to show it to you. Robots are now renting humans. All right, so this is 3 million visits. 213 humans have put their names up. These robots basically say you can set your rate direct to your wallet with no corporate bullshit. And these are the sort of services you can browse humans. If you need a ride now back to your home, you can check this out. So pickups, meetings, signing, testing, errands, photos, purchases. So this is an AI, I guess, website hiring humans in real time. Okay, so take it how you may, but it's probably coming. And I will then end by saying thank you. And probably we'll take questions at another time, but two challenges which the world faces is natural stupidity and artificial intelligence. So thank you very much. We probably there'll never be a right and wrong answer, I guess, so we can take questions at the end, or you can email me if you're interested to have further discussions. Can we take a picture now? And then we can adjourn. But I'd like to thank you all again for spending the Saturday being here and the Friday. I'd like to thank all the chairs who've kindly spent their time coming here, and especially the faculty as well. Two of our international faculties, thank you Amol and Honchi, and all of our national faculties, and all of my colleagues, and not forgetting the nurses who are all here. Thank you very much. And also my son decided he's going to come and watch me speak on AI, so I hope he learned a few things, but not that last thing over there. So thank you very much. So yeah, so we'll just take a picture if it's okay, and then that's the live, the hands-on component coming up.
No. Okay. Oh, that's nice. Okay, everybody. 1, 2, 3. Okay, another one.
Yeah.
Do something. Oh, all right. All right. Okay. 1, 2, 3. Okay, that's good.
Thank you.